Do the questions come in the chat box for the speakers?
Yes, sir.
Yeah.
Moderator should look into the questions.
Yeah.
Hello.
There is a chat box as well as question answer box also.
Yeah. They can put questions live. Can the audience put questions live or in the chat
Yes, sir.
box only?
Yes, sir. Yes, sir. It's
Live.
live. So moderator needs to take the questions, and after the session, they can ask the speaker.
Okay.
Deepak from WebCon session should start at 9 o'clock. It's already 9. You can start the session, like the first video and all. Be ready.
Yes, sir.
Okay.
We work very hard. We work very, very hard. We do our very best to our patients in this country. And you know,
Do we have all 6 presenters there in attendee list?
When something happens, adverse especially, and he said, I wasted my life, person welcoming an Indian with so much of warmness in it. And the
Even first 2 speakers are available, so we can start now.
Thank you. Fine, so we can start, I believe. It's already 9 o'clock now. We can start.
Yes.
Shall we start?
Yes, please.
Deepak, start the video.
So good morning to all. So we will go to the first paper of this medal session, which is a very prestigious event for this OSSCon. The first talk is on outcome of combined neuropathy and tendon transfer for common peroneal nerve injuries by Dr. Purushottam Lingaya.
Some
Can
other
we have
talk
the first
also,
video, please?
some other talk also is overlapping.
It is outcome of combined neuropathy and tendon
Some
transfer.
other talk also is overlapping.
Human locomotion is described to be composed of 2 phases, stance phase and swing phase. The most important component during the gait cycle is dorsiflexion of the ankle and foot. And this dorsiflexion is controlled by a group of muscles which is supplied by common peroneal nerve. Naturally, injury to the common peroneal nerve, either by road traffic accident or fracture around the fibular neck or any trauma or glass cut injury will lead to loss of dorsiflexion, and that will lead to a deformity which has been described as foot drop, and the resulting gait is described as high steppage gait. Foot drop leads to considerable morbidity as it disturbs the normal locomotion. Now, repair in the upper extremity has been very successful. However, in the lower extremity, it has a poor prognosis because of the length the nerve has to travel during recovery. Since dorsiflexion of the ankle and foot is the prime factor which is responsible for carrying out routine activities smoothly, restoration of the dorsiflexion of the foot by early surgery, that is nerve repair and or tendon transfer, should be done to restore the function to near normal as early as possible. The aim of the study was to understand the concept of early tendon transfer. The early tendon transfer means neuropathy and tendon transfer done simultaneously, either in the same sitting or 6 weeks apart. This tendon transfer concept has been tried in upper limb and has been successful. We wanted to try the early tendon transfer concept in lower limb surgeries to document the outcome of early tendon transfer and to document the complications. To achieve these aims, we conducted a prospective study between September 2012 and November 2016. The total number of cases included were 36. These were the traumatic cases of common peroneal nerve palsy. Early tendon transfer was performed in all cases, that is, in stage 1, common peroneal nerve exploration and repair was done, and in stage 2, that was 6 weeks apart, the Malleolus posterior tendon transfer was done. All the patients were followed up for a minimum of 24 months, and pre and post operative functional evaluation was done using Stanford assessment questionnaire score. So this Stanmore assessment questionnaire score was based on 6 parameters. One is pain, ability to wear shoes, degree of ankle dorsiflexion, need for orthosis, power grade of ankle dorsiflexion, and foot posture, adding to a total score of 100. And the grading was made based on the points that the patient has got. That is 85 and above is very good, 70 to 84 good, 55 to 69 fair, and less than 55 is considered as poor. Coming to the surgical technique, exploration of the condylar was done with the patient in supine position after anesthesia. The lateral approach was used and centering around the fibular neck. The cut ends of the nerves were identified. The ends were freshened, that is the neuroma and the glyma were excised to expose the fresh nerve bundles. And this visibility of the nerve bundles gave the adequacy of the surgery, and then end-to-end epidural urography was done. And once the urography was done, this was protected by keeping the limb in flexion and putting an above knee plaster. Coming to Tibialis posterior tendon transfer, the medial incisions were given, one on the at the insertion of the tibialis posterior, one on the distal aspect of the foot from where the tendon was harvested. The tendon was pulled from the distal most incision to the proximal incision, and then on the lateral side of the foot, the incisions were given to retrieve the tendon from the medial side to the lateral side through the interosseous membrane, as this is the interosseous membrane. So tibialis tendon, posterior tendon was transferred from medial side to the lateral side, and then over the extensor it was passed and fixed onto the base of the second metatarsal or middle cuneiform with the help of a screw. Coming to the results, the Stanmore assessment questionnaire components showed a significant improvement in all parameters. The most important point was all patients were free of ankle foot orthosis post-operatively. 29 patients becoming free in 3 months post-operative, and the rest 7 cases after 6 months post-operative. The reason for the 7 cases after 7 months of post-operative was probably because of non-compliance to strict physiotherapy. So this is a video showing the gait in the pre-op state. As you can see, there is a high steppage gait. The patient is walking by flexing the knee and lifting the leg to clear the ground and cause less injury to the nerve. This is the post-operative video showing the near normal gait after the repair has been done. You can see the surgical scar mark of exploration of the CPN as well. So this is the near normal gait of the patient after the surgery. So in the long-term follow-up cases, that is after following up certain patients for more than 40 months, there was further improvement in Stanmore assessment score. The initial mean score of Stanmore assessment pre-operatively was 17.5. In the post-operative phase at 24 months follow-up, the average was 83. And in the post-operative phase on an average follow-up of 40 months, the score raised to 93. Most important point was all patients were able to return to their job early, that is in a mean of 4 months, and satisfactorily carry out all routine activities. Most of our patients were farmers and they were not able to go to the fields and work, and at the mean of 4 months, all the patients were able to return to the fields and carry out farming. Ankle dorsiflexion of the operated limb was comparable to the normal limb in cases where there was nerve recovery, and nerve recovery was observed in 29 cases of complications of the procedure. There was a valgus deformity and flat foot noted in the long-term follow-up cases. This was because the main prime factor which maintains the arch of the foot, that is tibialis posterior, was transferred to the anterior side. Hence, the arch of the foot was lost, and the plantar flexion was also restricted to some extent. These were known complications of the procedure. However, neither of the complications were disabling to the patients. Patients were much more satisfied subjectively. Conclusion, we know that the gait in the foot function is very important to carry out routine activities, and hence restoration of this gait by performing an early tendon transfer, that is urography and tendon repair, tendon transfer simultaneously should be done. This will not only be helpful in better rehabilitation but also be helpful in restoring the normal function as early as possible. So this will help in reducing the time of work. They can return to their work early. This tendon transfer, when carried out properly, acts as a helper. It also acts as an internal splint, providing enough environment to nerve recovery, and also as a substitute in the rehabilitative effort of the patient. This present study strongly supports the performance of early tendon transfer for all traumatic foot drop cases. These are my references. Thank you.
Are there any questions?
Yes, sir. Can I ask questions, sir?
Yeah.
Can I ask questions?
Yeah,
Yes,
go
sir.
ahead.
Yeah. See, one of the, as he said in the discussion, the on the complications, what are the complications? He had the patient went in for flat feet as well as some impairment of plantar flexion. So, and he says it's not that very disabling. But I think this is a short-term follow-up, and already at this short period of follow-up, the patient has already developed a flat feet. What are the long-term consequences of this tendon transfer?
Good morning, sir. I just want to tell that flat foot per se, as per and natural patients are concerned, the main problems that they face is something called plantar fasciitis. That is one thing that they will face. In the follow-up of 48 months that we have seen in few of the patients, these patients have not developed any of such things. However, a long-term follow-up is definitely required to know the complications that these patients will face. However, what benefit they have got because of the surgery and the foot drop has been corrected is going to outweigh the plantar fasciitis that they may develop in future.
It's not just plantar fasciitis alone is the complication. There is going to be derangement of all the joints of the metatarsal as well as the tarsometatarsal joints. Everything is going to get disorganized.
Yes,
and
sir.
because of that, we have seen over the end of the aged people only, the flat feet, they go in for all the problems. So
Yes,
don't you
sir.
think this person is all these persons are going to go into these complications later?
Now, there is definitely a possibility, sir. What we are thinking is in few cases, the nerve recovery has also happened after the transfer has been done because it acts as an internal splint and common peroneal nerve has recovered. Because the power of the transferred muscle was 5, and it is as per rule, after the transfer is done, the tibialis posterior transfer power is going to be 4. We are trying to do a further study to replace the tibialis posterior back to its original position to restore the arch of the foot. Because most of the patients are young, they are still more prone for all the complications as you mentioned. So correcting the arch of the foot either by giving a arch support and teaching them exercises, or the further study that we are conducting by doing a tibialis posterior retransfer back to its original position since the tibialis since the common peroneal nerve recovery has started.
So continuing the same discussion, how many patients you have seen nerve recovery?
The 29 patients we have seen nerve recovery.
So it's a quite huge number. So in that case, would it be appropriate to wait till you decide on the nerve recovery and then consider the tendon transfer rather than having this that you have to transfer it back again, one more surgery?
We have not started yet, sir. We have just given a thought of it, and we have just started to look into literature and propose this thing to the institute to start the study. We have thought of in that sense, and we have not done any tibialis posterior retransfer to any of the patient.
So if you are considering nerve repair and you expect a good recovery, probably it is better to wait for some more time and then see whether the nerve recovers or not, and then take up the tendon transfer.
Okay, sir. Good suggestion, sir. But I would like to add one point in this that common peroneal nerve injuries in the lower limb, the nerve repair recoveries are relatively less prognostically.
Since your study says 29 patients they have recovered, so it's quite
Yes,
good, no? The recovery rate is quite good.
This was because of the concept of early tendon transfer. So it was done in the upper limb for radial nerve injuries by one of the surgeons, European surgeons, Buckhalter, in which he showed that tendon transfer will give an environment to the nerve to recover. If that adequate environment is not given, probably the scientific basis of nerve recovery in early tendon transfer is still not been established. However, it has been shown that early tendon transfer allows an environment for the nerve to recover. So that is what we also thought that by.
Okay.
What is the time taken for the nerve recovery on an average?
So on an average, it was 7 months.
7 months. There is a disadvantage of two surgeries,
more reason?
definitely.
Yes.
Yeah.
Any more questions? Sayed sir, you have any questions?
No, it's good. It's a good paper. Okay, we will be assessing. Thank you. We can proceed. Can you hear? Yeah.
So your voices.
Sir, please unmute yourself.
Hello, can you hear me?
Yes, sir.
Yeah, this is a good paper. We used to try on neurolysis, wait for the recovery, and then split the limb. The author is proposing surgery as the internal splint. Of course, this is a short-term follow-up, and we have to continue that. It looks like a good idea to do the neurolysis and tender and create a conducive environment for the nerve to recover. That will help hasten the recovery and patient's ability to return to his job. And waiting for the nerve to recover, going for this thing, it means that he has to be attending the hospital for a long time, leaving his job. It looks like a good idea, but being a short-term follow-up case, it needs to be further studied to see the outcome. Thank you.
Thank you, sir.
We'll go to the next paper because
So the next paper
time
is
also.
on
Yeah.
epidemiological distribution of foot injuries in South Indian population by Dr. Gopi Shankar Balaji. Shall we have the second presentation?
Very good morning. Today I'm going to talk about the epidemiological distribution of foot injuries in South Indian population. Foot injuries constitute both clinical and psychological challenge to the patient and the treating surgeon due to its complexity. Rapid urbanization, increase in motor vehicles, high-speed travels, and increase in traffic has led to increased road traffic accidents. The demographic of these foot injuries varies worldwide. So why is this epidemiology important? Knowledge of epidemiology is very useful in implementing injury prevention programs and also for academic purpose. Epidemiology of foot injuries have previously been reported, but these have been reported only in a specific population, like rugby players, elderly women, sports people, etc. So the aim of this study is to understand the epidemiological pattern of foot injuries among patients presenting to a tertiary care center in South India. There has been a study previously, but it caters to patients who are from North India. So this study is basically for patients who are presenting to a center in South India. So we did a retrospective study between May 2016 to April 2017. It's a one-year study. We analyzed the orthopedic trauma registry for cases of foot trauma. All patients with foot injuries during the study period were included in the study. So what was collected? We collected the demographic details, the mode of injury, the site involved, type of injury, soft tissue or bony injury, and the associated injuries. Totally, there were around 4,417 patients who presented with musculoskeletal injuries during that study period, out of which 592 patients, that is 13.4%, had foot injuries. Among them, 12 had bilateral foot injuries. So at the end of the study, we had 604 feet for final evaluation. You see our study, the mean age was around 32.09 years, ranging from 2 years to 76 years. Road traffic accident was the most common injury among all these cases. It accounted for around 357 cases, followed by slip and accidental fall, which accounted for around 112 cases. The most common associated injury was an associated lower limb fracture, which accounted for around 21% of cases, followed by upper limb, then head or facial injuries and polytrauma cases. So coming to distribution of injuries, we had around 4,400 musculoskeletal injuries during study period, out of which we had 604 foot. So out of which 249 were open injuries and 355 were closed injuries. Among the open injuries, 196 were bony injuries, and among the closed injuries, 216 were bony injuries. Among the bony injuries, we had 154 forefoot injuries, 23 midfoot injuries, and 15 hindfoot injuries. Among the closed 216 bony injuries, we had 164 forefoot injuries, 15 midfoot injuries, and 30 hindfoot injuries. Coming to the soft tissue injuries, 53 patients had open injuries and 139 had closed injuries, out of which 138 had contusion or ligament strain, and one patient had cellulitis. Among the open injuries, laceration was the most common, accounting for 44 patients. Heel pad avulsion was seen in 5 patients, and nail bed avulsion was seen in 5 patients. Coming to forefoot injuries per se, metatarsal injury was the maximum, accounting for 43.3% in forefoot injuries. Among the metatarsals, multiple metatarsal injury was the most common, accounting for 60 cases, followed by fifth metatarsal, which is accounting for 41 cases. Coming to midfoot injuries, Lisfranc fracture dislocation was the most common injury, seen in around 31.6% of cases. Coming to hindfoot injuries, calcaneal injury was the most common among all the cases, accounting for 60%, followed by Tala, which accounted for 24.4%. So in our study, foot injuries accounted for 13.4% of total musculoskeletal injuries. This is almost double compared to that of a study done by Dr. Dhillon et al. From North Indian population, and also by Tadros et al. In a study in UAE. This may be because of rapid urbanization and increased speed of the vehicles, increase in number of motor vehicles, thereby increasing the road traffic accidents. If you take age and sex, almost 50% of the population are affected between 21 to 40 years. These are young patients, and morbidity in the foot due to foot injuries may result a long time problem for these patients. Among males and females, males accounted for around 77.8%, and RTA, as I said before, this is the most common mode of injury. Among the 412 bony injuries, forefoot accounted for most of them, accounting for 323, followed by hindfoot and midfoot. This pattern was similar to that of Dhillon et al. But it was in contrast to Mr. Tadros et al., who reported hindfoot injuries were more, because in UAE, fall from height was the most common mechanism of injury. That's why hindfoot injuries were more common in their study. So this study highlights the epidemiological pattern of injuries in the Indian scenario, particularly South Indian scenario. These are the number of cases which has come to a tertiary referral center. Actual number of injuries might be much more, as isolated cases might be treated in a nearby local hospital. Also, there will be missed foot injuries and neglected injuries which are not included. The limitation of the study is it's a retrospective study. We have not assessed the severity of the injuries, the timing of surgery, the type of treatment, and the outcomes. To conclude, foot injuries account for 13.4% of all the cases. 51.3% are between 20 to 40 years. Closed injuries are more common compared to open injuries. 68.2% had bony injuries, and among them, forefoot injuries were more common. Lisfranc injuries are more common among midfoot injuries. Calcaneal injuries are more common among hindfoot injuries. Thank you.
Yeah, can I ask a question?
Yes, sir.
Gopi.
Good morning, sir.
Yeah. Now, you have compared your study with that of the study from North India. Forget the UAE study. We will not go into that now.
Yes,
see, North India, Dhillon, probably it is from Chandigarh.
yes, sir.
Okay. See, in your introduction, you said that urbanization has a role in the nature of foot injuries. What I would think is more urbanization, you will get more of RTA. The cost could be more of RTA. Whereas in your study, you see that in JIPMER, the RTAs are nearly the double than that of Chandigarh. Whereas Chandigarh is more urbanized than, I should say, than Puducherry. So did you discuss about, why did you not discuss about it there in your discussion? That's a very important point.
True, sir. Problem is, it was retrospective studies there. So main thing was only we are able to collect the data, whatever was available in the register.
No, the data is there for you to discuss. You could have discussed.
Yes,
why, what is the reason, or at least you should say that there is discrepancy. We are not able to explain it. You could have said.
Sure, sir.
Okay, right. And second is, what is the message you're going to give now? Any study should come out with a message. In a conclusion, you should have given the message. What is the message you're going to give in this case?
Yes, sir. Actually, this is just epidemiological studies. We are not concentrated more on treatment or delay in surgery and all these things. So we just wanted to see the pattern of foot injuries and how the foot pattern is being distributed among all these things. That's all.
Yeah, I think it's coming to that point, epidemiological study, all these patients were presented to your institution, isn't it?
Yes, sir.
So when you say it's an epidemiology study and then in your title, it refers to South Indian population,
Agrees.
probably the patients coming to the hospital may not represent the true population. There may be a lot of foot injuries. You have mentioned it in your limitations, but I think that is the major limitation. Many of the smaller foot injuries would have been treated outside. Yes, so we will not get the correct epidemiological picture also by studying these.
True, sir. It's not the entire South Indian population who has been referred to the hospital. We have just taken. He agrees.
About 70% of the population is in the rural areas.
Yes, sir.
How are you going to address that population injuries? Is there any way, or it is only because of lack of adequate information from the rural population?
Rural population.
You try to pick up the data from other institutions.
Yes, sir. Yes, sir.
across South India, from your known friends or other teaching institutes,
sure,
which
sir.
are also available in some rural areas.
Sure, sir. Sure,
it
sir.
could have given a much more wider spectrum of injuries rather than restricting only yourself to your institute.
Definitely, I agree, sir. Definitely agree. Yeah. That would have given a good picture about the entire population.
Any questions?
One question from me.
Yes, sir.
Bobby, what are the instances of crush injury in the rural population? The people who have come from the rural area,
yes, sir.
The agriculture is getting mechanized.
Yes, sir.
Tractors and thrashers and all that thing.
Yes, sir.
Noticed any crush injury of the foot? It's
yes,
usually much more problematic.
Yes, sir.
Road traffic accident, because
yes,
there are open injuries with mud and all that rice, this thing husk and all that.
Yes, sir.
End up with doing so much of effort to salvage that foot.
Yes,
I've
sir.
encountered such instances in the past. And what is the message you want to give to your colleagues and youngsters who are ignoring the foot injury? Because they don't give much importance to the foot injury. It is relegated to the lowest rung in our teaching hospitals to manage. And patients end up with more morbidity and lifelong disability because of these foot injuries.
Yes,
what the message you want to give? How we should improve upon in providing a service to persons who has a foot injury, either a road traffic accident or agriculture injury?
Agree, sir. Agriculture, we actually found among the villagers, the cow stampede also contributed more to the foot injuries. Because of cow stampede, less than 5% had some cow stampede injuries and all this, which are very rare in other populations and all these things. I agree that the number of people from rural area have been less in this study. So because we're not divided as urban or rural, so all these things. But however, foot injuries are very important because they cause a lot of morbidity, because being a weight bearing thing cause a lot of morbidity, and the male patients are the breadwinners of the family and causes a lot of income loss and all these things. So foot injury should not be missed and should be treated with utmost care for better outcome.
Okay. I think
yeah,
we are going behind schedule.
Yeah, so we will proceed to the next talk. Yeah.
Thank you.
A prospective study of arthroscopic transosseous rotator cuff repair using novel arthrocuff system. Can that presentation be played?
Hearty greetings to the senior faculty, colleagues, and friends. We have effectively made shoulder arthroscopy a rich man's procedure. Over the years, the need to use suture anchor has been infixed in us, so that we have come up with various configurations to improve the stability and also the cost with it. I believe it's about time we get back to the basics, that is the gold standard transosseous repair. I'm Dr. Raj Suresh, and over the next few slides, I'll be talking about arthrocuff with surgical technique and how it fares with other studies. It all started with this patient, a 48-year-old mason by occupation, presented with right shoulder pain. He is unable to actively lift his right upper limb. MRI showed a massive rotator cuff tear, which is retracted. He's failed conservative management. What will we do for this patient? Yes, like everybody thinks, an arthroscopic repair with suture anchors will be ideal for this patient. But for such massive tears, even single row costs around approximately 35,000, and let alone double row repair. So the irony is that these procedures are all not included in the CM scheme also. So the only option for this patient would be an open transosseous repair. So in our effort, we wanted to provide this patient the benefit of both arthroscopy and transosseous. So in association with NHHID, that is the National Hub for Healthcare Instrumentation Development from Anna University, we developed ArthroCuff. That's an arthroscopic, implantless, reusable transosseous rotator cuff repair system. We have been using this system since 2017, and for the purpose of this study, we've selected 73 patients with 2 years follow-up with the following criteria. It's a single surgeon study, and the following objective and subjective data have been collected. These parameters were assessed using SPSS statistics software 22.0 version. This is our ArthroCuff instrumentation. It consists of the ArthroCuff jig. It has a cannulated base and a screw tip in the distally. So apart from that, this is the pilot all. This is a 2 mm drill bit, and this is an introducer. So on the apex of the introducer sits a hexagonal forward threaded screw. It has an eyelet in which the sutures can be inserted. This suture lock mechanism is the one that helps us in settling the sutures. It is pattern painting. So this is one of our patients, a 43-year-old female with chronic right shoulder pain. MRI showed a degenerated cuff tear. So we proceeded with the diagnostic scopy through the posterolateral portal under regional anesthesia, lateral position. So the cuff was mobilized and repair mobility was assessed. After preparing the footprint, we proceeded with the tunneling. So for the first step is to make the vertical limb of the tunnel using the pilot awl. So we have to make this as much vertical as possible. It also serves as the entry point for the jig. Through an accessory lateral portal, the jig is introduced and the tip is navigated so as to engage in the jig. So you can see in the dry bone model on the right the configuration which will be there. So we drill through the cannulated guide. A 2 mm drill bit is used to create the lateral, that is the horizontal tunnel. This intersects with the vertical tunnel, and a through and through L-shaped tunnel is created. With the jig in place, the suture lock mechanism which sits on the introducer is introduced through the cannula, and it's tightened so that the suture lock screw locks to the tip of the jig. So once you take off the introducer and withdraw the jig, the shuttling process is complete. So then we proceed with the standard rotator cuff repair using a retrograde suture passer and sliding arthroscopic knots. Any configuration is possible if you use more than 2 tunnels. In some cases, we have placed 3 tunnels. So this is the patient at 1 year follow-up, and she is happy. Our rehabilitation protocol is pretty much the same for any cuff repair. Immobilized and sling for 2 weeks, short chain motion, passive motions to 6 weeks, active assisted motion from 6 to 3 months, and then proceeded with strengthening. This patient is an 8-month postoperative acute traumatic cuff tear. He came for follow-up, and recently he had decurrence at the left hand. So he is happy. He has good range of motion and good power. We had 73 patients in the study. Out of them, 27 are female, 46 are male. The mean age is 56.9, and most of them having degenerative tear. The size of the tear has been classified using Cofield, and most of them are stage 2 and stage 3. And the fatty degeneration is in Bucalier. Most of them come under stage 1, 2, and 3. We didn't include stage 4 patients. And at the end of 2 years, all our patients had good range of motion and almost equal to the other limb. And the visual unlock score is also negligible. Our results are comparable with the other studies also. The Oxford shoulder score are compared with preoperative values at 6 months post-op, 12 months, and 2 years. The results were comparable with other studies. Yes, of course, we had few patients falling behind the mean at 6 months, but with extended physio, they also improved. Our mean operating time is comparable with other studies. So this is one of a patient who had pain and significant stiffness at 6 month post-operative period. We gave him a steroid injection and extended physiotherapy, but at 1 year, he's happy. He has good range of motion and pain free also. Like any study, yes, during upfront stages, we had 2 design-related intraoperative complications. When one, the tip of the jig broke and the screw went past the jig in another case. We made necessary design modifications to the jig, and we haven't encountered the similar complications now. Coming to the discussion part, there are a lot of studies in the internet and the literature comparing the results of transosseous tendon repair, transosseous suture repair, and ankle repair. All of them show a clinically equivalent result. There are a few studies that point out that the ultimate, that is the initial fixation strength and the footprint coverage, the tendon to bone pressure is much better in the transosseous repair. I would like to point out the statement by Umashri Kumar and al. From Johns Hopkins that the transosseous approach dominates the anchor approach because it gives an equivalent outcome at much lower cost. These are the various arthroscopic repair systems available. So, like any other transosseous repair, we encounter the same problem. All surgeons ask us, will the bone do it? When we were in the prototype stages, we encountered an original article with Akal and Calvary. This is for open transosseous repair. They've studied the distance between the sutures from the tip of the tuberosity and the footprint to tip of the tuberosity distance. So they calculated the mean ultimate strength of fixation according to the location of the sutures. So at 10 mm footprint to tip of the GT bone ridge and from the tip to the lateral canal bone ridge of 22 mm is sufficient to hold 165 newtons of force, which is more than sufficient for the repair. This is further augmented by a Kramer et al. CD quantitative study, which shows that there is sufficient cortical support even in the osteoporotic bone in the subchondral region and in the lateral cortex. To conclude, we were able to tick all the boxes. We were able to give the patient the benefit of arthroscopy, a cost-effective transosseous repair, and a clinically equivalent outcome to all modern techniques. Additionally, we also believe our tunnel acts as a crimson duvet and provides the much needed growth factors and for the repair, and it also improves the biology of the repair. Yes, we have few shortcomings and we are hoping to improve it in the further studies. We also have come up with a new disposable system, and we also have to do more number of revision cases. I'd like to thank Dr. Senthilvel and Neju Om Prakash and HHID for the financial support. Thank you.
Yeah. Can I ask a question?
Yeah, please go ahead.
Yeah. What's the name of the presenter?
Dr. Raj Suresh.
Raj Suresh.
Yes.
Yeah, Raj Suresh. I was just observing, like, is this a novel equipment?
Yes.
If it is so, what is the routine method of transosseous fixation? You should have shown that, like, how is it being done? Because you showed a lot of studies there. How have they done the transosseous? You should have shown that basically, and then you should have shown the difference and how your novel equipment is going to differ from the other methods. You're not shown that.
Yes. This is a novel equipment, sir. We have started this from the prototype stage. We have designed our own jig, and the thing is, all the other systems have a similar type of jig, but they use a nitinol wire loop, which is reusable. It costs for every patient. So to overcome that, we have come up with a suture lock mechanism where the screw fixes to the tip of the jig. So we can reuse the screw. So that is the major difference. Rest of the jig, the other main difference is the transosseous tunnel comes in the metaphyseal region in most of the previous arthrograph systems. In ours, it comes in the metadiaphyseal system. So we believe it provides more fixation strength and prevent cutoff.
You should have shown all this, because any non-arthroscopic surgeon, you will not be able to understand what really you are telling. You should have shown the difference between the other methods and what is novel about your method. Only when you see that, we will be able to understand that. Yeah, sure. Thank you.
Thank you.
Shall we go to the next talk because we are running short of time?
Yeah.
3D printed surgical simulator for percutaneous fixation of hand and wrist fractures by Dr. M.V. Reddy.
Respected Chairman and Co-Chairman, today I would like to share our experience with 3D printed surgical simulator for percutaneous fixation of hand and wrist fractures. I have no conflict of interest and no financial support for this project. 3D printing technology is a process of making a three-dimensional solid object of virtually any shape from a digital model, that is from your CT scan. 3D printing is widely used in medicine, more so in orthopedics. Now, percutaneous fixation of hand and wrist fractures is the most popular and a preferred method of treatment. But close reduction and percutaneous fixation of hand fractures can be deceptively difficult procedure that requires simultaneous spatial coordination and haptic feedback. So it's difficult for the postgraduate to do this percutaneous fixation of these hand fractures and wrist fractures unless he is adequately trained. Now, training of percutaneous fixation saw mold models has its own disadvantage for the simple reason here there is no skin sleeve, so the student will be able to see the bone in all directions and he knows the direction in which the guide wire is passing. But actually, in reality, we'll be only seeing a part of the bone. The rest of the whole surgery, percutaneous surgery, is done with the guidance of the C-arm. So sawbone models are not very useful for percutaneous surgery fixation of hand fractures for training the postgraduates. Now, the surgical simulators are very useful in percutaneous fixations. These surgical simulators allow the learners the opportunity to become proficient in surgical procedures in a safe environment, and they'll be easily able to translate these skills learned on simulators to the operating theaters. There are a lot of benefit of surgical simulators. I will not go into the details. A lot of other specialties also are using surgical simulators. Now we are trying to develop a basic surgical simulator for percutaneous fixation of hand fractures for our postgraduates. Now this is our surgical simulator which we have developed. This is a wrist which has got bones inside, and as you can see the bones on C-arm, they are opaque and they are as normal as the normal wrist. So this surgical simulator is used for percutaneous fixation of scaphoid fracture. This can also be used for Bennett's fracture and also fracture base of the fifth metacarpal. We'll not go into the details like how we have developed it, but I'll tell you the basic steps. So first we got the DICOM images, CT scan images of the wrist, and these images are added to various software to develop a 3D model which can be printable. That developed 3D model is printed using an FDM printer, and this is the FDM printer. It's a desktop printer which I use to print the model. This uses ABS plastic, and I will not go into the details of how it does it, but it prints the model doing layer by layer. Now from the CT scan, first we printed the carpal bones, then next we printed the metacarpal bones, and then we joined the carpal and metacarpal bones to form one unit. Then we printed the distal end of the radius and the distal end of the ulna, which is again joined to the previous bones, and a complete wrist is developed now with radius, ulna, carpal bones, and all metacarpals. These size and shape of these bones which were printed is anatomically exactly accurate as the original bones of the patient. Now, from the same CT scan, we used the files to develop and print a skin sleeve. Now, this skin sleeve is printed from the CT scans of the same patient, and as you can see, they are as accurate as the normal skin. You can even see the impression of the dorsal veins. Now, this printed skin sleeve is hollow and it is not very flexible. Now, we have introduced the printed bones into the printed skin sleeve, thereby making the wrist model complete. But still, there's a gap between the printed skin and the carpal and the printed bones. So, if we fill the gap with a very soft silicone, Shore 10A hardness silicone, so that it's very flexible. Now, once the silicone is set, the skin sleeve is slit and removed, and the model, the silicone model with the radius, ulna, carpal, and metacarpal bones is ready. This is our prototype model. You can see the model is opaque, so you can't see the bones, but the advantage of our model is there are a lot of unique features, like it's anatomically accurate, it is flexible, you can see the dorsiflexion and palmar flexion, and it is radio opaque, so that you can see the bones under the C-arm. At the same time, it is opaque, so that through the eyes, we cannot see the bones. Now, this is the same simulator, and under C-arm, you can see the images, the bones in the simulator look and appear just like the normal wrist. Now, this is the same patient who had a scaphoid fracture, that is his wrist and that is his X-ray. From the CT scan of the patient, same patient, we have printed our 3D simulator model, which you can see same, it looks like a wrist, and the image of the wrist under the C-arm is almost same like your original X-ray. Now, this simulator is given to our postgraduate to do a percutaneous fixation surgery. As you can see, the simulator is placed under the C-arm. The postgraduate has decided the point of entry and they pass the guide wire using images under the C-arm, and as you can see, the C-arm images are exactly same like a normal wrist. After passing the guide wire, the position of the guide wire is confirmed under the C-arm in all views. Again, you can see all views under the C-arm of this simulated wrist is exactly same like a normal wrist. Then a cannulated drill is passed over the guide wire, and an appropriate screw is selected. And once the appropriate screw is selected, the screw is passed over the guide wire and fixation of the scaphoid is done. And finally, the compression of the fracture site is given, and then the position of the screw is confirmed in AP, lateral, and oblique view. Now, as you can see here, this percutaneous surgery of fixation of scaphoid is done through a small hole here in the simulator. This is exactly the same procedure what we do in a percutaneous fixation of acute scaphoid fracture. Now, the same patient I have operated and I have put a percutaneous screw fixation, and the same patient on the model, same patient's model, my postgraduate has operated and put a percutaneous screw. In fact, if you see both the things, both of us have done the same job, and the placement of screw is almost the same in both the cases. So this gives a lot of confidence to the postgraduate that he is able to do a successful surgery as good as me. We use these models for 3 to 4 postgraduates, and we try to take their opinion about the usefulness. So the feedback from the postgraduate was they found that the models are very accurate, and the tissue feel of operating is as good as the normal hand. And the drilling through the bone, they found 90% of the time it is same as drilling through the normal bone. So this 3D printed bones drill feel is as good as a normal bone. So the residents feel that this is a very useful training, especially for percutaneous fixation of fractures of the hand and wrist. And we are developing a 3D printed hand. So we have 3D printed all the carpals, metacarpal phalanges of the hand, and we are printing the skin sleeve of the hand, so that the same way we are going to create a 3D model of the hand with all fractures, Bennett's fracture, fracture neck of the metacarpal, fracture phalanges. Again, the student can practice percutaneous fixation of all these fractures in this hand model also. So there are a lot of advantages of a 3D printed model. First advantage is the model is as near accurate and normal as the original patient's hand, and then the feel of drilling the bone is almost 90% of this thing. The models are malleable, so it just gives the feel as though they are operating on a realistic hand. Now, to summarize, we created a wrist stimulator, which is an anatomical, low-cost, multi-procedure tool that can be used to train and improve the basic surgical skills of residents in training. Finally, coming to the cost of it, we are able to produce a wrist and a hand models, each one costing less than 1,000 rupees. Thank you.
Very good research work has been put in, a lot of efforts. And how about the cost of the equipment for the 3D printer? Is it within the reach of a average orthopedic surgeon?
Sir, you able to hear me, sir?
Yeah.
Hello?
Yeah.
So the cost of the printer, sir, this cost of the printer which I've used, it's a regular printer. It just costs about 1,30,000 rupees. Now I think it's come down to 1 lakh. The question is now, from the same file what we have created, we can have any number of prints. So if an institute has one printer and one file, so you can keep on printing these things, and every batch of postgraduates can start getting trained. That's a big advantage. It's very cost effective. Printer is just about 1 lakh rupees. And the material, all that cost is all just, it all comes to less than 1,000 rupees.
Yes, sir. Can I ask a question, sir?
Yeah.
Yes, sir.
Ready, sir. You said the student has the, say, 90% feel as that of a bone.
Yes, sir.
We normally see like getting the 3D models. The standardization of the material has to be there. Probably you should have done a repeated standardization and trying to get it to that of the bone, the texture to that of the bone. Have you done
Sir,
this in this case?
Yes, sir. Now what we did, sir, first thing is that there are 2 experiments which we did before this, sir. First experiment is, sir, we printed the whole skeleton once from the anatomy department, and then we measured the bones to that of printed bone, and they were very, very accurate, which we have already published it, sir. So next is, then we tried different materials to print this, sir. We started with ABS plastic. The last material what we have started is a wood plaster. That is, it's got 40% wood and 60% plastic. And since I'm printing the bone from a CT scan, the internal architecture of the bone, what I've printed, remains exact the same. So that's why the wood plast bone, it looks also brown. And anyhow, it doesn't matter here because we are doing percutaneous surgery. And its feel is almost 90% as the same what we did in the bone.
how did you differentiate between the cortical bone and the cancerous bone there? I think that is a very difficult one to get a construct like that.
Yes, sir. No, sir. With the 3D printing model, whatever is the structure of the bone in the normal CT scan, the cortical and cancellous, the printer prints with the same density, sir. In fact, if I print a head of femur, I'll have outer cortical shell and intercancellous like this. In fact, we have printed mastoids, sir, for ENT surgeons for temporal bone dissection, sir. And the internal architecture of the mastoid was exactly the same as the real temporal bone. So based on that, we thought, okay, why not we make a simulator so that one hand, I can have 10 fractures. With a wrist and hand, I can have 15 fractures. So one model costing 1,000 rupees, a postgrad can practice 15 fractures percutaneously under CM. That's the, especially in the COVID time, I think this is the best option. Otherwise, postgraduates usually for percutaneous fixation of scaphoid and surgeries like this, sir, where only surgeon does it, they only have to assist. They never get the feel of the tactile feel and then the direction in which they should pass in the C-arm. Sawbone model, sir, it is seen all around. So you know exactly where your screw is going. But in reality, you see only a part of the bone. So that's why the simulator probably is very useful for postgraduate, especially for wrist and hand fractures, because where we do 90% percutaneous surgeries.
So it was a nice paper, sir. Just I wanted to know, these residents who rated this model, do they have the experience of drilling a normal bone also? Have they done enough surgeries or practice so that they can make a judgment?
So this is given, say I had, this is just developed the model, sir, and then the COVID came. So this model is given only to the final year postgraduates, sir. I didn't test it on first year.
Yes.
So, because final year postgraduates has already, he has done.
They would have done, yes.
Yeah. So that's why. Actually, sir, we are making a detailed study of the effectiveness in the terms of the accuracy and all out of things. But with the COVID, now with all the, we are not meeting each other, so it's cystic, sir. So we want to make a hand one and a wrist one, and then one model, sir, I'll create 15 fractures. That's what we have decided. And then one can practice all fractures. So each postgrad, one model is, in fact, this can be used to assess the surgical skills of the postgraduate also, sir. The same model can be given to 2-3 candidates and decide how much time they are taking to fix and how good they are fixing it. That itself can be a, I mean.
Shall we go to the next paper, sir? Single stage double incision fasciotomy, column specific internal fixation, and vacuum assisted closure for compartment syndrome. It's Cancer 5 and 6 tibial tubercular fractures. Dr. Muthukumar. Can we have the next paper? Yeah.
Good morning. I'm going to be presenting on single stage double incision fasciotomy, column specific internal fixation, and vacuum assisted closure procedure for compartment syndrome in shortcut type 5 and 6 tibial plateau fractures, a novel approach. I'm Dr. Balaji from Medical College. Introduction: compartment syndrome and tibial plateau fractures present a permanent challenge for treating orthopedic surgeons. In the literature, no consensus on the management of these fractures has been arrived at yet. Most common strategy is early fasciotomy and external fixation, followed by a second stage definitive fixation. We performed prospective study of tibial plateau fractures type 5-6 with impending compartment syndrome treated by single stage double incision fasciotomy and column specific internal fixation and back dressing. The purpose of the study was to analyze the outcome by relieving compartment pressure and its clinical symptoms, immediate fracture reduction and fixation to allow for early mobilization and joint range of movements to prevent the knee stiffness. The study duration was between May 2017 and February 2020. Institution Medical College Hospital. Study population: all patients with tibial type 5 and type 6 plateau fractures with impending compartment syndrome and included in study. 21 patients, 16 males and 5 females were included in the study. Diagnostic criteria for the fasciotomy: clinical features suggestive of impending compartment syndrome, stretch test, raised intracompartment pressure using the needle method. 10 patients had all three factors. 4 patients did not have stretch test positive. 7 patients did not have raised intracompartmental pressure. Exclusion criteria: established compartment syndrome with irreversible tissue damage, compartment syndrome due to other etiology treated by other protocols. Materials and methods: computed tomographic scan was taken in all the patients. All surgeries were performed by the same surgical team. Functional and radiological outcome was measured using the modified Rasmussen functional and radiological scoring. The OMAC score was also used. Surgical steps under spinal anesthesia without tourniquet application, the part preparation and draping is done. The double incision fasciotomy is first done. The first incision is along the anterolateral aspect of the leg and measures 20 centimeters. The incision is directly above the intramuscular septum between the anterior and lateral compartments. Using a metronome, both compartment is released and the epimysium of the muscles are released. Here we can see the anterolateral incision location. And this is the location of the posteromedial incision, just 2 centimeters posterior to the posteromedial border of the tibia. The first incision, once the incision is made, the fascia is visualized and a vertical incision is made between the intramuscular septum so that the muscles of the two compartments bulge out separately, and you can notice the muscle bulge here. Through this, metronome is inserted and in 4 different directions it is completed. The second incision is then placed 2 centimeters behind the posteromedial margin of the tibial chain. The superficial compartment of posterior compartment of leg is first released. Following this, the dissection is carried along the posteromedial margin of the tibia. A periosteal elevator is then used to release the attachments of the deep muscle of the leg from the tibia. The fasciotomy is now complete. Here we can see the periosteum being used to release the posterior deep compartment. Fracture stabilization is then done using the locking plates, using the standard procedures. The incisions are primarily closed. The fasciotomy wound was then covered using the back dressing. The wound was examined on second post-op day for suitability for SSG. You can see the incisions for the implants. Post-op protocol, the limb is immobilized for 8 days for allowing the SSG to settle. Then the mobilization is begun. The wound examinations are done every 4 days. The minimum of 90-degree flexion is attained by 3 weeks. Patients who fail to achieve this are subjected for manipulation, partial weight bearing by 6 weeks and full weight bearing by 12 weeks. The early range of post-op movement is the goal. The mean age of the patient was 38 years. The mean follow-up period is about 27 months. The mean hospital stay is 14 days. All patients underwent emergency surgery as soon as they presented with or started developing features of compartment syndrome. The mean functional and radiological modified Rasmussen score in our series is 27 and 28 respectively. 4 patients had excellent outcome, 16 had good result, 1 had a poor result. The mean OMARC score in our study was 8.9. 5 patients had a score of 0, 14 patients had a score of 1 to 10, and 2 had a score of 11 to 20. There was no varus or valgus instability at final follow-up. The average union was 12.3 weeks. An average of 110-degree knee flexion was achieved in all the patients for 3 months. 3 patients had less than 90-degree movements at the end of 3 weeks and underwent manipulation. Ankle and foot function was good in all the 21 patients. 4 delayed unions, 3 superficial infections were noted, no deep infections in this series. Clinical results: first patient, 40-year-old male patient with type 5, type 6 tibial fractures. Early compartment release, and the fixation has been done as a functional outcome, excellent functional outcome. Next, with 35-year-old male patient, similar procedure. The X-fix was removed on day 2 and converted to internal fixation. And you can see satisfactory function. Another similar case, 19-year-old male with type 6 and compartment pressure, early release, and back has been done. So 2 days later, X-fix was removed and internal fixation was done. Compartment syndrome in tibial fractures is a well-known complication. The reported incidence is 13 to 31%. However, in literature, there is conflicting evidence regarding management. Most studies have reported staged procedure as similar as against single-stage procedure in the management of these fractures. The results, however, has been suboptimal and associated with multiple complications and loss of function. Controversy remains regarding appropriate compartment pressures for performing fasciotomies. Repeated clinical examinations are necessary to decide about urgent fasciotomy, regardless of the compartment pressure. The measurement of compartment syndrome is often inaccurate in up to 25 to 30%. We used the needle method in our institution and was accurate in about 66.67%. The rest, 33%, high index of suspicion and clinical examination was used. We used severe pain with passive motion, firm swelling with woody feel, pain out of proportion to that of injury as the clinical criteria to diagnose impending compartment syndrome. Muscle weakness, altered sensation, and vascular findings suggest a more evolved compartment syndrome and a different management strategy. One radiological parameter related to the occurrence of acute compartment syndrome has been highlighted, namely a longer distance from the center of the tibial fracture to talar dome, meaning a More proximal fracture of the tibia is unlikely to cause compartment syndrome. Conclusion: this study shows that treating tibial plateau fractures type 5-6 with type 5 and 6 with compartment syndrome by dual incision fasciotomy early dual plate fixation at same stage gave satisfactory clinical and radiological outcomes. This treatment approach has the benefit of avoiding repeated soft tissue trauma of secondary surgeries, reduced hospital days, early rehabilitation, and less expenditure to the patient. Also, this method avoids complications of temporary externofixator application followed by definitive fixation at a later stage after the healing of fasciotomy wound. Example, pin tract infection, osteomyelitis, or deep soft tissue infection. Thank you.
Can I ask a question? Can
Yes,
I ask a
please.
question?
Yeah.
Balaji, I think in your discussion you said that the needle method of measurement of the compartment pin pressure is sensitive in only 66%. So it may not be very useful in using this method in all cases. And I see in your statistics, you've shown that there are a few cases where you had based upon the pressure measurement and the clinical presentation, stretch pain was negative. In such cases, you are taken up for compartment release. Are you justified in just believing the symptomatology alone and the pressure without the presence of stretch pain in going ahead with the decompression? Is Balaji here? Is he present?
Sorry, sir. Good morning, sir.
Yeah.
Going with the clinical scenario would be the best choice of things. But the needle method, oftentimes when we have been regularly using it, we were quite sure that, okay, this method is trustable under single person's experienced hands. We can go along with that. But stretch pain, oftentimes we wait for the stretch pain to happen and we go and release the thing. Post-operatively, the patient still complains the pain. And that is the reason I went in early and did in few cases.
Because the clinical findings may be more deceptive. In fact, some people, it varies with the status of the patient, no, the pain threshold of the patient. So some people might have a severe, they may not be able to tolerate the pain. Some will be able to tolerate pain. So you cannot purely go, but because one of the clinical symptoms is pain only. That's the most important one. But if you're going to go along with the pain, the symptomatology alone, without any clinical findings, I think you might end up doing more decompressions
than usual. I agree with you.
And one more thing is, are you sure that this is a novel method? No one has done this in literature?
The earlier publications, they have mentioned that it's not the incisions or the fixations, so it's all the same. Fixation quite early with the double incision fasciotomy wound, I think this is the first of its kinds.
Okay.
I've seen one such study in IJO where Timegowda et al. They have done just a single anterior anterolateral incision, introduced the plate through that incision, and they have done an early closure as well, sir.
After decompression also?
Yes, sir.
When did you close your fasciotomy wound?
So fasciotomy wound, usually it takes about 4 days, sir, but sometimes we have gone in early on second day and did the SSD using plastic tile.
What are the chances of infection when compared to the regular open reduction and internal fixation without compartment syndrome? Is there any increased rate of infection in your study?
There is a theoretical increase in risks, but with the help of VAC, we're able to clear most of the edema and the tissue things. The infection rate is almost virtually nil. So the only trouble is in handling the soft tissues during the fixation. If we are close, the closure is tight, or the using diathermy, we injure the skin and the soft tissues. That causes trouble, sir. Usually, that is my observation.
Okay. Thank you, Balaji.
Thanks.
I think we'll go to the next paper.
you have the last paper? There are no treatment-based classifications to address the surgical challenges in advanced lumbosacral spinal tuberculosis. The need for a classification to address the surgical challenges in advanced lumbosacral spinal tuberculosis can be best understood with this case example. This is a patient with L4-L5 tuberculous spondylodiscitis who was managed elsewhere with L4-L5 posterior stabilization involving one segment above and below, and these are the immediate postoperative radiographs. 1 year after surgery, the patient presented to us with back pain, and radiographs show evidence of implant loosening with a risk of impending fixation failure. Implant removal and redo stabilization was done with a spinopelvic construct. At 26 months follow-up, the lumbosacral spine is stable, well-healed, and the lordosis is within physiological limits. Because of the absence of a treatment strategy-based classification to address the surgical challenges in advanced lumbosacral spinal tuberculosis, surgeons around the world manage this lesion in their own unique way, which may sometimes result in complications, as seen in the case just a while ago. Literature lacks evidence-based recommendations. Levels of instrumentation are not clearly defined. The feasible distal anchor points needed to reconstruct an unstable lumbosacral junction have not been well defined, and the scenarios in which an anterior reconstruction is needed is not properly defined. The unique lumbosacral anatomy and biomechanics will determine the pattern of disease progression and the development of deformity. In a predominantly anterior spinal lesion like lumbosacral tuberculosis, even moderate destruction of the vertebral body or the intervening intervertebral discs can result in a gross reduction in physiological lordosis or a kyphosis with grave functional outcomes. Early lumbosacral spinal tuberculosis can be successfully managed with chemotherapy alone, whereas advanced lumbosacral tuberculosis with extensive destruction leading to hyperlordosis or kyphosis and instability, resulting in a loss of lumbosacral biomechanics, can lead to back pain and poor functional outcomes. Surgery remains the mainstay of treatment in advanced lumbosacral tuberculosis as it helps restore the stability at the lumbosacral junction. It restores the physiological lumbar lordosis. It restores the regional and global spinal stability and maintains the spinal stability until the bone heals. Literature has shown that anterior debridement and fusion will prevent and lessen kyphosis, but there is a high incidence of graft-related problems and rehabilitation is slower. Supportive posterior instrumentation has several advantages and allows early mobilization and rehabilitation. Posterior instrumentation at the lumbosacral region is technically demanding due to its complex regional anatomy, unique biomechanics, fixation difficulty in the diseased bone, loss of sacral bone for implant anchorage, and high chances of failure due to shear stresses. Spinopelvic fixation is an effective surgical option in such scenarios. These are the indications for spinopelvic fixation in lumbosacral tuberculosis. To understand the biomechanical strength of a spinopelvic fixation construct, we must know the lumbosacral pivot point of McCord et al. It is a point at the middle osteoligamentous column between the last lumbar vertebra and sacrum. The farther the implants extend anterior to this point, the greater will be the stiffness of the lumbopelvic construct. The failure rates of S1 pedicle screws used as the sole means of fixation for long fusions to the sacrum are as high as 44%. Although the combination of S1 and S2 pedicle screws are stronger than S1 screws alone, the S2 pedicle screw remains dorsal to the lumbosacral pivot point and does not add much to the overall strength of the lumbosacral fixation construct. Iliac screws are an ideal option in such scenarios. We did a retrospective analysis of a prospectively treated single center cohort of symptomatic biopsy-proven patients with lumbosacral tuberculosis who required surgery. The mean follow-up was 3.5 years and the maximum follow-up was 10 years. These were the indications for surgery. All patients received a transpedicular biopsy and a standard 9 to 12-month chemotherapy. Patients were classified into specific types based on the increasing severity of destruction of the lumbosacral spine, and appropriate surgical strategies for reconstruction were proposed, incorporating the biomechanical principles of spinopelvic fixation. In a type 1 lesion, which is L4-L5 tuberculous spondylodiscitis, the lumbosacral spine was stabilized with posterior stabilization using 4 anchors proximally and 4 anchors distally. In a type 2 lesion, which is L5 tuberculous spondylitis with destruction of L5, stability was achieved by posterior stabilization with at least 4 proximal anchors at L3 and L4 and 2 distal anchors at S1 with supplemental iliac screws if the fixation in S1 was inadequate. In a type 3 lesion with destroyed sacral promontory and an intact sacral ala, spinopelvic stabilization was done with 4 proximal anchors at L4, L5 and 4 distal anchors using alar screws and supplemental iliac screws. In a type 4 lesion, which is L5 tuberculous, L5S1 tuberculous spondylodiscitis, in which both the sacral promontory and the sacral ala were destroyed, the lumbosacral spine was reconstructed using spinopelvic stabilization with 4 proximal anchors at L4, L5 and 2 distal anchors using bilateral iliac screws. Anterior reconstruction was indicated in scenarios with significant vertebral height loss and with significant anterior column deficiency, where additional restoration of lordosis within the physiological limits was needed. Outcomes were analyzed using the following parameters. This is a type 1 lesion which was managed according to our protocol, and at 39 months follow-up, the patient showed good, stable, well-healed lumbosacral spine. This is a type 2 lesion in which the L5 vertebral body was grossly destroyed. The patient was managed with spinopelvic stabilization using S1 screws and bilateral iliac screws. At 6 years follow-up, the patient showed a stable, well-healed lumbosacral spine with good functional outcomes. This is a type 3 lesion in which the sacral promontory was destroyed with an intact sacral ala. Spinopelvic stabilization was done using bilateral alar screws and iliac screws. At 42 months follow-up, the patient showed good functional outcomes. This is a type 4 lesion which was managed using bilateral iliac screws. At 8 years follow-up, the patient showed good functional outcomes. A total of 46 patients were managed. The mean follow-up duration was 43.5 months, and the mean duration of symptoms at presentation were 5.7 months. Good functional outcomes were seen at a mean follow-up of 43.5 months, as evidenced by significant improvement in VAS scores for back pain and leg pain and Ospesty Disability Index scores. Good bone healing was seen in all patients at a mean of 8.5 months. Restoration of the lordosis was achieved in 41 of the 46 patients, and no neurological deterioration was seen in any patient. These were the complications which were successfully managed. Surgical treatment of advanced lumbosacral tuberculosis remains difficult and controversial. Few detailed studies exist on this subject. There is no universally adopted surgical strategy to reconstruct the lumbosacral junction. No defined guidelines exist on specific fixation techniques to reconstruct the lumbosacral spine. The proposed classification and the corresponding treatment strategies have proved to be effective in addressing the various complex scenarios of lumbosacral tuberculosis in a systematic way. It helps reconstruct the lumbosacral spine and restore stability at the lumbosacral junction. The current study has shown that patients treated according to the recommendations classification have achieved good functional outcomes at a mean follow-up of 43.5 months with a minimum follow-up of 36 months. Thank you for your patient listening.
Where is Aital? Is Aital not there? Would the judges would like to ask questions if there are no questions from the delegates? Okay, I don't see any questions in the chat box. Syed sir, can we conclude the session?
Yeah, we can conclude the session. Thank you very much. It was a very interesting session, and it has been well organized from the technical point of view. I think it's quite a successful session.
Okay. Aital?
Papers present. Sorry?
No.
Thank all the speakers, and I think all the papers were of highest quality, and I think we need to strengthen this medal session in OSSCon, and today all the papers were good. I thank all the presenters as well as the organizers for giving me this opportunity. Thank you all.
Thank you. Thank you.
Thank you.
Yeah.
Thank you.
Good morning, sir. Good morning, sir. I'm Dr. Kaushik Reddy. On behalf of OSSCon Organizing Committee, I would like to thank the judges for conducting such a wonderful consultant gold medal session. Hello?
Yes, we can hear you.
Yes, sir. Yeah. Thank you very much, sir, for conducting such a wonderful consultant gold medal session. So, since the session is over now, so we'll move on to the next session. So, which is there in Hall A.
Yes, sir.
It's oration. We'll start with the oration. Okay, sir?
Yes, yes. President, sir.
Good morning to everybody.
Yeah.
Good morning.
Let us start the next session.
Yeah.
And I request Professor Nalli Yuvraj to start the proceedings for the prestigious past president's oration.
Yes.
By Professor S. Pandian.
Yes. So I will start. I will just introduce the speaker, and then I would request our president to invite the speaker to deliver his oration. Dr. Selvaraj Pandian hails from.
Then Hall A, then Hall A continue.
He had his education from the undergraduate education from Tanjore Medical College from 1981 onwards. He had his D-Ortho training at Stanley Medical College and MS from Madras Medical College. He has undergone the trauma fellowship in 1994 under Professor Thomas Rudy. I joined Ready-Placing Fellowship in 2003 under Professor Muller in Germany, and Spine Fellowship under Robert Gaines. He practices in a semi-urban area as a general orthopedic surgeon, and he was actually in Tamil Nadu Medical Service for 3 years and left because of his demand in his private practice. And he's been executive committee member of the Tamil Nadu Orthopedic Association, and he was one of the founder members of the Pondicherry Orthopedic Association, and is the president of the Pondicherry Orthopedic Association. And he had conducted the 2005 TNOA annual meeting, and he concluded with the. He was also a part of the OSSCon, which was held in 2019. He has got a number of paper presentations, both in the national and the state region level, and also has a few publications in national and international journals. Just to hailing from a semi-urban area, a place like Kadalur, I've always found that he's been interested in academics, and even now you can see that he sits in the conferences and starts noting down a lot of good points that he hears during the lectures. With a small, this is a small introduction. I request our president to invite the orator to deliver his oration.
Please unmute, sir.
Yeah. Thank you, Dr. Nalli Yuvraj. It's my proud privilege and honor to invite Professor Pandian, who, as we all know, was the past president of our association and always very affectionate man and very prompt when you call him or to reply to our mails. That should be the character of a past president. Now, of course, you will hear his academic achievements that we are going to hear in form of his past president's oration. Over to Professor Pandian.
There's a recorded presentation, no? You have a recorded presentation?
Yes, we have. It's going to come now?
Yeah. Respected President Dr. Raghav Dutt, respected Secretary General Dr. Nalivaraj, respected President, Secretaries and Executive Members of the YSS, senior colleagues of profession, delegates attending this meeting, I thank you all for giving me an opportunity to share my experience. I've chosen this topic because this problem is not being addressed to the postgraduates nowadays. I'm happy to inform that this is from a rural area. Clubfoot is a very common deformity and it is a global problem. This child, 3 days old, came to the OP on 10th November, 15 days ago, with a deformity. Obviously, it is clubfoot and we have applied a plaster by Poncety technique. 1 week later, this patient came with a deformity. That is 3 days old child. This is 1.5 years old child. If this patient would have come to me 20 years ago, I would have immediately suggested surgery. If the patient was not willing, I would have suggested a just fixator. Professor T.K. Shanmugasundaram, my teacher in orthopedics, taught me the conservative management of CTV and the application of POP. It is Professor Devadas who taught me all about the CTV to all the postgraduate. He is an enthusiastic teacher with a Midas touch, and this paper is out of his teachings to me. I salute and thank him. Every 3rd minute, a child is born with CTEV. We all know it's a fibroproliferative disorder, congenital in nature. Still, the pathogenesis is not known. It is not clear which proteins are involved in the pathological process. Biopsy of the resected tissue on the medial side shows that it is a calcified fibrous tissue. After treating 175 cases in my practice, I'm still not able to give 100% success in the management of CTEV. Parents will be shocked to see the baby when it is born with CTEV. It may be a precious child born 10 years after their marriage. These are the questions that will occur in the mind of the parents. Sometimes patients come with an anomaly scan and their question will be whether to terminate the pregnancy. Richard Gross says, I don't completely understand this condition and must regard my approach tentative, but I truly believe it is the best that I can do given my current state of knowledge. Seddon says it's an ancient disease and no human race is immune to it. It's a central and almost a clubfoot as a central and almost a unique place in the story of crippling disorders. In the modern era of robotic surgery, clubfoot has not been given much importance and training. This needs a good analysis and management rather than off-quarter treatment. Review of literature shows the immense amount of thought about this condition. But still, there is divergence of opinion. Various methods of treatment are being advised. Multiplicity of operations and methods of treatment are ample evidence that still CTV is an unsolved problem. One must understand the pathological anatomy to give a rational method of surgical treatment. In the era of pessimism, Adams in 1866 thought it's mid-tarsal subluxation. In the era of optimism, Delvin Evans in 1961 presented a paper in JBJS showing that it is talonavicular subluxation which causes the deformity. In the era of enthusiasm, in Poncety in 1996 showed that it is the cavus deformity that it produced the CTEV. The treatment of CTEV depends on the pathology of this condition. So it is almost like a total knee replacement. One must stretch the tendons or surgically lengthen and release the ligaments so that the ligaments and the muscles remodel themselves and balance themselves. The bones and the joints will come back to its position as in a total knee replacement. Histological findings in clubfoot. Fibroblasts are the primary cells to cause this clubfoot. And the resected specimen, where in a case of resected specimen in a neglected clubfoot shows that it contains fibroblasts, myofibroblasts, fibrocytes, smooth muscle, and adipocytes. To put it in a nutshell, an immunohistochemistry study shows that the contracture on the medial side is of 12 times more compared to the normal side, and it is 4 times on the lateral side. Calcium deposition occurs over the fibroblasts to produce this deformity. It is collagen 4, collagen 6, calcification on the medial side, and angiogenesis, which cause tissue dystrophy to produce a tough tissue on the medial side. Coming to the evaluation, Epstein-Barr presented a paper in JBJS 2005 where he showed 85% positive predictive value in clubfoot. It is more reliable at the 6th month of intrauterine life. Tillett and others in 2000 showed the degree of deformity is difficult to assess with an ultrasound. In all his series, he showed that 61% of his cases needed surgery. French surgeons in Stanford Hospital injected Omnipac into the subtalar joint and showed that there is a parabolic curve in a normal foot and a horizon type of curve in a clubfoot. Once you see a curve of horizon type, you must cut the posterolateral fibrous knot. This is a picture depicting the cutting of posterolateral fibrous knot. Shafiq Pirani showed that ultrasound also is another method of evaluation. You can see the 2 feet, one with third correction, the other with a correction after tendoculi stenotomy. The MRI pictures follow it. He also showed that MRI after a correction of the foot shows abnormal relationships of the tarsal bone, and also you'll be able to assess the tarsal osteochondral angles. If you take an MRI prior to application of plaster or any surgical procedure, the epiphyses of talus and calcaneum overlap each other. After correction, the talonavicular joint goes back to its position. This is a photograph taken in Austria showing that it is a disease which runs in families. The whole village in Austria is suffering from disease. They considered this is a sin from God, and they considered it's a curse from God, and it runs in families. The incidence of CTV is 1 in 1,000, but one child is born with CTV. The future child, there is a possibility that the future child also will be a CTV child. So the affected child, the possibility is 20 to 30 times greater than greater. If one parent is involved, there is a risk of 3 to 4%. If both parents are involved, the risk is 15%. In our series, we found 25% consanguinity. These are the questions that are still not answered based on evidence-based medicine. When you treat bilateral CTV, either by surgery or by conservative method, one side does well, the other side is not doing the same well as the other side. Uterine package defect is a word coined during the word 1990 by the European surgeons. So there were many hypotheses postulated at that time. One is abortifacient, the other is the cord around the foot The third is consanguinity. This term is no longer used, and the first two postulated theories have gone out. Only the consanguinity theory still exists. These are the points to be evaluated before treating the CTV child. One must convince and console the patient, parents, and prepare them for any future surgery if there need be. I am not going to the details of the Pirani score. These are the midfoot signs and these are the hindfoot signs, and the total score is 6. The more the score, there is a need for tender Achilles stenotomy. Poncety believes this is more of a prognostic value, and those with a higher score require tenotomy. These are the goals of treatment of CTEV. One should get a supple foot, muscle balance should be good, and it should be a normal looking plantigrade foot, and child should be able to wear a footwear comfortably, and the heel should be in slight valgus. These are the options available with us. So we treated all these CTV cases in 1989 with plasters. The order of correction will be adduction of forefoot. The first correction will be adduction of the forefoot. Then the varus deformity will be corrected, and finally the equinus. Cavus was not taken into consideration at that time, and after once you apply a plaster, wait for 3 weeks and change the plaster. Like that, we go on putting plaster for 4 or 5 plaster and then advise surgery. This equinus deformity correction is indicated in patients who have less Pirani score, and if you are able to correct the other deformities well. When the heel is tucked up and the heel is small, the TA tenotomy may not help. These patients need TA lengthening posterior capsulotomy and lateral tether release. Obviously, ankle capsulotomy and posterior release gives a better result than percutaneous tenotomy. Posterior medial release is the surgery which I have done from 1989. Turco described this in 1979. This one surgery fits for all CTVs, whether it is mild, moderate, or severe. He reported 15 years follow-up with 75% excellent results. Professor Govardhan only taught me Turco's method of correcting this deformity. Dublis and others in 2006 showed in their paper that a follow-up of 25 years showed 47% poor result. These are the complications that occur after a posteromedial release. In our hospital, we have operated on 112 patients from 1989 to 2012, and most of the surgeries were done between 1989 and 2002. And we had a satisfactory result in 86% of cases. This is the incision starting from the lower third of the leg on the medial side, crossing over the ankle, going up to the head of the first metatarsal. Whereas the Govardhan lengthens the tender Achilles, and then the tibial is posterior. It doesn't touch the flexor hallucis longus and flexor digitorum longus. He always fixes the talonavicular joint after cutting the ligaments of the talonavicular, tenio-metatarsal joints, and he does a stainless procedure. There is this patient 3 years follow-up and 13 years follow-up. Abductor hallucis erasure is a must in all these patients to prevent relapse of adduction. Professor Rajshekharan at the same time was doing CTV surgeries by the same posteromedial release. We have done bilateral cases in 11 patients. In Ganga Hospital, they don't put a K-wire for the talonavicular joint. Professor Govardhan believes that the deformity revolves around the talus, and the deformity, all these deformities are following a talonavicular subluxation. In our series of 11 cases, in 11 patients, we put a K-wire on one side. When we operate on left, we left the other side without a K-wire. In those patients where you put a K-wire for the talonavicular joint, those patients did well than the other group. Professor Rajamani taught us the Cincinnati incision. This is a posterior incision. You can approach both the medial and lateral side. The only problem is skin necrosis in this condition. The skin necrosis was more, and we stopped with 3 cases. Resistant foot means the foot strives against correction. All club foot strive against correction. Recurrent means once you correct a deformity and go back to its position after sometimes it is running back to the original deformity. This is called a recurrent foot. And Poncety believes the pathology in the recurrent club foot and the primary club foot are the same. These are the points to evaluate it in a recurrent club foot. B.B. Joshi, Professor B.B. Joshi, the former IOA president, has invented the JESS apparatus. Thanks to him, we did in JESS fixation in 14 patients. We had 72% good results and high patient satisfaction. The first 2 cases were done by Professor Govardhan. This is the first case. The immediate correction. After 4 months, we removed it, and the foot on the corrected side is small compared to the other side. 14 years follow-up, child is doing well. This is another case, bilateral case. Immediate correction, 1.5 years. We put up JESS fixator on both sides simultaneously. 12-year follow-up, good correction. This is another child which we have corrected ourselves and showed a good result. This also had a good result. These are the unfavorable results after posteromedial release: skin breakdown, recurrent club foot, forefoot adduction, rocker bottom foot. Elizarov external fixators in another method of treatment. Dorpoli in 1994 showed far to poor results in his long-term follow-up. There is a Russian study by Ivanov showing good results, 95% good results in all his 112 cases. This is the apparatus he has used, and this is the correction after treatment. Obviously, foot on the other side is small, but a good correction of the deformity. We have done triple orthodosis in 2 patients and Dillwyn-Evans in 1 patient, but results are not satisfactory. After the JESS fixator, after we started using the JESS fixator, these surgeries are not at all followed up. Coming to the conservative treatment, we followed the Poncety method. Ignacio Poncety of USA presented a paper in 1948 about his technique of correction, but the technique came to India 20 years ago. Poncety in 1980 published the results with 27 years follow-up showing 90% good result. Cooper and Dietz in 1995 reported the longest follow-up showing 78% good result. In our study of 60 feet, in less than 1 month, we had 47 cases, and more than 1 month we treated, we had 13 cases. Once again, the consanguinity is 25%. I'm not going to the details of Poncety method, but the cavus is the first deformity that is to be corrected, which you failed to do initially. The first metatarsal should be dorsiflex, stretched along with the toes, and then once you start correcting, the cavus also will get corrected. Kite's error is Kite's gave pressure on the calcaneal cuboid joint instead of the talus. Poncety gave pressure on the talus to correct the deformity. He gave pressure on the calcaneal cuboid joint, and the varus didn't get corrected. This is called Kite's error. Equinus, in all cases, we do percutaneous tendoachilles stenotomy. Case 1, this is the preoperative. This is the first cast of the first, second week, third week, fourth week, fifth week, sixth week. The deformity has been almost corrected. You can see the POP after correction. This is before, after. At 9-month child is really doing well with the doing well. And this is 3.5 years follow-up. Case 2, bilateral CTV, first week, second week, third week. And we always do a percutaneous tender-occlused tenotomy in all these cases at the 6th week or the 7th week. We do it under local anesthesia. This is a picture showing Poncety doing it as a OP procedure in his clinic. US surgeons prefer Achilles tenotomy under general anesthesia. We have no experience, we do it under local anesthesia. Accelerated Poncety technique is nothing but applying the same plaster twice a week so that the time becomes shorter, the treatment time gets shortened, and results are equally the same as the regular Poncety technique. Accelerated Poncety technique reduces the cost treatment, and it is equally effective as a standard Poncety treatment. We get good results in 5 to 6 plasters. Some patients needed 8 plasters. You have to assess and then apply the plaster. Achilles tenotomy in idiopathic clubfoot, a paper from Montreal shows that the recurrence rate is recurrence of the clubfoot deformity is very less in a follow of 5 years. This is the third case, before casting, after casting, 9 months follow-up and 4 years follow-up. This is yet another child with a deformity after correction, a reasonably good correction. We use a modified Dennis Brown splint in our country. This is a paper from North Carolina where they show you must that splint should be used for 3 years. We changed our protocol and started using it for 3 years nowadays. Alvarez in 2005 used botulinum toxin injection into the gastrosoleus complex instead of tenotomy and claimed good results. Ramchandran and others did a retrospective study on 20 patients and found no difference at all. We don't follow the Pirani score, though it is a prognostic value. Once you get a good dorsiflexion after a clubfoot, after Poncety method with a slight valgus, we take it as a effective treatment. We take it as a good result, and this paper confirms it. Professor Ratanlal Mittal, you can call him as father of clubfoot surgery in India. As a postgraduate in 1990, I heard his lecture. He gave a silver jubilee commemoration lecture in an IOA con with 250 cases. He released all the tendons. He did Z-plasty of all the tendons. He released all the ligaments on the medial side, on the posterior side, and then apply a plaster and claimed good results. He himself said that Poncety, Zilizro, Turco, Simons, whatever it is, they are good in mild to moderate deformities till 78 years only, but they fail in extreme deformities. When you don't treat a child with CTV, when they become adult, these are the following complications that can occur. So adduction produces a severe hallux varus, inversion will go into a reverse foot, and coupling all 4 components with various grades will produce a triple plus dislocation. He has been operating on all these patients. These are the complications seen by him in adults. Stress fracture, genu valgum, residual heel varus, genu recurvatum also in adults. And these are the reasons to operate on these patients. You can see marital problems, stress fractures, extensive course, painful walking, early OA. He has written a book on clubfoot and it has been released. It was released in November 28, a very comprehensive approach to clubfoot, past, present, and future. Those who are interested can buy this book. To put the treatment by algorithm, brought immediately after surgery, day 1, if the child is, most of the cases can be treated by Poncety. From 6 months to 2 years, still, if it is a virgin case, you can try and correct it with Poncety. If you are not getting a good correction, probably you may go for a PM or just fixator. The child comes after 2 years, still you can do a Poncety and correct it. As I show in the fifth slide, that we have applied a plaster for the child, we are sure we will get it corrected by Poncety. There is no place for orthodesis in CTV. No more. There is no more a place for orthodesis in CTV. To conclude, Poncety method must start from day one. The footwear, it's very important. So in the follow-up, one should see to the child, one should see to that the child wears the DB splint for a longer time. So the compliance is less in our country. This is a same with Nayagam's paper in 2006 from Alderhay Hospital, Alderhay Children's Hospital. There is still much to learn about idiopathic clubfoot. This is another meta-analysis paper from Brazil with 150 cases where they showed excellent results in 89% by Poncety method. Clubfoot and orthographisis, they go together, and here also they claim good results in 95%. 95%. Poncety still holds good with orthographisis. This is another paper where there is coexistence of both clubfoot and DDH, where also you can start the treatment with Poncety to outweigh the problem of Costa valga. This is an eye-opener paper from Poncety. This is used nowadays in 120 countries, but wrongly done. 5 R's or rigid 5 R's is a must. Right age, right deformity, right technique, right bracing, and right follow-up. So Carroll in 2002 on Poncety's paper on Poncety's technique in Trends in 20th Century tells surgeons are now learning the limitations of this method. But Poncety himself said this is not meant for extreme deformities. Future, genetic engineering might enlighten the clubfoot prevention and its cure in the future, but we will still be in the dark as far as environmental factors are concerned. At present, this regime seems to have a strong foothold throughout the world. This is yet another study from Philippines where the child is able to squat after Poncety method. This is the first child whom I applied the plaster. It didn't work out. I operated PMR surgery. She is now 30 years now. This is another basketball player. He's 24 years now. This child is 1 year, 9 months. This is the son of the first child where I applied the plaster. The first slide I have shown. She's an IT worker. This child has been treated at Hyderabad. So child didn't have an improvement. So they brought the child to me and I said there is no need for surgery. We will treat with Poncety and the child is able to walk as you have seen in the video. With Poncety treatment technique, we were able to correct the child in 1 year, 9 months. I thank Professor Malfracture, my teacher, who has stood with me on all junctures of my happiness and sorrow. Saint Monica Vasak in the 2nd century told, Matramam Vayagatin Vevere Vandarivam. Change is inevitable. Innovation and concepts go on changing. Surgeon has to update. To put it in timeline, in 1988, after my post-graduation, I started with POP. Up to 2002, I have been doing a lot of surgeries. I thought that was the only treatment, that was the only good treatment for CTV. Then in 2002, we learned the technique of Poncety and treated 60 feet with Poncety with excellent results. So time alone will tell whether this is going to change. So I'm sorry.
We will stop the video now.
And the Pondicherry Orthopedic Association for giving me this opportunity, but for them, I would not have stood before the podium, before this podium to present my experience. I thank Secretary General Dr. Malleolus, who stood with me and shouldered me to continue my presidentship. Swami Vivekananda told, "You are the creator of your own destiny. I may not be there yet, but I'm closer than I was yesterday. There are a lot of things to discover and research in CTV. This is only my experience. I thank for your patient hearing. Thank you."
Thank you, Dr. Panyan. It was a very lucid talk. It was so clear. And I stopped doing these treatments a very long time ago, more than 2 decades ago. But it was a complete relearning for me, myself. I don't know why in the hierarchy somebody said we should not ask questions for orations. I never understand this, because an oration is an experience of a lifetime. I just want to ask you a small question. Because you are practicing in one place and your patient population is around your area, what is the trend that you have seen? Is the incidence of children with club feet the same as before? Is it decreasing or is it increasing?
Definitely decreasing.
Why do you think so?
Patients are not coming to me. Probably they are going elsewhere. I'm not able to say whether it is really decreasing, but we are seeing less patients in our OP, CTE.
Because that's what most people are telling me, that the doctors are seeing less and less compared to maybe 20 years ago.
Yes, this is my observation.
What do you think, Professor Nalli? What is your observation? Are we seeing a decreasing trend?
No, I think we may not be able to say this correctly, because the decrease may be due to the more number of specialists around. No, like initially it used to be like I still remember. No, like Dr. Pandian is like a god in that area.
Right.
Yeah, at least 2 to 3 districts in that area, and now today there are hundreds of nearly 100 orthopedic surgeons around him now. So that may be the reason why it's increasing. And then I don't think there should be any reason why the incidence should decrease. You should have clear-cut reasons why there should decrease. So I don't think there should be any reason at all. Probably it is the more number of orthopedic surgeons around, the number is coming down.
Must be right.
Thank you very much, Professor Panjan. I thank you once again on behalf of the Orthopedic Association of South Indian States. We are certainly enriched by your talk today, and I'm sure you'll continue to inspire OSS and guide us to, as we discussed yesterday, a more academic and more theoretical as well as practically enriched OSS. Thank you very much.
Thank you very much, sir. Thank you, sir.
Thank you. We will move on to the next session. The Professor S.K. Marthandam Memorial Oration by Srinivasalu Metikala.
It is SSK Marthandam.
SSK Marthandam.
Yeah,
Yes.
yeah, okay.
Professor SSK Marthandam.
Because he's my teacher also. So.
Yes.
Okay. I think as usual, I'd introduce the orator. Today's orator is Dr. Srinivasalu Metikala. I hope I have spelled his name rightly. He is at present the assistant professor at the VCU Medical Center, Richmond, USA. I heard that he recently moved there. And his biodata to read out. He did his MBBS from 1993 to 1998 and MS Ortho from 2000 to 2003 at the Osmania Medical College, Hyderabad. And following which he had UK training from 2005 to 2006. He finished his master's diploma. And following which he came back to India and had his private practice in Kadapa from 2006 to 2017, in 11 years here. And had an academic practice at the SGS Medical College from 2006 to 2017. He has had various trainings in the form of AO Trauma Traveling Fellowship at Wake Forest Baptist Medical Center, North Carolina, USA in 2015, Limb Reconstruction Fellowships in Sheffield, UK from 2017 to 18, Foot and Ankle Fellowship in University of Pennsylvania, USA from 2018 to 2019, and a Sports Fellowship in Pennsylvania State University, USA from 2019 to 2020. And he has a special interest in and expertise in foot and ankle surgeries, also interested in trauma, sports, and pediatric orthopedics. So with this short introduction, I think here is a man who educated in India, practiced in, I should say, a semi-urban area, Kadapa, and then had a lot of training abroad, and finally has gone abroad. So with this short introduction, I leave it to our president to invite the speaker.
A few years ago, Srinivasalu was in Hyderabad attending one of the academic sessions at Apollo Hospital. And he presented his work on he presented a case how he removed a broken nail, if I remember correctly, from the intermedullary nail. And I was so impressed the technique that he showed. And from then on, I was in touch with him. And last time I went to Kadapa a few years ago, he's been there and working. And we know that he has an academic bent of mind and very promising future. That's what I thought when I met him about more than 10 years ago, when he was a young surgeon. I'm sure he is much more enriched now with his knowledge and his wide travels and fellowships. And let's hear what he has to say in this oration. Over to you, sir.
Srinivasalu online?
Dr.
Are we ready?
Srinivasalu, are you online?
I think it's ideal that the orator is present during the delivery of the oration.
He knows the time and he knows we've been communicating. Yeah. He has replied to the mails also. Maybe there's a problem in communicating.
Okay. Okay, just go ahead.
We will go ahead because we cannot stop.
Good morning, everyone. I'm truly honored and humbled by this opportunity. Professor Marthandam was the external examiner during my final year ortho exams. Indeed, he is a great source of inspiration to many. Ankle fractures have a lot of variations in their occurrence. Some fractures look simple and stay simple until union is complete. Whereas a fracture like this appears benign to begin with, but gets complicated afterwards. And we also see fairly complicated stuff from time to time. So we really need to understand who needs surgery and who can be treated without it. When surgery becomes imminent, then in what sequence? Before we discuss on that, let's step back for a minute and review some basics. Ankle joint is not just a hinge joint. Although the predominant motion is in sagittal direction, there is an element of rotation of the talus within the ankle mortise, thus making the ankle a rotary hinge. We are already aware of these classification systems, which are very descriptive. But why don't we just summarize everything into two categories, stable and unstable? Because that's what really matters for decision making. Just like in pelvic ring, we have an ankle ring, where the talus is stabilized by a ring of bony and soft tissue structures. The ring begins at lateral mal, moving anti-clockwise. We have AITFL, and then comes deltoid ligament and medial mal, travels through posterior mal and PITFL, and finally back to lateral mal. So a single break in the ring results in stable injury, whereas two or more breaks lead to an unstable injury. The bony injuries can be readily identified in radiographs, but as a clinician, we should be able to recognize the concomitant soft tissue injuries happening to syndesmosis and deltoid ligament, which in fact determine the overall stability in every ankle fracture. In a nutshell, any injury to the ring that destabilizes the talus from its position within the ankle mortise must be treated by surgery. And the aim of the surgery is to obtain a congruous joint and a stable joint that can reliably maintain the talus position within the ankle mortise until healing is complete. The serious consequence of incongruity was already explained by Ramsay and Hamilton way back in 1976. The contact area of tibio-talar articulation suffers immensely by 40% with just a millimeter of lateral talar displacement. This concept was retested after 30 years using modern techniques which had just confirmed the same statement. So how do we obtain a congruous joint? Well, by anatomic reduction of articular fragments, taking care to preserve their soft tissue attachments, restoration of fibular length, followed by achieving congruous reduction of syndesmosis within the tibial incisura, which can often be quite challenging. The second component of obtaining a stable joint is typically by soft tissue stabilization of syndesmosis and medial ligamentous complex. All these measures are basically to keep the baby with the mother, I mean the talus within the ankle mortise, so as to restore the contact area of tibio-talar articulation, distribute the peak contact pressures, and delay, if not prevent, the future onset of post-traumatic arthritis. It's indeed interesting to note the evolution of ankle fracture management. We have learned that bone surgery is not just enough. It is critical to recognize injury to the unseen structures such as syndesmotic and deltoid ligaments and restore them when needed. And more recently, changing concepts in the fixation of posterior malleolus fractures. Here are some undisplaced fractures, and I'm sure most of us consider them as stable fractures and agree to non-operative treatment with no further testing. But this may not apply to an ankle fracture. An undisplaced lateral malfracture may not remain stable despite being protected in a well-molded cast. We know that it happens due to concomitant injuries to the ligaments. Can we recognize them early? Of course, by stress testing, and we have 3 methods to do so. Each one has its own pros and cons, so any test is okay as long as the foot is kept plantigrade, which can tighten the deep deltoid ligament. Manual stress test can be performed in an outpatient setting under live fluoro. It consists of 3 steps. One hand of the examiner will stabilize the leg in slight internal rotation. The other hand applies a gentle external rotation force on the foot while maintaining plantigrade position. Being clinician dependent, this may be more reliable but can be uncomfortable to the patient and also requires the availability of a mini C-arm. Gravity stress is more patient friendly. It has the same reliability and is widely practiced, although is technician dependent. Weight bearing stress is patient dependent, who should be able to stand on the injured foot. The test is considered positive when the medial clear space is more than 4 mm or at least 1 mm greater than the superior joint space. First of all, why does the medial clear space widen in an isolated lateral malfracture? Well, we have 3 reasons. Fracture displacement, associated syndesmotic injury, and associated injury to the deltoid ligament, which can involve just superficial ligament or complete injury involving both components. One can also argue that it is the ligamentous injury which has resulted in the displacement of fracture fragments. Let's review the relevant anatomy of medial ligaments. The superficial ligament has 4 bands. Although the tibio-navicular and tibio-spring ligaments are consistent in majority, these long bands connect the tibia with the hindfoot and acts as a strong restraint to eversion stress. This is the picture for the superficial ligament. And the deep ligament has two short bands connecting tibia directly to the talus. The posterior band is the strongest of all and acts as a strong restraint to external rotation stress. Injury to just superficial ligament complex can cause widening of medial clear space, but does not lead to instability when the lateral structures are intact or stabilized by surgery. On the other hand, a complete injury involving the deep deltoid ligament results in persistent instability despite lateral fixation. Let us discuss this with a couple of examples. Here is a 50-year male with an isolated lateral malfracture of right ankle and widening of medial clear space. We have just discussed the three reasons for a wide medial clear space: the fracture displacement, injury to syndesmosis, and injury to medial ligaments. So we need to determine the contribution of each of these by a step-by-step approach. Step 1 starts with fracture fixation, which is achieved by the principle of absolute stability using a combination of 2.7 mm cortical screw as a lag screw for direct fracture compression, followed by application of a lateral neutralization plate. Please note, anatomic fracture fixation typically corrects the wide medial gap. Now we proceed to step 2 and apply external rotation stress in the same way we did before in the clinic. In this case, the medial clear space opened up again, indicating issues with the other two ligaments which need to be addressed individually. Let's begin with the syndesmosis. How do we diagnose syndesmotic instability? It is just by look, feel, and move technique, which is a pretty standard method of every orthopedic clinical examination. It is possible to take a peek into the anterior tibiofibular joint by simply dissecting anterior distal fibula and retracting the anterior flap. We can directly identify the torn anterior syndesmotic ligaments, feel the gap using a freer elevator, and can also move the distal fibula in AP direction by holding it with a clamp. In this case, there was obvious syndesmotic injury with instability, which was stabilized using a 3-5 screw as a positional screw. So with this step, we have eliminated the contribution of syndesmotic injury as a reason for medial clear space widening. But the surgery is not complete yet. We still have to test for integrity of the number 3, which is the medial ligaments. We do this by simply repeating the same external rotation stress. And what do we look for? It's not the medial gapping, but we look for talus tilt and opening of medial tibio-talar joint space, which is not evident in this situation, and hence there is no need for additional medial exploration. So in this case, we learned that the ankle ring was broken at two places, lateral mal and syndesmosis. There may be a partial injury to the deltoid ligament, but the deep ligament was definitely intact. So the learning point is not all cases with the wide medial clear space require fixation of deltoid ligament. Indirect medial stability can be achieved by a lateral fixation of fracture as well as syndesmosis, and this is called surrogate fixation. The typical sequence of surgical steps starts from lateral to medial, fibular fixation first, followed by stabilization of syndesmosis, and finally stress examination of medial instability. Let us discuss another example. A 20-year male with a closed distal fibular fracture and widening of medial clear space as well as tibiofibular clear space. Again, the same 3 steps. Step 1, lateral plating of fibular fracture. Step 2, external rotation stress and syndesmotic stabilization using a couple of tight ropes, which is my current choice in younger patients. And step 3, repeating external rotation stress test to identify medial instability, and in this case the test was positive with the lateral tilting of the talus and opening of medial joint space. This particular situation represents a complete injury to the deltoid ligament complex involving both superficial and deep components. The traditional teaching is application of a below knee cast in plantigrade position for 6 weeks. If we decide this route, it is important to avoid plantar flexion because plantar flexion causes healing of deltoid ligament complex in an elongated position with a risk of residual medial instability postoperatively. The other option is by surgery. In the recent decade, we have realized that primary deltoid repair offers better outcomes, which was practiced here using a couple of suture anchors. How about fixation of lateral malleolus fracture by a posterior plate? Of course, it's an option. Here we have an undisplaced fracture of lateral malleolus. Stress examination in the clinic revealed widening of medial clear space and fracture displacement. It is a typical supination external rotation type with an oblique fracture running from anteroinferior to posterosuperior. Such fracture geometry is very much amenable for posterior plating with an anti-glide principle, which means the application of a cortical screw through the plate hole situated just proximal to the fracture spike will allow the plate to fully reduce the oblique fracture and restore the fibular length. The fixation was then completed by placing additional screws on both sides of the plate. With this, the medial clear space was restored to normal. Upon intraoperative external rotation stress, the medial gap did not open again like in previous example, indicating stability of syndesmosis and medial ligaments. The follow-up radiographs at 8 weeks showed satisfactory healing of the fracture with anatomical restoration of ankle mortise. However, there can be two problems using a posterior plate. Number one, possible injury to superior peroneal retinaculum and peroneal tendons, and for that reason, the lower end of the plate should stop at least a centimeter proximal to the tip of lateral malleolus. Also, when syndesmotic fixation becomes necessary, the screw has to be placed outside of the plate to achieve an optimal trajectory, and that has a risk of lateral cortex blowout and loss of stability. Let us pay attention on this 32-year male who jumped off a 6-foot wall and twisted his right ankle. X-rays demonstrate distal fibular fracture, widening of syndesmosis, and a small posterior malfracture. Please note, there is no widening of medial clear space. The surgery started with the lateral approach. There was an obvious defect in syndesmosis. The fracture fixation was achieved by a posterior plate in an anti-glide fashion. A cortical screw was employed in lag mode through the plate hole to achieve direct compression of the oblique fracture. This was followed by syndesmotic stabilization using a cortical screw placed anterior to the plate. If you can pay attention on the immediate postoperative radiographs, you can sense that something is not quite right. The tibiofibular clear space got better, but there is widening of medial clear space which was not evident in the pre-op images. And the reason for this is syndesmotic mal reduction due to posterior translation of distal fibula relative to tibia. So the learning point is appearance of wide medial clear space after fixation of fracture and syndesmosis, once thought due to interposition of torn deltoid ligament, is now believed to be a result of syndesmotic mal reduction. Let's look at syndesmosis in an axial CT image. A congruent joint demonstrates fairly symmetrical gap throughout the tibiofibular joint. Mal reduction patterns can happen in anterior direction or posterior direction or medial direction, also called over reduction, which can still happen with the bulky King Kong reduction clamps. Or the distal fibula can external rotate or internal rotate, or a combination of abnormal translation and rotation if we are really unfortunate. So how do we reliably evaluate syndesmotic reduction during surgery? Well, we have three methods. The first method talks about traditional measurement of tibiofibular overlap and tibiofibular clear space. In light of anatomic variations among different individuals, we know that this method is not always accurate. The second method is about open reduction. As discussed before, it is possible to directly look into the anterior tibiofibular joint through the lateral approach, but it will only identify the anterior relationship with no idea on what's happening at the back. The last option is obtaining C-arm images of contralateral ankle in the operating room and using them as templates to evaluate syndesmotic reduction. This method was published in 2013 and I find it quite reliable. For this, we need two views. The first picture is the Mortise View, which helps to understand the fibular anatomy. The relationship between the tip of lateral malleolus and lateral process of talus serves as a reference to fibular length. And the profile of lateral malleolus helps to understand the rotation. The second picture on the right is a true lateral view, which is obtained by centering the fluoro image over the talus, with perfect superimposition of medial and lateral borders of the talar body, and this image is called talar dome lateral view. In this view, we know that the distal fibula overlaps the distal tibia, and we measure the width of anterior tibia that lies anterior to the anterior border of fibular cortex, which serves as a reliable reference to assess syndesmosis. These two images are typically obtained before prepping and draping the injured side and saved in the C-arm monitor for comparison during surgery. Let us practice this technique with a recent example. A 55-year male with a closed injury to the right ankle. The radiographs show a displaced distal fibular fracture and widening of medial clear space as well as tibiofibular clear space. As we said, before prepping, we save the Mortise view and talar dome lateral view of the opposite ankle. The steps of surgery happen in the same sequence. Step 1, anatomic fixation of distal fibular fracture using 2 lag screws and a lateral plate. Step 2, given that there was obvious widening of tibiofibular clear space, we proceeded directly with the syndesmotic reduction and fixation using a 3.5 cortical screws drilled across 4 cortices. But when in doubt, one can use a K-wire until the verification process is complete, instead of committing with a definitive screw. We now obtain our classic 2 views of the injured side for comparison with our templates of opposite ankle. The Mortise views on both sides confirm symmetrical fibular length and rotation. The lateral images also demonstrate equal measure of distal tibia anterior to anterior border of fibular cortex, confirming congruous syndesmotic reduction. Finally, we should not forget step 3, which is the external rotation stress examination for medial instability, which was negative with no talar tilt. Let's focus on fractures of posterior malleolus. This has been a topic of great interest in the recent times with the debates on decision making. Traditionally, we tend to estimate the size of posterior malleolus fragment in lateral X-ray and fix only if it represents more than a quarter or 1/3 of articular margin. However, given that the typical pattern of posterior malleolus fracture is in oblique fashion, we now learn that estimation of its size by lateral projection is probably imprecise. So the current concept is to focus on fracture morphology instead of size. This is according to a CT guided classification in 2006, which described 3 types of fracture patterns. Type 1 is the commonest variety with a large posterolateral oblique fragment that has the attachment of PITFL. Type 2 is the next common pattern extending all the way to the medial side, often with comminution, impaction, or incarceration of fracture fragments with overall poor prognosis. And type 3, which is the least common type involving just a shell of posterior cortex. Before we discuss on how to approach each fracture type, let us reiterate the relevant anatomy. In the axial section of distal tibia, we have Achilles tendon at the most posterior location, and from medial to lateral we can see the tendons of posterior tibial, FTL, neurovascular bundle, FHL, and peroneals. For type 1 fracture patterns, the classic posterolateral approach between FHL and peroneals gives an excellent exposure and permits direct reduction and posterior instrumentation of distal tibia as well as distal fibula. The classic benefits include congruous reduction of articular margin of distal tibia, indirect restoration of fibular length, and indirect stabilization of syndesmosis due to attachment of PITFL. This kind of surrogate fixation by posterior approach, in fact, is more reliable in achieving a stable syndesmotic reduction than transsyndesmotic fixation by lateral approach. But in case if you decide on lateral plating of distal fibula in anticipation of additional transsyndesmotic fixation for any residual instability, you can still do so by going over the peroneal tendons, which are now retracted in a medial direction. Then for type 2 fracture pattern, a posteromedial approach provides a great convenience. Depending on the location of fragments, the approach can be between the adjacent tendons and neurovascular bundle. The final type 3 fracture involves just the posterior lip and may be ignored with no fixation, but needs special attention on achieving congruous and stable syndesmotic reduction. This is in sharp contrast to type 1, where all emphasis is placed on reduction of the fragment, which in turn stabilizes the syndesmosis, a type of surrogate fixation. These posterior approaches are not without problems. There can be injury to the sural nerve, peroneal vessels, and adjacent tendons as reported in various studies. Some advocate posteromedial sparing approach, arguing against fixation of the posterior malleolus fractures based on few biomechanical studies. But overall, in selected cases, it's worth fixing since it facilitates stable reduction of syndesmosis. Let's review a recent example. A 49-year female fell off a ladder and sustained a trimal fracture with posterior subluxation of the talus. Actually, the initial presentation was frank dislocation, which was immediately reduced before obtaining these x-rays. The CT images demonstrate posterior step-off at the level of posterior malfracture, a long oblique fracture of lateral mal, and a medial malfracture with comminution. The axial CT demonstrates a type 2 split fracture pattern with a predominant posterolateral fragment. She was operated on the same day before the worst of the swelling set in. Although it is type 2 in light of large posterolateral fracture, we addressed this injury by posterolateral approach in lateral position using a beanbag. We were able to achieve anatomic fixation of posterior mal fragments using a small fragment T-plate. You can now see that the distal fibular fracture is already well aligned with good length restoration. The fibular fixation was achieved next by a combination of lag screws and 1/3 tubular plate. To facilitate medial fixation, the beanbag seal was released and the patient was rolled supine. Because of comminution, the medial mal was fixed with a combination of a K-wire and screw with a washer. Of course, we did not forget stress testing, which revealed no residual syndesmotic instability. The recent post-op radiographs show congruous reduction of the articular margin and stable position of the hardware. The next case belongs to a 22-year female who fell off a two-wheeler and sustained fractures of lateral mal and posterior mal with posterior dislocation of the ankle. The post-reduction films demonstrate satisfactory reduction with no fracture on the medial side. Surgery had to be delayed due to swelling. It was once again a posterolateral approach on lateral position and posterior plating of both fractures. The patient was then rolled into supine for intraoperative external rotation stress examination, which was negative for any residual ligament instability. The last patient, a 68-year female with morbid obesity, fell off a step and sustained a trimal ankle fracture. Post-reduction films demonstrate a long spiral fracture of lateral mal, an oblique fracture of medial mal, and a small posterior mal involving just the posterior lip. Surgery happened in supine given the fracture morphology and the massive BMI. Started with lateral fixation using 2 lag screws and lateral plate, followed by medial fixation using 2 screws. Although syndesmosis appear reduced, external rotation stress demonstrated medial clear space widening. So we proceeded with syndesmotic fixation using a screw. The learning point is anatomic fixation of lateral and medial columns typically facilitates congruous syndesmotic reduction, which now requires just in situ stabilization. At the most recent follow-up, all fractures healed well and the patient had good function. In summary, ankle fractures are often more complicated than what we think. According to ring concepts, it's very odd for the ring to be broken at only one side, so have a high index of suspicion. Every lateral malfracture should receive a stress test to look for occult instability, and surgery may be offered when present. Also practice stress test intraoperatively ×2 to diagnose hidden injuries to syndesmosis and deltoid ligament complex. Primary deltoid ligament repair has better outcomes when there is residual talar tilting despite lateral stabilization. The contralateral ankle flora images are reliable sources for intraoperative assessment of congruous syndesmotic reduction. And finally, decision on posterior malleolus fracture is based on fracture morphology but not on its size. When indicated, fixation of posterior mal offers a definite advantage by achieving congruous and stable syndesmotic reduction, although other benefits may be controversial. Of course, posterior fixation have a small learning curve, but I don't see a reason why we can't master them. Hope this lecture makes sense to better understand the management of common ankle fracture patterns, and I'm happy to take questions for more discussion. Thank you so much.
Thank you so much. I think we're everybody is trying to contact Dr. Srinivasalu. Are you there, Srinivas? Dr. Subramaniam is trying to contact him. He was informed this morning as well about the timing by Dr. Subramaniam, who is the president of OSAP. And he just called me about at the beginning of the oration that he'll be made available. And he agreed. I think there must be a technical issue.
Oh, he's not there.
He's not there. So he knows this is the reason why we were insisting on pre-recorded recording of all the talks and orations so that there's no last minute glitch. Having said all that, I think this is one of the talks that every trauma surgeon should go home, shut the door and listen to once again. It's too good. It's such a simple thing that we all think has so much to learn and so much to unlearn as well, our methods of practice. And I'm glad that his very lucid way of explaining, which is so easy to understand, the way he presented his work is a must for every trauma surgeon, I repeat, and to every postgraduate in training. I will certainly convey my sincere thanks on behalf of our scientific committee and OASISCon 2020, but I'm sure he would be an asset to our organization in future with talks like these. Over to Dr. Nalli Yuvraj.
Yeah. So we'd like to thank Dr. Srinivasalu for having delivered the SSK Marthandam oration. I think we come to the end of the oration sessions, and I now hand over the proceedings to the organizing committee to proceed with the next program. Thank you.
Thank you very much. And that was wonderful to hear such two very nice talks today. And as we all talk about academics for almost 4 days, including the postgraduate training program, as I do most times, I involve a few non-academic sessions. Yesterday, we had an interaction with Dr. Jay Prakash Narayan. Today, it is with this great soul of this nation or of the world, Sri Kamlesh Patel. I am not a member of Sri Ramachandra Mission. I don't meditate. And if there is a human being who is not at all spiritual, that is Raghavdat Mulukutla. I am not a spiritual human being. I am not interested in spirituality or the divine forces and all that. I have my issues, I have my problems, and I have my own worries, misconceptions, and lots of doubts in my mind about this whole world. So I thought that the best person to address us is Sri Daji, as is fondly called, the head of Sri Ramachandra Mission International. He agreed, but COVID prevented all that for him to be the chief guest. So we recorded a session which ran for a long time, and we show a little bit of the edited version of my interaction with him. The full version will obviously be available in our OSAP websites after the end of the conference. May I request our team, RASISCON 2020, to start the recorded tape. Please remember, these are the questions that I thought would be the questions asked by an ordinary, honest, young orthopedic surgeon. We work very hard, Daji. We work very, very hard. We do our very best to our patients in this country. And you know the challenges that doctors face. We work 12, 14 hours a day. We go home. Our wife is not happy because you don't have time to spend with her. When we are young, the children, we don't know how they grow, what they are doing because we have no time for them. We have no time for friends. We have no time for relatives. And then all we do is we get a little bit of time to exercise. And then we have workshops, we have seminars, we have books to read, to upgrade ourselves, we travel. We do a lot of things to be good doctors and to help people. But deep down, as a community, we are unhappy. We are unhappy with our perception of us by our friends, our relatives. They say that, yes, you doctors are the elite of the society, you are the cream of the society, but deep down, we are not enjoying our success. And then there's a conflict of different nature between us and the patients. And then today with the big modern hospitals coming up, there's a conflict between the values that we hold and we were taught, and that the values that the current management of the hospitals, quite rightly so, because obviously the hospitals have to make money to run the hospitals and to provide us with the crores of equipment that I need to practice. So there's a number of conflicts that are going on. And in this scenario, we turn to some lectures on YouTube and here and there, and then we hear that, you do meditation, you try to have positive thoughts. Then they say that as Lord Krishna said, forget your rewards, work hard. All this we keep hearing. But it's not easy for us to put that into practice. I request you to talk to us. You'll be heard by the orthopedic surgeons of whole of South India and some of the North Indian doctor surgeons as well today, when we broadcast this on in the last week of November. What do you think should we do to enrich our lives for us to lead more wholesome lives? And what is the meaning of this life? This has been a constant question asked, I'm sure, by most human beings. How do we lead our lives? Or how should we lead our lives?
I think nothing needs to be changed at the moment. You continue in the direction. What we need is a shift in our attitude. That's all there is to it. What I mean by that, people do not understand what meditation is all about. First of all, we have to understand what is meditation, what is the purpose of meditation. Often when we read Gita, we get the understanding from this particular sloka, and people get so confused with it. Kanmanyavadhikaraste, ma phalesu kadachanam. It has confused almost everyone whosoever has read that sloka. Confusion lies in not understanding the true meaning behind what Lord Krishna wanted to say at that time. Before I get into that, I would like to share with you how the words, they change. The meaning of such words change from time to time. Pre-1970, you know this word called gay. There was no problem in using this word gay in common, discussion. Oh, I'm so gay and happy today. But today, the same word has changed. The meaning has changed. Gay today, you all know what it means today, right? Just sexual preferences people have. Likewise, what Lord Krishna meant in those days, karma, that you have a right upon your action, you have a right upon your karma. Ma phalesu kadachanam. That's a different story. Now, karma, those times, had a different meaning. That anything that we do for our spiritual emancipation was categorized that we did for material welfare. It's shrama. So there is a distinction between karma and shrama. What you are doing, working 8 hours, 10 hours, 12 hours, 14 hours, and sometimes 16 hours, or even more as need arises. It is all shrama for material welfare, not only of yourself, but others at a physical level. The rewards are in this world in terms of finance. Many a times you have done operations and surgeries perhaps without any financial gains also. You continue doing that. That is shrama. Now, when I have to go to Bombay, I will have to work with the fruit of the results, or fruit as a result of my action. I'll have to buy a ticket. I'll have to arrange for the payment of my tickets. Isn't it? So, a lot of things are involved in fulfilling what is my destination ahead of me, my desire to be fulfilled. That I want to go to Bombay. And I have to do some work because of that. So fruit of my action is already there in my mind. But in sloka, Lord Krishna is understood as if he is telling you not to have the fruta or the fruits of your action already in your mind. You have to forget that because the meanings are different. Anything that we do for spirituality or for my spiritual welfare, it is all under that category, and I cannot categorically say that it is something that I demand because of my worship of God. I worship out of love. The fruit of love I cannot demand. I cannot love my wife and at the same time ask for a favor. It's up to her. When there is mutual love, there is no transaction. See, with God also, when I love God for the sake of love, there is no transaction. And since there is no transaction, there is no fruit of your action involved in it. It is pure love, where there is no end result at the end of it. Anytime we bring in prayer with the end result, that prayer will become null and void. Because prayer, after all, is nothing but an expression of your inner joy to God and being grateful. The moment I start asking for this or that, it becomes transaction. And transaction is not love. Transaction is not prayer. Transaction is transaction. It is begging. God, I want this. God, I want that. And there is no end to such things. Coming back to the busyness, how busy we are in this modern world. You know, I worked all my life as a pharmacist. I started from scratch and established many pharmacies in New York City area. Not only that, I would come to India many a times during, at least 3-4 months in a year. I would come and be with my Guruji. So a lot of work used to be there before coming and after going back also. Pharmacy means always, it's not only the business world, but there is a professional world also. There is a financial world also involved with it. You have to do all the financial transactions, you have to make business deals at the same time. You have to work with the patients and colleagues. If you talk of computer engineers or consultants, they also have the similar schedules, maybe even more, though they are sitting in one place, which is a curse actually. Actually, you are lucky that you have to focus only on one thing, surgery. And I have seen your biography a little bit. I have gone through it, and you are one of the rarest of surgeons available in India, perhaps in the world. And I must congratulate you for that. And I think if you can make your work itself as meditation, then you will not have to take out time of half hour in the morning or half hour in the evening, because now you have made your whole life as meditation. So it's what I started to say in the beginning, it's just what you need is a change of attitude. See, Gandhiji used to say that precisely when you don't have much time, you should meditate more. Because when we meditate, when we close our eyes in the morning, for a few minutes, let's say half hour in the morning, you meditate. In the beginning, to some people, it will be difficult. But because of transmission involved with this heartfulness way of meditation, it becomes relatively easier. You are able to dive deeper into your consciousness and experience that shift immediately. Having experienced that shift, a new level of consciousness, you get used to that peace inside. And with that peacefulness, we go into the working environment. And with that, we work. Now, what magical things can happen now and then is this, that we are able to avoid unnecessary things. For example, when I close my eyes and meditate in the morning, besides my meditation on divine principle, my mind will also venture into other things like what I'm supposed to do today, who is waiting for me, which patients to take care of, whom to meet. The whole schedule will come in front of your vision that, oh, I have to do all this. And when you go through that structure, you will be able to prepare yourself so well mentally. At the same time, you'll be able to discard, oh, this is not worth doing. I will not do this. I will not attend to this. So you're able to save a lot of time that way. And when you have a topic in front of you already and you are mentally prepared, I think further you save a lot of time in that, because something that you go unprepared and start working, it consumes more time. But you're mentally prepared so well ahead of time that you save time actually. And because of this meditation, we become more efficient in whatever we do. whether you are performing your duty as a father. It is not the time that you spend, but the quality time. You are saying that you're not spending time at all with, but even 10 minutes, 15 minutes, 5 minutes of your association with children will change the ballgame, because you are interacting with them at a very different level, from a very different dimension. As far as wives are concerned or husbands are concerned, see, wife would say, you are never enough. You are never spending enough time at home. But if you start spending time also, they will have another problem. You're spending too much time at home. See? This is, if you, I don't know, this is the problem most people face. If you bring a nice, beautiful sari, why did you bring the sari? I could have done better. And if you don't bring it, they say, oh, you never give me anything. So does that mean we have to ignore them? No, this drama, this joyful drama will continue forever. So we enjoy it. And if our spouse can also get along and join us in meditation, when we meditate together, our mutual understanding, not only logically, but also at an emotional and spiritual level, will skyrocket and becomes harmonious. There will not be room for this or that. You're a doctor, and I think you would understand the principle of entropy. It's in physics or chemistry, where the second law of thermodynamics, which says that everything in the universe tends to degenerate over a period of time if you don't interfere with it. For example, if you go on a vacation and come back after a month, no one has attended your house. What happens to the house? Though nobody came in or out, still there will be dust. You'll have to clean it up. There'll be floors to be cleaned up. There'll be smell everywhere, in the bathrooms, especially in the kitchen, in the dustbins. With children also, when we bring in a lot of toys, for example, clothes, somebody has to make sure that these toys are properly placed every evening, or clothes are washed and put in a proper place, books in a proper place on a shelf. But if a child doesn't do it, and somebody else also doesn't do it, what happens over a period of time? The whole room becomes chaotic and disorganized. So input is required. Input of energy, input of effort is required in all situations. But there is a way out. Let me give you one more example of husband and wife. When you go home after a day's long work, tired and frustrated, irritable sometimes joyful, and if you go late, she will ask you, why are you so late? If you go early, why are you so early today? And every time, for some reason or the other, this coming and going becomes a questionable thing in some families. And every time you have to defend yourself. Oh, honey, I had to do this, I had to do that. Imagine what sort of relation would that be? It's a hell. When you are being interrogated for coming home late, it's a problem. But if there is a true love between couple, such questions will become redundant. You may ask, why are you late? But that question will be with a lot of concern and with of love. Honey, what happened to you today? You are late. There will be so much of concern behind that question. But the question, what the hell were you doing today? Why are you so late? That is a different connotation, different meaning. Now, what is the energy input that would be required in maintaining such relationship? It will always be incremental in a relationship which is on a rock, you can say, which is always disturbed. You need more and more energy input to maintain your relation. But for example, if there is a lot of love between the couple, then there is no need for explanation. Question also would not arise. If at all, it will be just for a conversation, for why are you late or why are you early, just mere conversation. And there is a dialogue after that. That is also a formality. So when there is love, no further input is required. No further effort is required. Love itself takes care of everything. And I'm sure that love is definitely there. But especially when we are meditating together, when you are working, and while you are working and doing your surgery also, if one part of your mind somehow subconsciously busy in divine remembrance, it is actually higher than meditation. And to come to that level, some level of practice will be required. I would say maybe 2 months or 3 months of meditation, and occasional meditation will help. It's like, and it is not as difficult as it sounds, how meditative mind can be for more than your working hours. It can be even during your sleep, you can remain meditative. How? I'll give you a small example. As you know, you have children. When they were very young, 3 years, 4 years, you bought them a tricycle. And they became master of it, tricycle. So tricycle will have good balance. Once those tricycles are mastered, then you bring a bicycle with 2 more wheels on the side, and they start riding and they become master of it. Then you remove those 2 supporting wheels and they are only on bicycle, 2 wheels only. You support them in the beginning, but the time comes when they start riding it on their own. They don't need your support then. They are going to school on their bike with their friends, singing songs, often leaving their hands also off the handle, paddling it away. So it becomes a subconscious or reflex action. Similar things happens when we are learning to drive a car for the first time. See? In the beginning, there is a struggle. Afterward, it becomes our subconscious act. For me to handle a scalpel and a knife and other stuff at the same time will be a challenging job. But for you, you can do perhaps surgery with your closed eyes also. You have become expert in that field. For me, it will be so much of effort. Even after making efforts, I will be losing. So what I'm trying to say, that when we meditate, and a stage comes that this very process becomes subconscious, then it becomes 24 hours. Then you don't have to take out special time for it. You become meditation itself.
I think I have now understood very clearly what you're saying, though I heard your videos and tapes. Now I'm sure my colleagues also understood what you're saying. I think you put it very nicely. I want to ask you this question. See, now we are human beings, as I said, and we do these complex surgeries and we try our very best. And then if there is a mistake or if there's a natural event when the patient doesn't get better, today we see a very, very angry reaction. Sometimes there are acts of omission, sometimes there are acts of commission. People forget that this man is also a human being, he's trying to do his best. And then Suddenly, before the events where the people say we are gods or we are next to gods, and suddenly we become devils. And today, I'm sure we must have realized in the press, people are coming to attack us, people are destroying the hospitals, they are trying to, in some instances, they have killed doctors. How should we react to these situations? Are you saying that we should now become like a war between two countries like India and Pakistan, and always be on guard? Now, where is this doctor-patient relationship? And a lot of doctors are getting so fed up. And recently, in South India, a young doctor committed suicide, and it hurt us tremendously because a small child died. So, how do we react? And especially the younger surgeons who are on their own in small nursing homes with not all that much of paraphernalia available to deal with the situations. What is your advice to them? How should they support in themselves mentally?
It's tough. There are no answers for so many things in our life. When something happens, adverse especially, we feel at pain. I give an example, my real life example. I was in US when I heard my father is on a deathbed. I came. I stayed with him for almost 2 weeks. At the end of 2 weeks, for some reason, I went away from that ICU, came down just for a coffee. And meanwhile, the nurse, through these tubes, he was on tubes. He had tracheostomy done then, see. So they were feeding him through those tubes. Unfortunately, the doctor who prescribed nifedipine XR, 24-hour release, it cannot be given through the tube, but it was 30 milligram. Nurse crushed it and gave it. So all the 30 milligram was released in one go. And he just lost it, consciousness, and he went into coma and never came out of it. He died the same evening. I knew it right away that this is bad news. See, I felt sorry. What could doctor do also? I think he made a mistake, gross mistake, but should I fight? It will not help. But would other person understand this? I doubt it. People here, we become everywhere actually, become so emotional about everything. Persons for whom they did not even care for, now they're ready to fight for them. They lose the focus and they take the advantage of it and show off emotionally, burning things, destroying people, their lives. Similar thing happens even in United States. A very good friend of ours, she was rather a gynecologist, obstetrician, and there were so many lawsuits, even minor things, and insurance companies were there, of course, to pay. But her premium went up to almost $150,000 a year, $150,000 a year in premium alone because of this increased numbers of lawsuits. She had to leave her profession and became a lecturer because she could not afford to pay. Even if you make $400,000 a year and you're in a 40% bracket, there goes your $160,000 minus this $120,000. What becomes of that? It's better to work as a lecturer a few hours in a week and make similar amount or lesser amount, and still you come ahead. This is a financial aspect of it where you are taking a blunt at a financial level. But here, especially in third world countries where lives of doctors are at stake if they make mistake or somehow, even without making mistakes, patient had to die for whatever reason. And the relatives and friends of that, patient takes action against doctors, unfortunate action where becomes a victim. They kill them. Anything can be done? I don't think so. I don't think anyone is prepared to face such a situation. Neither a doctor, nor the administration, nor even the police staff. So even if you keep half a dozen police, somehow this vendetta will spill over outside the hospital when you're going home, which is very unfortunate, sir. And I'm sorry, I don't have a right answer to give you that can satisfy that what if commission and omission results in such violence. Is there anything to protect ourselves? I don't think so. You have to prepare and become defensive somehow. I take it for granted that surgically all the procedures were done properly, and despite of that, when the relatives take violence into their hands, it's not in your hands, it's not in our hands. And when such thing happens, you know well that it's dangerous to go outside. Protect yourself.
Now,
But how long?
Yeah, I understand what you're saying. Now, if the media which takes up these stories and they put it up on the television saying that this patient was killed by this doctor's negligence without knowing the truth, what should we or the doctor do at that time? He feels bad that his name as this obstetrician or whoever it was in US, your friend, how should they react? Should we ignore or should we feel bad that the whole world is listening to the story of this journalist who is, sometimes being bribed or sometimes out of not checking up the story, putting it up on the national television? What do you think? Should we ignore that and carry on with our lives?
I don't think so. I don't think you should ignore it. And it cannot be ignored. But what else can be done? You see, these days, as you correctly say, there are many journalists for the hot news, they say, that will make them famous. They're looking for some stories. This is the danger in our country, especially, where journalists are taking not only the doctors, but other politicians, other spiritual leaders also at ransom. That if you don't do this, it is this. Under the circumstances, what can you do is administration of the hospital should become very strong and proactive and send out a defense message that whatever has happened and say the truth. People will understand. And people these days also understand that the journalist is cooking up stories.
Raji, I want to take you into a different direction now.
Yes, sir.
Now, we all were brought up with deep religious roots. We have somehow not as religious in that sense, you know what I'm saying, as our parents, perhaps our grandparents were more religious. Today we have become more materialistic. Now, I hear from people that this running after positions is bad. Is it wrong to have a good car, a good house, a good life? Is it a sin? Why is making money associated to be a sin nowadays? Is it jealousy or envy of the people?
I think Indian people, by and large, or most religious people throughout the world, are hypocrites. If Buddha had to declare after Nirvana and fall at the feet of Yasoda, begging for forgiveness, forgive me, I left you. I could have attained this Nirvana even in a palace. It says a lot. It speaks a volume that we need not leave our house in search of God realization. Our bhautik jivan, material life, and spiritual life can go together without any incompatibility. There is no incompatibility between a godly way and a materialistic way. If I am earning with honest means, it is in tune with my divine purpose. When spiritual life and material life at crossroad, it creates a lot of problems, ethical problems, and that creates a lot of guilt. Best would be to integrate my spiritual life. As I was saying you earlier, when I am with my consciousness 24 hours in meditative state, am I not surpassing even my great grandfather in their approach religiously? After all, what did they do? I watched my father from my early childhood. He would wake up at 4. He will do his puja in the house. We had a small little corner in our house where he would offer puja. After finishing that puja, he would go to the temple and do puja all over again over there. And I would always go along with him to the temple as a child. Come home, again the same thing in the evening. Some arati and some, puja, deepam and bhajan kirtan. Before going to sleep, again there will be some prayers. So these things were going on. Is there anything more we could have done? You see, God's approach is never enough. Even 24 hours are not enough. But when we do this with the wrong understanding, that creates the problem. When we say God is Antaryamin, Ishwar Antaryamin, God is omnipresent, He is everywhere. If you argue on this two itself, we fall flat. When we say God is Antaryami, meaning He is within, but we start looking for Him outside. That is religious approach. So there is mismatch between our philosophy and practicality. When we say He is omnipresent, why should I go anywhere? It is not that I'm against temples and holy places. I am not. But we are applying this futuristic spiritual condition in the present, something that I would feel at the end of my career, of spiritual career, that I experience God everywhere. That is the culmination of it. Not only everywhere, but at all times, in everything that I see. But prematurely, if I start doing this and say, I feel the presence of God here, or let me worship this here, let me worship that over there, I start worshiping everything before time, then it's a problem. See? Religions are great if we understand the principles very well. All religions, they say, God is great. God knows everything. But we continue to do a lot of things which are against the religious principles, despite of knowing the fact that He is all-knower. So we go against the theory in our practical life. Spirituality is all about feeling the presence in ourselves and actually trying to honor that Antaryami within ourselves. And that's where meditation helps. Even in Gita, people read Gita but don't understand Gita too well. At the end, Lord Krishna shows Vishwarup to Arjuna and say, look, this is me. This is my form, which I have not shown to anyone, but you only am showing it. You are my friend. At the end of it, Arjuna asks Lord Krishna that, being my friend, you have shown me, I'm very thankful to you. But what others can do, what common people can do, how can they understand you and enjoy your beauty, your form, your divine presence? Then Lord Krishna tells one simple thing to him, that in order to perceive me, in order to feel my presence, look myself in your heart. It's a simple prescription. But we have always looked for him outside, which is unfortunate. We don't even take his advice seriously, but we go on reading without understanding. Then it's a problem, see. And all of us, without exception, we follow religion because what if I don't? This question arises in our hearts. What if I don't do this, or what if I don't do that? There is a fear. And there is also this hidden agenda in our heart that if I do this, maybe I might become eligible for better things from God. Maybe I might become eligible for heavens. Maybe I become eligible for more successes in life. So temptation and fear drives many religious beliefs.
Ajay, I want to ask you this now that we have come to this topic of religion. Coming to this religion, now you think, as somebody said in India some time ago, now the generation today, the generations that are going to come in future, they're all may not be interested in this heaven and hell business. They're interested today in my laptop, in my computer, in my clothes, in my watch. And would these religions exist if this is the way people are going to think after 50, 70, 100 years? Would not be people more interested in now and here than do something good and worry about this heaven, which nobody knows if it exists or not. And I don't think anybody has ever seen God as they claim to be, some people. And
You're
very
right.
clever, they say that see God in yourself.
No, it's very, you have raised the right question. Apparently there is a group, there are groups of children today, youth. Some are so focused and sincere about the truth, the reality. Why are we? What are we? How are we to proceed towards this? What is the truth behind our existence? There is some minority of youth who are pursuing this in a very serious way. We have a lot of youth coming to us with these fundamental questions. And there's another part of the youth whom I call a bit lost, however temporarily, but they will, I think, make their way as they learn their lessons in life. Okay. When they say, when a question arises, I don't believe in God, I think is fundamentally, it's a right question. I don't believe in God because, I just say, I don't see it. But God is not a thing to be seen. God can be experienced only. There is no other way. Moment you bring God and bring him into a form, how would you recognize? Someone asked my Guruji, can you show me God? His answer was very profound. He said, suppose if I show you God, how will you know it's God? Isn't it? Yes. So, and second thing, you ask any elderly person today, your grandmother or mother or, do you believe in God? And immediately see what answer would she give you? Perhaps she might even slap you even though you are grown up. Why are you asking me such a question? Don't you think I believe in God? When you ask such a question, they think you are attacking them. But they get angry because they have no answer why they believe in God. They really have no profound or real answer behind their belief. At the most, they would say, I believe because my mother taught me. I believe because my father taught me. I believe because our religion says so, our books, our sastras say so. So I believe. So my belief is always on the outside because of. But what about you? What do you say about it? Then they keep zero, zap. See, one day I was discussing these things with my father one evening, sometime in 1977. And I asked my father, "You've been doing all this for years and years, and as much as I notice. Can you tell me the best experience that you ever had with these worships that I can share with your grandchildren?" Of course, at that time I was not married. But I put the question like that, that something that I like to share from, what you said me today, I will share it with your grandchildren, your best experience. They kept on thinking, he kept on scratching his head also and said, Kamlesh, I don't know. I just do it. It makes me feel good. It makes me feel as if I have done my duty. I said, towards whom? God is not asking you to do this or that. Why are you doing this? Have you felt anything out of it? Have you become anything after doing all these things? He said, no. I said, then would you like to experience the presence of something very profound in yourself? I said, yes. So I took him to one of the trainers nearby our village, and he sat in meditation. Simple form of meditation, the way you all do. Close your eyes and be receptive towards this incoming transmission with the thought that, my heart is being illuminated with divine presence, with divine light. That's all. And when the work was done on him by the trainer, this through yogic transmission, at the end of meditation, he started crying like a child. I was witness to it, see. And he said, I wasted my life. I said, how so? He said, something that I had been wondering to experience. It has come through today in the very first session. I said, look, you should not feel bad that you wasted. You should not feel like that you wasted your time. All those things have prepared you for this moment. It is not that religion is bad. Religion prepares us. But we should always be open for spiritual experience. See? All these murtis, nothing wrong with it. They are akar. It gives us a direction that move in this direction. But these akar are human-made. Like when this Mahabharat movie has spoiled my imagination of Lord Krishna, because each time I think of Lord Krishna, this actor comes in my mind who played the role of Lord Krishna.
Yes.
You see, and many a times, even Ramayana or even Mother Sita would come in the form of that actress.
Yes.
Now, is that real? No. And we keep on creating images or photographs of these lords. In the images portrayed by these cinemas. Similarly, the artist imagination through a murti. But when I encounter godly presence in my heart, it will not be through any form, because divine presence is always beyond forms. They say we go beyond akar into nirakar, and still further, we transcend all these things. So I think there is a beauty behind all these things, you see. Though religion gives us a direction, we should not stop there. We should try to go further, venture. As they say, it's an inner spiritual adventure in proceeding towards unknown.
Sir, I want to ask you this. Why the hell
Sure.
have the generations of Hindus and perhaps other religions too hammered with this fear of hell? That you do this, you go to hell. You do this, you go to hell. You do this, you go to hell. And then you need millions of births, I believe, to reach heaven. Now, how do these people know?
Sir, this is See, all the religions start with good intentions. In Vedic times, there were no temples. Moment you have a temple, you have to have Mathadikari, a priest. And there will be competition of priests. Because each one will be just sitting there and making money morning and evening, day after day. And more gods and goddesses you create, you're creating more avenues of income. You worship this, you worship that, you worship this graha, you worship that graha, and you want to remove this particular problem. For everything, there are fees. God doesn't need all that. See, what will God do? It's not God's sake. It is for the sake of the priest. So people have to understand that. But what kind of common man understand? You were just talking about when a patient dies accidentally or naturally in a hospital. There are times when they take matters into their hands and become violent. The same group of people are so greedy that, oh, it's okay, let me invest 100 rupees with this temple or with this priest. Maybe I'll get something much more.
Do you think we should give importance to the Vastu that has now gone into every cell of every Indian? Most definitely so in Hyderabad, everybody talks about Vastu. Then suddenly I realized that people are telling me that today is this day, today is Rahu Kalam from 11 to 12. Sir, don't do surgery at this time, give anesthesia after 12, we'll shift the patient. Every building in Hyderabad looks in a different direction because of Vastu. Should we, as people, believe in this Vastu with the direction of the house, with the auspicious dates and not so auspicious dates? What do you tell us as doctors? What should we do?
I think you have posed many questions that itself can have a separate session, but I'll be brief as possible. You know, this research on autophagy, fasting,
yes,
and intermittent fasting, it's taking a new trend now.
Yes.
Intermittent fasting or autophagy was quite rampant in India. Once a week or twice a week or once a month or twice a month, they would fast. And this fasting was associated with religion so that people would observe their diet properly. Because fasting truly does help our human system to fine-tune once again to the normal rhythm. But it should not be overdone, see. Just as we say, Gyaras, they call it, or 11th day of the moon cycle, Ekadashi. A lot of people fast on that day. And you're a doctor, man. That lunatic word comes from the effect of the moon. So astrologically speaking, all these astral bodies, they do have impact on our human system. But it was tied with religion so that people would follow those rituals without fail, because that fear was instilled. But the main reason to fast on Ekadashi is to improve your health. Anyway, there's a big science behind the whole thing. So what we understand, the circadian rhythm, how physiological functions change during day and night time, and how early morning hormones also change drastically. We'll reserve this topic for later, but about Vastu. Vastu is nothing but choice of direction of various functions of the house or the house itself. For example, where should the kitchen be? Where should the main landlord, the main person of the house should occupy the room? Where should the children be sleeping? Where should the puja room be? This is a Vastu thing. It is also to a large extent scientific, but made more complex also. Now, in Northern Hemisphere, the rules of Vastu are different from the Southern Hemisphere. I give you one example. What happens during winter? Winter times, all throughout India, especially, the wind flows from northeast. You must have noticed just a week before, the northeast, the wind have started flowing in Hyderabad. It has started. Moment this start, now what happens as winter proceeds? Dryness increases tremendously in winter months because northeastern winds come. And from the north wind, because there is no water like ocean bodies, the humidity level is very low in the winter months. So they say you should have a water body on the northeast side. So as the wind comes, it takes humidity with the wind, and enters the house. It keeps the air moist. So it's a health reason. Why should the main household of the house should be on the southwest side of the bedroom? Bedroom of the main person should be in the southwest corner. Why? It is because it is the hottest spot in the house. Meaning my children and my other relatives should be more comfortable. I can be in the hot place, but others should be in a cooler place. That is the logic behind it. But now with the air conditioning and availability of humidifiers, do you think all this is required? If you can adjust, then you can understand that I need not follow the Vastu. If you follow the natural rhythm, it will be required. When we have a puja room in the northeast side, because it is the coolest place, where you see when you enter the coolest place in a house, India by and large being a tropical country with its hot temperature, you feel kind of comfortable entering such cool room. Those days the ACs were not there. So when you enter the cool room, you feel internally drawn and you feel comfortable and drawn towards that moment. Okay, let me spend more time there, where you find more comfort. So you see, it's mainly related to our comfort and health.
Right. Now, just a couple of more questions before I know it's time for is getting over. But when we're in the house, we get a ring from the hospital. And the first reaction is, what happened to my patient? This, I've asked lots of doctors. Suddenly we get a call. So how do we prevent these negative thoughts? So especially when we get these calls and all that, so the mind, is meditation one of the methods to have good positive thoughts and reduce our negative thoughts about patients, about our life in general? Or is there any easier way for us other than meditation? Why am I asking this? Because as I said, we spend 12, 13 hours in the hospitals, all of us, and then we come home and next morning we get up, we get hardly an hour's time for exercise, to play a game, sport or walk. This meditation is an extra time. And a lot of doctors and my friends that I know feel that it is so difficult to practice meditation. But now I understood what you're saying about making work as meditation. Now I got the message from you very clearly today. And I'm so glad that this session, I myself am engaged in what you have told me today. And I'm sure my colleagues will understand. I want to know from you how to reduce or remove negative thoughts from our minds. This is extremely important to our community.
Well, I tell you from my personal experience, to me, it's a very good sign that when a phone call comes from your workplace asking, doctor, what to do? This patient is going through this. And your worry comes up, oh, wow, what happened? Tell me what happened. It's a very good sign that you do care for your patients. But I have to also understand as a physician that I should not get panicked. I should remain balanced and calm while listening because I am at home. I can do whatever I can from here. If need be, I'm willing to go and look after or instruct the next step to the another caregiver in the hospital. That's the best I can do. But it's a very good sign that whenever a phone call comes and your heart misses a bit and say, oh, what must have happened? I think it shows a quality of a physician that yes, he does care for someone. And I must congratulate such doctors who loses a bit of a heart when get a phone call from a hospital. It's okay. But please don't be nervous because you can do nothing about it from where you are. Listen carefully and do whatever you can do in the best possible way. Advise the listener on the other side in the hospital what to do next. And if need be, always say, I'm willing to come. But there is nothing more than that can be done. See? So meditation, I think it does help in making us focused. There's a focused listening, focused responding, focused action. At the same time, you're calm, you're peaceful. And doesn't matter what happens around, but you will always remain calm. And when you are calm, you are able to make a good decision actually, without worries and anxieties, because deep in your heart, you know you could do only so much.
Sir, I want to ask you one last question before I take the final message from you. I know I have just exceeded the time. Should I worry about the way I dress, what people think about me, what others are thinking about my life, the way I dress, the way I speak? Or how much should I give importance to that? Or should I live my life the way I want to live my life?
Well, there are two things I will share with you today. There is it's a kind of a jovial statement that there is nothing wrong with the weather. Especially in US, they say this, there is nothing wrong with the weather. It's that you are not properly dressed. If you are shivering, because nothing wrong with the weather outside, you didn't wear the right clothes. Second thing, I once happened to visit one very wealthy person in New York, very wealthy. I was recommended to see him. And as he welcomes me with his cigar, and makes me enter his chambers, said, "Welcome, my son. I've been waiting for you." He was a Jewish gentleman. And I was very happy that a Jewish person welcoming an Indian with so much of warmness in his heart. He makes me sit and said, "Welcome, my son." That moved my heart so much. He must have been 65, 70, and I was in 25 or so. And he was one of the Holocaust survivors, where Jewish people were sent to chambers. He escaped. He was a child of 10 or 11 years of age. He escaped from that place along with his friends and came to New York. That softened his heart so much. Anyway, afterward, he told me, because I just went like an Indian, pant and shirt and nothing. I didn't take any flowers, or I didn't take any gift. I just went. He's calling me, so I went there as a pharmacist. And he gave me a beautiful advice. He said, whenever you visit an elder, you must wear a tie.
Wear a tie.
Wear a tie and go. I said, why so? He says, it's not for yourself. It is not that you want to look good. It's good. It makes you look good, no doubt. But it shows respect for the other person, that you do care. That I am in the presence of such an auspicious person, such a good man, that I show my respect by dressing well. So there are many reasons why we dress well, dress appropriately for the occasions. And when you go to a temple, you have to wear accordingly. When you do your yoga, you wear accordingly. When you go to night sleep, you wear accordingly, you see. So I think, and based on weather, we have to wear accordingly. See. It's mainly for our comfort and also to show respect to others. And this is one way of showing respect to others when you dress properly, especially in the Western world. And nowadays in India also, when you, like yourself, you see, you're wearing a tie, and it shows that you respect your audience. You had a choice of sitting there in a t-shirt, but that would not present yourself and respect others at the same time. See? So it's, I think dress does matter tremendously, actually.
And how much importance should I give about what people think about me?
Well, if you worry about that, you will not lead your life peacefully. I think, does your heart agree with it? You do it. And more meditation we do.
Ladies and gentlemen, I hope you enjoyed this session. This certainly is one of the most memorable days for this great soul, as I said before, to address us. It's not that easy for us to approach and for him to agree. But the day I requested him, he agreed to be our chief guest. But that would be, I'm sure, for another day and another occasion of Oasis. Spirituality is a different subject. Like orthopedics, it requires a different mindset, dedication, and above all, a burning desire inside to know this Almighty, the true nature of us, to lead meaningful lives, and all that. For that, we have to go there. Like in any field, we have to apprentice, and then that's the way. That's what I feel. However, as Daji said, let's become spiritual in the work that we do. Let's be honest to our patients. Let's be honest to ourselves. Let never in our life do a wrong surgery for financial gain. Never. Knowingly. Unknowingly, we are human beings. Sometimes we do things perhaps not to be done. But doing knowingly any wrong to any human being as doctors is the biggest sin. Nothing else is a sin. And this is my personal view. With the time slot given of 1 hour just exceeded, we have to go back to our scientific sessions. And that starts off with the free papers. Just 30 seconds to Dr. Ved Prakash, because he is one among us who is into this path. Dr. Ved Prakash, just 30 seconds, please.
Yes.
Yeah, we can hear you. Just 30 seconds.
Yes, you already said most of the things. Only one thing which needs to be stressed is this. For all, are you able to hear me?
Yes, very well. Please go ahead. Time is up.
Yes. The time is up in the sense that the only thing I would like to say that we are in this world because of some grace.
Right.
And because of that grace, we are what we are. And for that, you have got to be ever grateful to your parents, the people around, the patients, and the whatever things are around, including the weather, as you said. But you are not an individual doing things on your own. You are being made to do this. And this is because you have earned in your earlier lives. So that's why you are a special person in this life to be given this job to do. So please dedicate it to the power which is inside your heart, which has made you come and do all these things. Always dedicate your work so that you can never go wrong. Because whatever you offer to in the puja, nothing bad should go there. So when you are meditating, you are dedicating everything which we have done in the day to that Lord.
Thank you very much, Dr. Prakash. I really appreciate. I think that sums up. I think we should be grateful to what we are. This is exactly what Professor Shantaram Shetty said in Mangalore in one of the speeches that he gave. We are so fortunate in this life to be doctors, to be orthopedic surgeons, to be revered by the society by and large. By and large, we certainly will rededicate ourselves. And as the current president of Orthopedic Association of South Indian States, I urge every one of you to rededicate yourself to our field of orthopedics and to help our patients and to take this country to a much bigger or higher level. We will do that, and I'm sure the youngsters are far more intelligent than us. They understand what we are saying, and the future of this country, I'm sure, is much safer in these youngsters. Thank you very much. All good things must come to an end. I always say that. So we move on to the scientific committee to take over. Dr. KJ Reddy and Dr. MB Reddy to start the proceedings. Thank you once again.
Good afternoon. Good afternoon. Dr. Shuklingam here.
Chukulingam.
Yes, Dr. Shuklingam from Trichy.
Dr. Aneen and Kuti.
Hi. Nice seeing you here. So we are chairing the session.
Okay. Are they ready with the presentations?
Yes, sir.
Play?
So we are waiting. So it's a new experience, all these webinars and getting things in time.
They are doing a good job.
Yeah, I know. They're doing an extremely good job. I think we are running much better than a real-time meeting.
You are talking from where?
Good morning. My name is Dr. Arun Joy. I am a postgraduate in orthopedics at Government General Hospital, Vijayawada. My topic is microbiological profiles of infection after fracture fixation. My mentor is Dr. C. Shyamkumar, who is Professor of Orthopedics at Government General Hospital, Vijayawada. Introduction. Surgical site infection in orthopedic implants is a major problem. It increases the chance of implant failure, osteomyelitis, systemic disease, and even death. It also strains the healthcare system of a resource-poor country, and it is characterized by erythema, swelling, pain, and discharge from wound site. It is complicated by the presence of a biofilm on the implant surface. Antibiotics cannot penetrate the biofilm to reach the bacteria, thus prolonging the infection. Staph aureus and E. coli are the most common bacteria causing implant infection. Resistance to antibiotics is very common in these organisms. Aims and objectives: to determine the microbiological profile of infections following fracture surgery in our hospital, and to analyze the detected organisms in terms of variety of organisms, frequently affected sites and implants, and their sensitivity to antibiotics. Materials and methods. The study was conducted in the Department of Orthopedics at Government Siddhartha Medical College during the period from May 2018 to March 2020. The patients who had undergone fracture surgeries who later developed signs and symptoms of implant-related infections were included in the study. Patients who were treated for open fractures and comorbidities were also included in the study. Study subjects were diagnosed and operated for their various fractures following proper surgical guidelines. Informed consent was obtained from the patients about the study. They were discharged after routine postoperative care, which included IV antibiotics for 72 hours in open fractures and 24 hours in closed fractures. Regular wound dressing and early mobilization was also done. If open fractures with large skin and soft tissue defects were encountered, they were referred to the plastic surgery department after initial wound debridement and fracture fixation. Regular postoperative follow-up was done. Infected cases were identified. Antibiotics, if any, were stopped for 72 hours, and pus was collected from deep inside the wound and sent for culture and sensitivity to microbiology laboratory. Empirical antibiotics were prescribed until culture results were available. The results of culture were compiled into the study. Data regarding patient age, sex, site, and type of fracture, implant used, and comorbidities were collected. In early and intermediate infections, the implants were left in place after suppressive antibiotic therapy to allow for fracture healing. If suppressive antibiotics were ineffective, wound exploration and debridement was done and implant was left in place. Early infection means infection occurring less than 2 weeks after surgery, and intermediate infections occur 2 to 10 weeks after surgery. In late infections, if fracture healing was confirmed, the infected implant was removed and sent for microbiological analysis in a separate procedure. Late infections mean infections after 10 weeks of surgery. The infected implants and pus samples were analyzed by microbiologists, and statistical analysis of the infecting organisms were done in terms of percentage and frequency. Results. A total of 50 patients with fractures of long bones and who showed signs of implant-associated infection were included in the study. Mean age of the patients was 50.02, ranging from 16 to 85 years. Implants were removed in 30 patients, while the rest received antibiotics and bone debridement. Among the total 50 patients who were investigated in the present study, 42 or 84% had positive cultures, while in 8, the cultures were negative. The sole organism identified was Staphylococcus aureus. 38 were MRSA, while 4 were MSSA. No anaerobes were isolated. Microbiology of the organisms isolated. All the organisms isolated were Staph aureus. 38 were MRSA, while 4 were MSSA. 8 were sterile cultures. The affected sites in decreasing order were the tibial shaft, 40% of the cases, followed by femur with 14% of the cases, followed by medial malleolus, knee, ulnar shaft, lateral malleolus, radius shaft, and olecranon. Tibia interlocking nail was a predominant implant type affected by infection. There was a male preponderance. 84% of the cases were male with an average age of 40.60 years, and 16% were females with an average age of 55.75 years. 28 patients had comorbidities. Age in relation to onset of symptoms. In age less than 30 years, we can see that delayed infections are most common. In 30 to 50 years, we can see that late infections are common, and in greater than 50 years also, late infections are the most common. Sex in relation to onset of symptoms. In both male and female sex, late infections are the most common. This shows the site and fracture type in relation to onset of symptoms. We can see that tibia is the most commonly affected site of implant infections. Open fractures are more commonly associated with early infections, we can see here. And all other fracture types are associated with late infections. Implant type in relation to onset of infection. The most commonly affected implant is tibia interlocking nail. And in all types of implants, we can see that late infections are the most common. Comorbidities in relation to onset of infection. The most common comorbidity is diabetes, followed by hypertension. We can also see malnutrition, obesity, UTI, and anemia. And in all cases where comorbidities were present, we can see that late infections are the most common. This table shows the antibiotic sensitivity profile of isolated Staph aureus specimens. Out of the 4 MSSA specimens, which were all resistant to ampicillin, and 3 of them resistant to ciprofloxacin. The remainder were resistant to all the commonly used hospital antibiotics. Out of the 38 MRSA cases, we can see that all of them were resistant to ampicillin, and all of them were resistant to cefoxitin and methicillin, as expected. However, a large number of them were resistant to ciprofloxacin and cefuroxime. This pattern of resistance suggests that this MRSA is probably hospital-acquired and not community-acquired. All of them were sensitive to linezolid and vancomycin, however. Discussion. Based on Willinger and Roth classification, 16% had early, 24% had delayed, and 60% had late infections. There was an increase in the infection rate after 10 weeks. Out of 50 cases which were studied, 17 or 34% were open fractures with extensive tissue damage, which may have contributed to the infections. These patients had an early onset of infection compared to those with closed fractures. Hypertension, diabetes, immunosuppression, malnutrition, and obesity were the other risk factors seen. The relation between comorbidities and the onset of infection have been highlighted in Table 6. In the present study, Staph aureus was a sole isolate. 38 were MRSA, while 4 were MSSA. The present findings correlate with the findings of a study by Posterior et al., who reported Staph aureus as the most prevalent isolate. No anaerobe was isolated. The profile of antibiotic resistance in identified MRSA specimens suggests hospital-acquired MRSA. Unfortunately, facility for genetic analysis to confirm this is unavailable in our hospital. As Staphylococcus showed sensitivity to vancomycin, a regime involving vancomycin can be suggested for infections following fracture fixation. Staph aureus in biofilm can be effectively treated by rifamycin and rifamycin due to more penetration of these drugs into biofilm, while fluoroquinolones may be used for gram-negative bacilli. The treatment of infections following fracture surgeries usually includes long-term antimicrobial treatments and the removal of the implants with the debridement of infected bone and soft tissue. In our study, implant removal was carried out in 60% of the cases, while the rest of the patients were treated with IV antibiotics and serial bone debridement. Recent evidence indicates that a subset of patients can be successfully treated by debridement and long-term antimicrobial therapy while retaining the implant. The suggested criteria for such patients are an acute infection with its signs and symptoms lasting for 14 to 28 days, an unambiguous diagnosis which is based on the histopathology and microbiology, a stable implant and a good quality of bone stock, and the susceptibility of the microorganism to an effective orally available antimicrobial agent. So in conclusion, Staphylococcus species are the commonest isolates, and their ability to produce biofilms stresses the need for an appropriate antibiotic policy to be put in place to eradicate the infection. Hospital disinfection policies should be reviewed to reduce the infection rates. These are my references. Thank you.
Discussion now. Are we having a discussion now?
Yes.
Is the presenter available for answering questions?
Yes, sir. I'm available, sir.
Okay. Can I ask a question, Dr. Choklingham Trichy?
Yes,
you mentioned the MRSA in 38, which is a quite a high number proportionate to hospital-acquired infection in general. What steps have you taken in the hospital following your study to reduce this MRSA infection?
So we have considered improving our disinfection policies, sir. Hospital disinfection policies, and to implement a better antibiotic regimen, which includes possible vancomycin and linezolid in case of established infections, sir.
Have you screened your staff and people who are assisting and all those people for the MRSA?
Actually,
carriers are a major problem for MRSA.
Actually, in view of COVID, we have not conducted surgeries for the past 8 months, sir. So, as this surgical activity has stopped completely, we are unable to proceed with the screening and other activities. But as soon as we start surgeries, we will be doing this, sir.
The second question, doctor, the proportion of open fractures who are getting infected versus closed fractures who are getting infected. In your study, the closed fracture incidence of infection is fairly high compared to or accepted level. Do you have any answers for this question?
Yes, sir.
Because only 38% of your infections are open fractures, 62% are closed fractures. Is that right?
No, sir. 60% are. Yes, sir. You're right, sir.
So I remember your slide very well. So it's around 60% of the closed fractures having infection. What is the total percentage, number of cases you have done in this period?
Percent of infections.
Okay, doctor.
Total number of operations.
Yeah, 50 cases you identified infections. What I wanted to know, the total number of surgeries performed during this period, so that we know the real percentage of infections, your closed fractures incidents. It's okay, doctor.
Close to 2,300 surgeries, sir.
How much, sir? How much, doctor?
Around 2,300, sir, if I remember correctly.
Okay, doctor. Thank you. Thank you.
One more thing. Do you have a sterilizer indicator used in your sterilization unit for the implants? Or you think about that? Because implant surgeries, the implant can even be infected. That is a major number of that should be taken into consideration.
Yes, sir. This will be considered, sir.
Can I ask a question?
Yes, sir. Please.
Have you got a air clean theater, first of all? Being an institution, have you got an air clean theater? Do you know what is the air clean theater?
I'm not familiar, sir.
Not familiar. Okay, thank you.
Okay, shall we move to the next presenter?
We are on time.
Okay, the next talk is by Dr. Puneet Pai, timing of debridement of open tibial fractures during COVID-19 lockdown in India.
My name is Dr. Puneet. I am working as a senior resident in Government Medical College, Kozhikode. And the title of my study is Timing of Debridement of Open.
Hello, sir. Am I audible?
You're audible, doctor.
Yes, sir. Thank you. Yes.
Hello, everyone. My name is Dr. Puneet. I am working as a senior resident in Government Medical College, Kozhikode. And the title of my study is Timing of Debridement of Open tibial fractures during COVID-19 lockdown. Whenever there is a crisis or a challenge or a unique situation, always new questions are raised, and we need to find solution to such questions. That is how medical science advances. COVID-19 pandemic is one such crisis. New challenges are being brought up in orthopedic practice. Management of emergency as well as elective procedures needs a new protocol. The COVID challenge has been mainly in the terms of resources, the manpower, material, and time. Time determined by the time required to do the COVID testing includes rapid antigen, TrueNAT, and the RT-PCR. RT-PCR is the most preferred testing as it has higher sensitivity, 67%, and 100% specificity. But the time required for this is around 6 to 8 hours, and depending on the number of samples, it might take up to 1 day. In our institution, we prefer RT-PCR over TrueNAT. Coming on to open tibial fractures, they are the most common open long bone fractures. Incidence is around 3.4 per 1 lakh population. Tibial fractures are always difficult because they have deficient soft tissue coverage. There is higher chance of infection and the precarious blood supply. The treatment is by debridement, antibiotics, and stabilization. 6-hour golden rule for debridement of open fractures and open tibial fractures in particular have been followed historically, and the early debridement would need sterilized implants, proper staff, and presence of adequate healthcare workers. So in case of COVID-19 challenge, there is always staff shortage as there is shunting of the staff towards the management of COVID positive patients, and those which are in the OT are at higher risk if the patients have not been tested for RT-PCR. So this has brought the new questions that as to what is the exact emergency in orthopedics, what is the time which can be spared for doing a delayed debridement, and what is the role of patient selection. So our aim of the study was to analyze open tibial fractures, its outcome depending on the time of debridement at 5 months duration. We divided the patients into 3 groups: less than 6 hours, 6 to 12 hours, and more than 12 hours. And we observed their infection and union rates. Methodology: it was a cross-sectional study. Sampling method was convenience sampling. Duration was 54 days of the lockdown starting from 25th March and conducted at our government medical college, a tertiary care trauma center in Kerala. So we started with around 297 patients were considered, out of which 244 patients were excluded depending on the presence of a vascular injury, or if they were amputated early on, or if it was a polytrauma, having other surgical injuries, or if they had uncontrolled comorbidities, if the patients were pediatric, and if they had any other psychiatric illnesses. After this, we actually found 34 patients were suitable for our study, but 2 patients were actually lost to follow-up at the 3 months post-op, so they were excluded, and we were left with 32 patients. The management of all these patients were done with Rehabilitation Protocol. IV antibiotics was given in less than 3 hours of trauma or 1 hour of arrival. Debridement was done under anesthesia, either general or spinal, and low pressure saline irrigation was given for all these patients. Investigations were conducted, and especially importance was given to ESR and CRP. For all cases, plastic surgeon was there on call, and the follow-up was done weekly until healing, monthly until union, and clinical and laboratory adjuncts were used. In case of infection, serial pus cultures and antibiotics were used, and repeat debridements were done. Data entry was done in Excel, and analysis by SPSS 19. Outcomes at 5 months were observed. Descriptive analysis was done, that is average time to debridement, distribution of fracture type, the percentage of union was all done. Hypothesis testing was done using a ANOVA with 3 different groups, less than 6, 6 to 12, and more than 12, at statistical significance of p-value less than 0.05. Moving on to the results, we considered 32 patients with unilateral open tibial fractures. Average age was 36.81 years. Most of the patients are male, probably due to young healthy males being out for essential services and daily needs during this lockdown period. And most common type of injury was motor vehicular accident. Time to debridement. The average time to debridement was 5 hours, and majority were presented at referral center within 12 hours. And around 13% of the patients, or 4 patients, came after 12 hours, but within 3 days of the incident, and all of them had deep infection and non-union at the end of 5 months. Open fracture distribution. Most common type of fracture in ours was type 3A and B, and the least common was type 1. Time outcome was one test actually showed that union rates in those debrided less than 12 hours was actually having p-value of 0.005. Those having more than 12 hours had higher degree of infection, which was statistically significant, 0.015. Fracture type 3 were having poor outcome with the poor union rates with the p-value 0.0321. Around 72% of the patients had achieved union at 5 months, and 70% of the patient who had non-union had superficial or deep infection and required repeated debridement. There was no relation between early infection and union. On bivariate analysis, the union rates did not differ with age, sex, type of stabilization, and number of comorbidities. So coming on to the discussion, most guidelines in 2017 actually told that debridement timing for high velocity should be less than 12 hours, and for low velocity it may be up to 24 hours. In our study, majority of the mechanism of injury was road traffic accident, with no significant difference between those debrided less than 6 hours and more than 6 to 12 hours. However, the analysis of less than 12 hours and more than 12 hours showed that there is significant difference, especially among type 3 open fractures. This suggests that 12 hours may be a better cutoff point, as less than 6 hours might not be realistically possible when you are doing a RT-PCR for this COVID pandemic situation. Moving on to infection, in our case, actually the infection rate was a little bit higher. Type 1 were having 20% infection, 25% in type 2 and 33% in type 3. This could be due to the number of type 1 patients being small in number, and the sample size might be not adequate. In literature, actually, the fracture infection risk was more in type 3, 10 to 50% in one study, while in other study it could be around 22%. So for type 3 fractures, ours was almost correlating with the other literature findings. Snecker et al. In 2012 did a meta-analysis, and he found that there was no association between late surgical debridement and higher infection rates. Elmsky in 2020 did a 9 retrospective and 6 prospective study, and he also found that there was no significant correlation between early and late debridement. Antibiotics, actually, Patsakis and Wilkes review, that was around 1,000 open fractures reviewed. He found that the single most important factor in reducing the infection rate was the early administration of antibiotics. In our study, we have actually given antibiotics to all patients who were included within 3 hours and within 1 hour of arrival into our institution. Conclusion: open fractures are time-dependent management and should be considered as orthopedic emergency, but the time at which debridement may be done should be realistically considered. Type 3 open fractures need early transfer to the trauma centers and early administration of IV antibiotics, which will actually reduce the risk of infection. Timing of debridement might not be an independent determinant of early outcome in open fractures.
Okay, Dr. Chokiling, yeah, please. We'll have the discussion now.
Doctor, can I ask a question?
Yes, sir.
You have total of 32 patients.
Yes, sir.
And you separated them into 2 groups, less than 12 and more than 12.
Yes, sir. Actually, into 3 groups, sir. Initially, we did less than 6 hours, 6 to 12 and more than 12 hours.
Okay. And what have you had a discussion with the statistician on the sample size for you to make conclusions? Because you are making conclusion that late debridement is okay in this present scenario, and maybe you are making a statement for the future beyond COVID times. So we really need to know whether the sample size is adequate and whether you had a statistician advice on that, because minimum sample size should be 30 in general, but when it comes to infection rate, the percentage wise, they will give you the value. What is the sample size? Have you had a discussion?
Yes, sir. The thing is, what the statistician told us, it should be around a minimum of 150 to 200 cases minimum should be there to give a conclusion. The thing is that this was a cross-sectional study done with the available data, sir. Actually, we did not intervene anything in the patient management. We just did the we took the hospital data which was available and we analyzed whatever was with us.
Okay, thank you.
Do you get the RT-PCR within 12 hours, Puneet?
Yes, sir. The thing is, sir, RT-PCR, it depends on the number of samples they have kept. I personally went to that lab where they do it. They at a time keep around 90 samples, and depending on the number of samples they have kept, the time will increase. So it is meaning dependent on the number of samples they at once they keep. But at night it might actually come faster compared to the day because the number of samples sent during the day is more.
Okay. And we go to the next.
Thank you, sir.
Thank you. Next is paper by Dr. Naveen Jairam. Timing of antibiotic and wound debridement. Does it matter in open fractures of long bones? Dr. Naveen.
Welcome to the delegates. Today I am going to present the topic on timing of antibiotic and wound debridement. Does it matter in the open fractures of long bones? Introduction. Open fractures are known to have a multitude of complications and implications on the decision regarding the management of fracture. Open fractures are considered a surgical emergency and treated accordingly. There are conflicting reports in the literature regarding the cutoff point for the time frame within which, if treated, will lead to the decrease in complication. Factors not under the control of physician. The demographic profile of the patient, nature of soft tissue and bony injury, physiological status of the patient, and comorbidities. Factors under the control of physician: time since injury, administration of antibiotics, time to debridement, temporary or definitive fixation, and soft tissue cover surgery. Aim to find out the primary outcome in terms of infection and non-union, to find out the secondary outcome in terms of bone grafting and soft tissue cover. Materials and methods. It is a retrospective study period from 2017 to 2019. Inclusion criteria: all the open fractures of long bones presented in emergency who were skeletally mature. Exclusion criteria: pathological fracture, surgically treated elsewhere before presentation, and skeletally immature patients. Treatment protocol: as per the standard open fracture management, patients were followed up at 6 weeks, 3 months, 6 months, 12 months interval radiologically by using REST criteria. Radiological data were retrieved using the PAC system. Surgical data and other relevant details were retrieved from the patient medical records. Statistical analysis: the outcome variables were occurrence of infection, procurement of bone grafting surgery, and union at the end of 12 months as per the right criteria. Continuous variables were patient age, the time between the injury and presentation, between injury and administration of antibiotics, between injury and debridement, between injury and wound closure, and the number of procedures before wound closure and rest or at the end of 6 months and 12 months. Categorical variables: gender, affected site involved in presence of bone loss and presence of comorbid conditions. Converting the continuous variables into categorical variables gave added a number to compare the groups depending on the outcome. Independent sample student t-test was used to compare the means of continuous variables. Chi-square test was used for comparing the categorical variables. Receiver operating characteristic curve was plotted for continuous variable having significance to find out the cutoff value. Statistical analysis done using SPSS software system. This is the receiver operator characteristic curve obtained in this study. You can see the multiple characters, multiple variables were compared with each other. There, Results. So total number of patients were 78, out of which we got 89 fractures. Out of 89 open fractures, 12 were lost to follow, so eliminated. So remaining 77 fractures were followed up. Out of 77, 8 ended up in amputation. So only 69 fractures we followed up in this study. We classified the fracture based on Gustello-Anderson classification system, and this is the outcome profile of the patients included in the study. So total 69 patients, out of which 15 patients got infected and 16 patients went into non-union. And highest number of infected and non-union rate you can see in the Gustello type 3B and 3C. Demographic profile: number of patients 66, out of which 62 were male and 4 were female. Mean age of presentation 40.38 plus or minus 16.40. Affected limb: right involved more than left. Fractures: single bone fracture, 2 open fracture, 3 open fracture. Out of 69 fractures, 50 were single, 8 fractures were double, and 1 fracture is fully. Bone schedule: as usual, lower limb is involved more than the upper limb. Treatment protocol: all the fractures were treated as per the nature of the fracture characteristics, including plating, screw, X-fix, nailing, and non-opnamia. High-grade injuries type 3B and 3C took significant number of procedures and time to achieve wound closure in comparison to low-grade injury. Time of presentation: if you see less than 6 hours, 72% presented within less than 6 hours, and 27% presented more than 6 hours. Antibiotic administration: 46.6% got the antibiotic before 6 hours and 53% after 6 hours. Debridement rate: less than 24 hours, almost 71% of people admitted and get debridement surgery within 24 hours. Wound cover: less than 5 days, you can see that is 65.2%. Discussion: open fractures are usually due to high energy trauma. Gustello-Anderson classification still hold good in classifying these injuries. This classification can predict the outcome and complications and hence has a prognostic value. Friedrich, with his classic study way back in 1898 on guinea pigs, set a rule of 6 hours beyond which bacterial multiplication will lead to critical infective load in the open wound. The rule has been endorsed by eminent orthopedic association until recently. It has been a dictum that open injuries are considered as a surgical emergencies and to be degraded arbitrarily within 6 to 8 hours so as to reduce the complications such as infection and non-union. However, these recommendations have been questioned by recent studies. Majority of our patients who sustained injury were due to RTA. Similarly, high-grade injuries received early antibiotics and debridement much earlier than the low-grade injuries. This also could be due to preferential treatment received by high-grade injury patients in the trauma triage and during allotment of emergency OT. On contrary to the expectation, cases which got infected and went into non-union had undergone wound debridement earlier than other fractures, suggesting that earlier wound debridement is not only the factor leading to better outcome. Hence, many authors have started questioning the 6-hour rule and to take up open surgical cases during unofficial hours to operation theatre, having tired and inexperienced medical personnel without proper surgical plan, leading to suboptimal debridement and fixation. With similar findings, we also are of opinion that it is better to embark on complex fractures during daytime when all the facilities and expertise with the surgeon's disposal. We observed that proportion of fractures which go for non-union at the end of 12 months increases as open fracture grading increases. Similarly, we observed that proportion of fracture going for infection also increases depending on the severity of the open injury grading. We observed that number of procedures which were needed before achieving soft tissue coverage significant prognostic factor for forthcoming infection non-union in a high-grade fracture despite early soft tissue cover. Based on our observations, we recommend surgical planning which will have a minimum number of interventions to achieve the earliest definitive fixation and soft tissue cover. This strategy was found to be successful by Rajashekharan et al. In their study on immediate primary closure in type 3A and 3B open fractures. Accurate documentation of chronological events which happen in our busy trauma clinical setting with good follow-up is the strength of the study. Not including the complexity of the fracture pattern explicitly could be considered as the weakness in the study. Conclusion. In our study, we noted that open fracture severity and bone loss are the main factors which determine the chance of culture-proven infection. The presence of an infection and bone loss predisposes to non-union. Early antibiotic and wound debridement might not necessarily translate into reduction in infection and non-union rates in open long bone fractures. Thank you.
Naveen, you already told that high-grade open fractures were debrided earlier and treated.
Yes, sir.
Compared to others. So, you are telling the timing, the grading of compound fractures is not a uniform treatment protocol given. Timing also.
Yes, sir.
So how can you get into that inference? This inference of
No, that's what, sir. Earlier studies also suggested in that guinea pig study, they mentioned less than 6 hours rule is the golden rule. But same thing, we also divided our patients into less than 6 hours, more than 6 hours. But we didn't find anything statistically significant, sir. Even high grade injuries, which they underwent multiple number of debridements also, they also end up in non-union or infection, whatever. Both similar only, sir. High grade injury versus low grade, 6 hours versus 12 hours rule. Even though that high grade injury depends upon their soft tissue injury as well as the bone loss, how much ever time they underwent surgery, that the follow-up results almost similar, sir.
Doctor, can I ask a question?
Hello. Yes, sir. Hello.
Now, in your study, you classified less than 6 hours to 12 and more than 12. And could you just correlate the timing of surgery for these patients, whether it made a difference, whether in the daytime or night, seniority of the surgeon at the time of initial debridement, did it make any difference? Because that's very, because most of the papers quote are talking about using seniors at the daytime at the initial debridement. Is it right? Yeah.
Yes, sir. We also experienced that, sir. Hello, sir.
In your study,
yes,
did
sir.
you difference on the grade of the surgeon at the time of initial debridement and the timing of surgery?
Yes, sir. Yes, sir. Yes, sir. We find that grade of difference between the surgeon because that emergency is most probably done by senior residents, sir, whoever on call. But the definitive surgery that I am nailing or definitive plate fixation done by the senior surgeon, sir, associate professors category. So there is a difference, sir. We found.
Sir is asking whether you have graded the surgeons during the study.
No. That we didn't grade, sir. Sorry.
and the timing of surgery with reference to, I know your classification is less than 6 hours, more than 6 hours, etc. But in that group, what was the time, the daytime or nighttime? Did you find any difference?
No, nighttime we find difficulty in shifting the case as early as getting the OT theaters and all. We find difficulty.
On the statistics.
He's asking
No,
whether
statistics.
it is divided number of
No,
cases.
sir. No, sir. No, sir. No, sir.
Those would be something useful for you to follow it up in your future study.
Okay, sir. Okay, sir.
Okay, thank you. Let's go to the next paper by Dr. Harsha M. It is on role of antibiotic rationale in the management of grade 3 compound diaphyseal fractures.
Hello everyone, I'm Dr. Harsha, postgraduate in Department of Orthopedics and Traumatology, Usmania General Hospital, and my topic for oral presentation is role of antibiotic-coated intramedullary rationale in management of grade 3 compound fractures. Introduction: antibiotic-coated intramedullary rationale is one of the options available for early management of grade 3 compound fracture. It also has an extra advantage of early control of infection and gives access to soft tissue management with good rate of union. We prospectively studied 20 newly admitted cases of grade 3B compound diaphyseal fractures in Usmania General Hospital between 2019-20, which are initially managed with antibiotic-coated intramedullary rationale. All the patients were between age 15 to 50 years. Out of them, 13 were male, 7 female. Soft tissue management was done either by primary closure, graft, flap, which are followed up for 6 to 14 weeks for checking bone union and wound healing. Simple definition of a compound fracture. A compound or open fracture is defined as an injury where the fracture and the fracture hematoma communicate with the external environment through a traumatic defect in the surrounding soft tissues and overlying skin. Often they are high energy injuries and frequently associated with life-threatening polytrauma. The principles of treatment of open injuries have gradually evolved over the centuries and many advances have come. An image depicting the distribution of open injuries where the most common long bone injured is tibia. And in these cases, the functional restoration is aided by aggressive wound debridement, early definitive fracture stabilization, early wound closure or cover to achieve bone and soft tissue healing as soon as possible. Also, the functional outcome depends on the patient factors, comorbid factors, and the injury factors. The Gustello-Anderson classification for compound fractures, where we mainly emphasize on grade 3B, where the wound is usually more than 10 centimeters and with high level of contamination with extensive soft tissue loss, high energy trauma, and the bone cover is poor and which often requires soft tissue or other soft tissue reconstructive surgeries. During skeletal stabilization, the length of the limb must be restored as this restores the correct tension to soft tissues, decreases swelling, improves circulation, and aids venous and lymphatic return. It also increases the comfort of the patient during wound inspection and facilitates early rehabilitation and movement of the joints. Primary internal fixation for the lower limb diaphyseal fractures is mostly considered as intramedullary nails as the first choice, as they provide superior biomechanical conditions, also maintain the length and rotation of the limb. They are ideally suited for injuries where the contamination is minimal and effective debridement has been performed. The treatment protocol usually followed for compound tibia fractures, grade 1. Wound wash, debridement, and definitive interlocking nail is usually followed. And in grade 3B, we have options of external fixators, plus debridement of the wound, and our antibiotic-coated intramedullary rush nail plus debridement, which on further wound healing is followed up by definitive intramedullary interlocking nail. The procedure for preparation of intramedullary antibiotic rush nail, few instruments required are 32 size chest tube, whose inner diameter is approximately 7 to 8 mm, gentamicin bone cement, 3.54 mm rush nails of length 30 to 38, and general orthopedic surgical instruments. The steps: the desired length of rush nail is selected and the tapered end is curved like the hook of the other end. 32-size chest tube taken and slit vertically to fill in the bone cement. The gentamicin containing PMMA cement, gentamicin containing PMMA powder is mixed with monomer methyl methacrylate in a bowl until working phase of cement is achieved, and the rationale selected is inserted into the slit chest tube. The bone cement is packed inside the chest tube, and the extra cement is removed, and the proximal and rationale is left over, which is to be used while extraction of the nail. Once the cement is completely polymerized and set, the slit over chest tube is removed. The antibiotic rationale is inserted by the routine intramedullary nailing technique in the undrained medullary canal. Post-op, the patient is immobilized and non-weight bearing is advised for 6 to 10 weeks. Few images showing the preparation of antibiotic rationale. In the second image, we can see tapered end of the rationale is bent. The gentamicin containing PMMA cement with monomer is mixed in the bowl. The chest tube, which is slit vertically, is packed with the antibiotic cement. The final thickness of the antibiotic rationale we get is 7 to 8 mm, which is then inserted into the medullary. Clinical images, wound pictures. 30-year males, history of RTA, the wound condition and pre-op X-ray at the time of presentation. Post-op day 5, the condition of wound after primary suturing and post-op X-ray. Definitive intramedullary healing was done 12 weeks after complete wound healing. 6 months post-op, the condition of wound and knee range of movements. Case 2, 50-year-old female, history of RT and the condition of wound and pre-op X-ray at the time of presentation. Wound photo and post-op X-ray on POD5. Condition of the wound, which is completely healed at 8 weeks. Third case, case of RTA, the condition of wound and pre-op X-ray at the time of presentation. Post-op X-ray and condition of wound at 8 weeks. Case 4, there is extensive soft tissue loss, which is then followed up by plastic surgery, which the patient has undergone a flap cover and the post-op X-ray at 4 weeks. So results, the 20 patients who were followed up sustained grade 3B compound FSL fractures, out of which 13 patients showed proper control of infection with good wound healing, primary suturing, and the remaining 7 patients required additional plastic surgery procedures like graft and flap. These patients were followed up every 4 weeks with ESR, CBRP, CBP, pulse for culture sensitivity, and X-ray, and definitive intramedullary nailing was done. This infection was controlled. So conclusion, take-home message is antibiotic-coated intramedullary rationale is one of the options available for grade 3B compound FSL fractures. It provides a high concentration of antibiotics locally, fills dead space, provides mechanical stability, and also gives easy access for other procedures like graft, flap, and also allows easy access to regular dressings. Thank you.
What was the number of cases?
Good afternoon, sir. We followed 20 cases, sir.
Doctor, can I ask a question?
Yes, sir.
Now, when you insert the rationale, and then do you immobilize in POP as well? Because rationale is not going to give you any rotational stability.
Yes, sir.
So what do you do post-operatively?
Post-op, we follow up the patient till the complete wound healing occurs, sir. Like, if at all any plastic surgery procedures are required, we follow up with them.
No, I'm asking immobilization, post-operative immobilization. Apart from rationale, do you use any immobilization?
We use POP splint, sir, post-op, that's all. Yeah.
And you mentioned 7 of them needed plastic surgical procedures for soft tissue cover.
Yes, sir. Yes. Yeah.
So what was the opinion from plastic surgeons? There are no external fixator, so they were happy about it. That's probably what you're trying to say. Is that what you're trying to say? The rationale gives you delivery and also gives soft tissue access to plastic surgeon.
Yes, sir. Yes. And also with the comparatively compared, I mean, the dead space Due to the intramedullary nail, the alignment is stable, sir. It's comparatively.
No, you gentamicin for the antibiotic, doctor, or did you add any other antibiotic within that cement?
No, sir. No, the gentamicin antibiotic which is available.
You might have not got the soft tissue cover in many, at least 7 of these, right?
Yeah, yes, sir. Yeah.
Okay, so how many days after that you have given the soft tissue cover by the plastic surgeon, or immediately?
Immediately means within 48 hours the intervention was done mostly.
Have you?
Sorry,
have you? Okay,
sorry,
sir,
doctor. How many of you are grade 3B versus 3A? Because 3B, they actually do well with internal fixation. Because the bone is exposed to periosteal stripping is there. There's no soft tissue cover to the bone. Are we confident to use your technique in grade 3B and put a nail? Because there, in those instances, we tend to put external fixator. Is that right? Yeah. So I want to know how many of these you
Yes,
had.
sir.
Did you get that question, doctor?
Not all, sir, but which are.
How many were B and how many were
Can
A?
you repeat, sir? No, all were B only, sir. My study was B only.
Okay.
Yes, sir. Yeah.
See, in grade 3B, it's very difficult to achieve soft tissue cover without any local flaps or plastic surgery procedures. And you said that only 7 of them needed flap. And the rest of them you managed to achieve with the primary closure. So that doesn't fit in for a 3B, doctor.
It's only 3A.
Did you get that message, doctor?
Yes, sir. I mean, primary closure was possible in the 13 cases, sir. That's why I kept it.
Okay, doctor. So leave it like that. Thank you.
Okay, then.
Thank you.
Thank you, Dr. We'll go to the next paper, that is by Shravan Kumar, infected non-union of forearm bones treated by Ilizaro method.
I'm going to present about infected non-union of forearm bones treated by Ilizaro methodology. Background. Non-union of forearm bones is not an unusual complication but an infrequent complication of fracture of forearm bones. There are several factors which are implicated in the etiology of infected non-union, which includes disturbance of arterial supply, lack of stability, inadequate reduction, muscle forces acting across forearm bones, and finally infection. The problem becomes more complicated if it is associated with infection. Hence, it becomes a formidable task requested to surgeon to treat a case of infected non-union forearm bones. And why is the treatment difficult? Eradication of infection is the most important step in the treatment of infected non-union forearm bones, which includes debridement of bone and soft tissues, because drug do not penetrate into the infected or devitalized soft tissue as well as bone, and removal of devitalized bone and soft tissue will inevitably result in some amount of bone loss, which needs to be addressed, and healing of soft tissue results in fibrosis, which results in contractures, and if the contractures are not adequately treated, it results in fixed deformities. The radius and ulna, being subcutaneous bones, will have poor bone coverage, which also aids in non-union. And two bone structures with complex joint mechanism is present, and proximity to neurovascular and musculotendinous structures also makes the treatment more difficult. There is paucity of literature in the available literature studying the infected non-union bone bones forearm using Ilizaro methodology, and hence we have taken up this study to evaluate the control of infection, rate of union, and functional outcome in cases of infected non-union forearm bones using Ilizaro methodology. Materials and methods. This is a prospective clinical study taken up between 2012 and 2019, in which a cohort of 10 patients were taken up with 16 forearm bones. 8 were males and 2 were females, with a mean age of 36.8 years. All included only post-traumatic infected non-unions after skeletal maturity. The mode of injury being road traffic accidents in 9 patients and domestic fall in 1 patient. 15 were closed fractures and 1 was open ulnar fracture. And all were diaphyseal non-unions, with the duration of non-union being 9.1 months on an average. Intercalary defect was 4 centimeters on an average. There was only 1 case of posterior interosseous nerve palsy preoperatively. All were postoperative infections following 14 forearm plating and 2 were nailing. The duration of non-union was on an average was about 7 months, and discharging signs were present in 4 bones. None of them were diabetics and 2 were smokers. Materials and methods. It was carried out in a single or 2-stage procedure. In all cases, implant removal was done, adequate wound debridement was done, followed by Lateral fixation. This is the treatment protocol, treatment algorithm which we followed. The case of infected non-union, adequate debridement and implant removal was done in all cases, and assessment for infection was done. If the infection was minimal, a single stage Lateral fixation was done. If the infection was moderate to severe, then a temporary skeletal stabilization using external fixator was done, followed by Lateral fixator as a second stage procedure. The modalities of treatment which we followed were simple compression without shortening, compression with shortening of both bones, free fibular grafting, single bone forearm, distal radial corticotomy and bone transport, proximal ulnar corticotomy and bone transport. Operative procedure. The standard surgical procedure was used, extensive exploration was done, resect all the devitalized bone and soft tissues, ream the medullary canal, passage of thin rush nail for alignment, and external fixator application or Lateral fixation based on the residual infection. And standard hybrid fixation was used. 2 or 3 ring frame was applied. Transosseous pins were applied using safe corridors of the forearm, and stabilization of the proximal or distal radioulnar joints was done using a plain wire. Standard techniques of fixation of Lateral methodology were followed. Postoperative protocol which we followed were antibiotics for 4 weeks, including 1 week of intravenous antibiotics, intensive physiotherapy, functional utility was encouraged. All patients were hospitalized for a period of about 5 to 7 days. All patients at the time of discharge were given training about pin tract infection, pin tract care, as well as compression distraction training, and regular follow-ups were done. Results: union was seen in 15 out of 16 bones. Mean loss of forearm rotation was 15 degrees. Mean loss of elbow flexion extension was 8 degrees. Mean loss of wrist flexion extension was 10 degrees. Loss of grip strength was seen in case of 2 individuals, which was about 30 to 50%. This is the pie diagram showing duration of non-union, which was average of about 9.1 months. And the most common organism isolated was Staphylococcus aureus. 14 cases of previous plating was seen, and 2 cases were interventional nailing. And in 5 patients, single stage procedure was done. In 11, 2-stage procedure was done. 15 out of 16 forearm bones were united, and infection was controlled. The union period ranged between 6 and 9 months, with an average of 7 months. Follow-up period was a minimum of 12 months up to a maximum of 6 years. Functional results were calculated using Assamese scoring, with excellent results seen in 36%, good results in 50%, and other 7% fair and 7% poor, 7% failures. Bone results using Assamese scoring was done with excellent results in 64%, good result in 14%, and fair result in 14%. Common complications of pin tract infections was seen. Posterior interosseous nerve palsy was seen in only 1 patient, which was neuropraxia, after which the patient recovered. 5 to 10 degrees of malunion was seen in 4 patients. Stiffness of rotations were seen in some of the patients. This is a case of radius plating with infected non-union and intraoperative images after implant removal. And this is a free fibular graft and clinical image with Lateral fixator in situ. These are the clinical images showing good functional outcome, and postoperative radiograph showing union. And the case of both bones forearm with infected non-union showing implant removal, clinical image showing pus discharge, and this is a free fibular grafting harvest and Lateral fixator in situ, and clinical images showing functional outcome, and post-op final radiograph showing union. And the case of both bones forearm non-union, in which implant was removed, a single stage Lateral fixator was done, and this is the clinical image showing Lateral fixator in situ, and postoperative final image showing union. These are the clinical images showing functional outcome. Discussion. There is limited availability of literature studying infected non-union both bones forearm with Lateral methodology. Hence, we have taken up this study. There are debatable treatment modalities available, and by far, Lateral methodology is the cost-effective treatment with least amount of complications, and expensive allografts or bone morphogenic proteins and plastic surgical procedure are not required for Lateral methodology. And free fibular graft is more economical and good acceptability with less surgical expertise, and results are comparable with corticotomy and bone transport. Free fibular graft has a diameter which matches with that of the forearm bones, and hence refracture chances are very minimal. Lateral fixator in forearm is patient compliant, and various methods of treatment described in our study are quite affordable with minimal infrastructure and good outcome. To conclude, Lateral methodology has a wide array of options in the treatment of infected non-union of forearm bones with good functional outcome, and hence it can be recommended as a reliable method in the treatment of infected non-union of forearm bones using L0 methodology. This is the data sheet. All the patients with their clinical data can be seen. These are the references, and thank you.
Doctor, no, you said my moderate to severe infection, it was external fixator put first.
Yes, sir.
Why you have done that before? Why you have directly not gone to L0?
Yes, sir. In order to eradicate the infection, we have opted for a two-stage procedure because elimination of infection is the first step in order to prevent further complications and also to prevent implant-related infection and also to achieve good outcome. We have opted for two-stage procedure, sir. And based on
directly gone for L0, it is also an external fixator, right?
Yes, sir. Yes, sir.
But infection can be controlled there also. Why
yes,
do procedure?
Yes, sir. Because regular dressings becomes difficult if an L0 fixator is applied. If it is an external fixator, dressings becomes much easier. And we have relied more on dressings and wound debridement than antibiotics for the eradication of infection.
One more. Have you done any lengthening in this or all fibula you have put?
All were fibula grafting, sir. No lengthening procedure was done. We had an average of 4 centimeters shortening.
So how do you fix that fibula?
Sir, using a rush nail. Rush nail, sir. We used a rush pin, sir, for bringing about the alignment, and after which compression cycles was applied.
Doctor, I should congratulate. This is a very difficult condition to treat, and you compiled a group of patients and you managed very well. But I want to ask you a couple of things. One, you used rush nails at the end to stabilize. Did you use titanium nails or stainless steel nails? Because titanium would have been a much better.
Yes, sir. Yes, sir. We have used stainless steel. We have used stainless steel rush nails, sir, because most of the patients were treated under the government schemes. We could not use expensive or we used a better low-cost stainless steel rush nails. Because most of the patients were treated under government schemes.
So would you advise titanium nails if the cost is not a consideration?
Definitely, sir. Definitely, we would consider usage of titanium nails.
The second question is, there's quite a lot of radial and ulnar non-unions which are infected in your series. How did you manage to collect them? Because do they come from a specific area or do they come all around your centers?
All around
because forearm infections is fairly uncommon. It's a closed fracture most of the time. And if there are so many infections, maybe you should give a feedback back to the referring center. Because they have to change the practice, because it's not a good advertisement for orthopedics, you know.
And most of the fractures are closed fractures, sir.
That's why it's concerning. That's why it's concerning that you have a good number of patients who actually end up having a bone loss. It's really concerning as an orthopedic fraternity. Yeah. Thank you, doctor. Good paper.
Yeah. Anyway, good presentation. Okay, thank you, Dr. Sarvan. Next is the last paper on this session, by Dr. Shivakumar SP, timing of definitive fracture fixation in polytrauma patients, our institutional experience.
Hello everyone. Here's our experience in sharing the timing of fracture fixation in polytrauma patients. Polytrauma are increasing in number every year, and these kind of fractures and these kind of clinical scenarios are not uncommon these days. They almost constitute 14% of adult trauma fractures in this scenario. It is a leading cause of death in developing countries. They are life-threatening and limb-threatening injuries. Controversies always exist in the timing of fixation. There are a lot of questions that have been asked. How much can we do on day one? When can we proceed for definitive fixation? Is there any biomechanical marker that has been useful in identifying these patients for the timing of fixation? And there are a lot of papers that have been published for the past few years. However, the main concern remains the same. When to do a damage control orthopedics, when to do an early total care, and when to treat the fracture of these polytrauma patients. So here is a study that we wanted to analyze the time of arrival of hospital of these patients, the level of serum level lactate in these patients, the injury severity score at presentation of these patients, and the day of fixation were compared to the mortality and the duration of hospital stay of these kind of injuries. So we had included 97 patients over a period of 6 months. All patients who had an injury severity score of more than 17 were taken into the study. The methodology of how we did this study was that patients were managed by acute trauma life support protocol. An injury severity score of more than 17 were taken into the group. The decision of surgery and the decision of treatment was based on their clinical status and their lab parameters, and they were resuscitated and treated accordingly. All the patients were followed up to their discharge destinations. We had included 110 admissions during the study period, out of which 3 patients had a discharge against advice and 10 patients did not have their complete lab details. So the number of patients included in the study was 97. 9 patients had as ward admissions, they were stable and they were discharged. However, an intensive care unit admission required was almost 88% of patients. 17 patients recovered and got discharged from the hospital, while 9 patients died during the period of study. So when we say the results, the road traffic accident obviously constitutes the most commonest mode of injury in these polytrauma. And fall from height was next. The number of days average a patient had to stay in a hospital was almost 23, and the number of ICU days required in them was almost 8. Majority of the patients arrived late to the hospital. That is almost 67 patients arrived after 5 years after the injury to the hospital. We see a wide variety of spectrum of injuries in these kind of patients. Extremity injuries was the most commonest that we could see, followed by a chest and a head injury. Open fractures constituted almost 70% of our patients in this study. When we looked at the injury severity score, they were classified into mild, moderate, and severe. Mild group of patients was the majority in all of these kind of injuries. Almost 58 patients were into this mild. The average injury severity score was almost 27. And when we took this lactate, which is a very easy method to identify, very simple lab investigation that we could do using the colorimetric method, the mean lactate on arrival of these patients was 4.46. And the lactate normalized in 80% of the patients within 24 hours. Due to the various clinical scenarios of these patients, 95% of our patients underwent a damage control surgery at the time of admission, and followed by their clinical status, they were optimized and they were taken up for secondary surgeries. Every patient required almost 2 surgeries during the period of hospital stay, and the average waiting period for the second surgery was 7 days. The day of definitive surgery was equally distributed between the 1 to 5 days and 6 to 10 days, while 12 patients had to undergo definitive surgery after a prolonged period of optimization after 10 days. 9 patients had died during a study period that constitutes almost 9.2, and the average injury severity score was 27 in this group. Sepsis with multi-organ dysfunction was the most common cause of death in the study period, while brainstem herniation was 2 and acute MI was 1 in 1 patient. When we analyze the results, when we analyze the arrival time between the hospital stay and the mortality, they were not found to be statistically significant. The same applied to even the injury severity score versus the hospital stay and the mortality. Again, they were not significant. But when we took the lactate of these patients and we compared them with the hospital stay and the mortality, patients who had an increased lactate at presentation had a higher death. And also, a day of definitive fixation versus the hospital stay and the mortality, patients who underwent a definitive fixation between day 1 and day 5 had a higher mortality. When we analyzed those patients who died during the study, there were 9 patients out of these. So we analyzed the various parameters between all these patients, and we had a surprising result. That was the lactate was more than 5 in almost 6 patients out of the 9. That is 67% of the patients had a lactate of more than 5 in admission. The lactate clearance, that is the failure to clear the lactate of more than 2, was in almost 7 patients, that is 78% of the patients had a lactate clearance of more than 2. Head and chest injuries predominated in almost 78% of our patients. And fixation was done within 5 days in 7 patients. So to conclude, in our experience, a lactate level of more than 5 should be taken with a as a very important sign of having a hypoperfusion at presentation, and they can have a higher risk of mortality. A lactate clearance of more than 2 millimoles per liter after 24 hours had a direct correlation with mortality. Definitive fixation within day 1 to day 5 had a higher mortality in our group of patients. The lactate clearance was more sensitive than initial lactate in these kind of injuries. To conclude, resuscitation is the priority in polytrauma, and it has to be a team effort in all these patients who have multi-systemic involvement of injuries. Thank you.
Doctor, that's a very good paper.
Thank you, sir.
Doctor, can you listen?
Yes, sir, I am able to
hear you.
Very good paper. Thank you, sir.
Now, I have a question.
Yes, sir.
Do you recommend doing a lactate level just before you do surgery in future? Is that your recommendation from your experience?
Yes, sir. The lactate carries a prior importance. When the patient presents to an hospital, it's ideal to have a lactate even before the surgery and keep monitoring the lactate till it becomes normal. Not only the presentation lactate, also the lactate clearance, which has to be prioritized also, so that you don't let the patient be in hypoperfusion. So you normalize the lactate within 24 hours, the prognosis becomes better.
So have you waited till the lactate has come down to do the surgery?
Yes, sir. Yes. Almost all of them, sir. These patients were, this was a retrospective study. So all these patients were, the data were taken retrospectively. So when we analyzed, we found that 5 patients, we had the lactate level even more than 2. Not during the second surgery, but even after 24 hours, the lactate was high.
So in future, is that what you recommend to wait until the lactate normalizes if possible for managing surgery?
Yes, sir. If it's a life-saving surgery, we will go at, sir. If it is, if it's any other definitive fixation, we would like to wait for the lactate to become normal and then plan the surgery ahead.
And is the fixation external versus internal? Did you actually have any difference?
Most of these damage control orthopedics were external, sir. We didn't do any internal fixation in this group.
Okay, thank you.
The external fixators were delayed till the lactate has come down.
No, sir. External fixators were not delayed. The damage control orthopedics were not delayed. The early definitive fixation or the definitive fixation were based on the lactate levels.
Now, have you got any experience on using cytokines like interleukin, which are meant to be more sensitive than lactate level?
In our experience, we found IL-6 was not as sensitive as lactate, sir. We found IL-6 taking a lot of time for it to come down, but the lactate normalized earlier, and that was a more predictable value in seeing the hypoperfusion. So IL-6 we were using earlier, sir, but we have slowly stopped it. So lactate still we continue to use, and we propose it in future also.
Maybe you can do a prospective study, because that's probably going to be a landmark study. Is what the orthopedic fraternity will be looking forward to. Thank you.
Yes, sir. Thank you.
So that comes to the end of this session. Do we start now itself?
Sir. Yes, sir.
No, do we start now itself?
Answering, sir. Okay, sir. Okay, sir. Yes, sir.
Dr. Chocklingam.
Yeah, I am ready to continue. The next candidate is ready to give his presentation.
Good.
Because we are already late by 12 minutes.
Yeah. That's it. Usually they have kept a 10 minutes gap between that, but now we are around 20 minutes, 25 minutes delayed.
Yeah, we can go ahead. We will request Dr. Anand Badula to give his talk about this new tool of precise entry point in the greater trochanter for the femur intramedullary implant. Is the doctor ready?
Yes, sir, I'm ready, sir.
Yeah, please proceed, doctor.
Good morning, everyone. I take this opportunity to thank the chairman, the co-chairman of the scientific committee, and the organizing committee for giving me this opportunity to present this paper in front of you. Today I am here to present a new tool which is helpful for precise entry point into the greater trochanter for femur intramedullary nailing. As we all know, the newer second generation nails have been successful clinically and biomechanically in treating unstable trochanteric, subtrochanteric, and shaft of the femur fractures. The key to the smooth progression of the surgery is the correct entry point and time taken to achieve it. The routine, trial and error method under the imaging guidance is usually time consuming, especially in obese individuals. The drawbacks of the conventional technique which we do on day-to-day basis are, with all, it is usually difficult to get the exact entry point in the lateral views as CM becomes an obstacle and it can only be checked after piercing into the trochanter, as you can see in this picture. In the similar way, while checking the entry for the lateral views, the surgeon's hands may come in between the image intensifier and the hip joint, hence becoming an organ obstacle. Hence, a new tool. This tool was designed by our professor, Dr. V.S. Ravindranath sir. As you can see, this tool, it has made from indigenously with a regular intramedullary nailing tibia and also which is a vertical bar and a horizontal bar which is made up of an interlocking nail femur. And it has got another Tommy bar which is of 3 mm diameter for firm grip of the tool. This tool, it helps to minimize the soft tissue damage, also to minimize the blood loss and bring down the exposure time for the radiation without piercing the greater trochanter. Using this instrument, we demonstrate the ease in terms of time taken for the entry point, the amount of soft tissue dissection, and exposure to radiation for achieving an accurate entry point into the proximal femur. This device, it has got 3 parts. One is the conical cylinder with central cannulations, which helps to accommodate a guide wire of up to 3 mm diameter. And it has got a long horizontal bar of 10 mm diameter, which is attached to this conical cylinder at right angle, and a 3 mm diameter bar, which is fixed at a horizontal, which is fixed to this horizontal rod again. The conical cylinder, it has got 2 ends, the proximal end and the distal end. The distal end, it has got teeth which can rest onto the greater trochanter firmly by giving a gentle tap. This device, it can rest onto 3 places: the tip of the trochanter, lateral to the tip of the greater trochanter, and into the piriformis fossa. Moving the conical cylinder in coronal planes, it facilitates the exact direction of the entry of the guide wire even before the greater trochanter is pierced. Similarly, moving the handle in sagittal planes can change the location of the guide wire to be placed exactly into the center of the intramedullary canal of the femur. The curvature facilitates the easy entry of the guide wire. As the handle is away from the body, it is very easy to take the lateral views of the hip joint along with the greater trochanter. As you can see in the surgical procedure, we have taken only a 1 to 1.5 centimeters incision instead of a long 10 to 15 centimeters incision just proximal to the greater trochanter. And the tool is gently passed over to the exact entry point, as you can see on the left hand upper corner where there is a picture of the image intensifier, as is shown in this picture. And a guide wire is gently passed into the entry site, whether using holding it with a T-handle or gently drilling with a drill. And again, checking it with into the image intensifier in both AB and lateral views. As you can see in this picture, the surgeon hands are away from the body and it's very easy to take the lateral views of the hip joint, as you can see in this picture. And the rest of the procedure is much regular, where a reamer is passed over to the guide wire, followed by gently passing the nail onto the guide wire. And if you see here, the proximal most incision on the lateral aspect of the hip joint is very small compared to the long incisions, which reflects the amount of tissue dissection done for the entry point of the greater trochanter. This is the final outcome of the nailing. Hence, my take-home message is this tool is a very simple one, which mainly aims at minimizing the soft tissue damage, and it's known for its easy maneuverability and less radiation exposure easy imaging, further cutting down the surgical time. And we are planning for further devising this implant in all the regular procedures and planning to publish it very soon. I would like to thank again the scientific committee and also the organizing committee for giving me this opportunity. Thank you.
Doctor, well done for a good presentation and sticking to time. Now, two questions. Number one, have you or your professor patented this? Because it's very important to patent devices nowadays. Yes, number two, you really needs to be manufactured on an industrial scale so that more surgeons can use this.
Yes, sir.
Because what you've shown is a very useful technique and to reduce the surgical time and exposure. Thank you.
Thank you, sir. Not yet, sir. We are planning to take the patents of this one, and we have designed only few of the instruments, sir. We are planning it on a large scale, and we are for past 1 year we are using this instrument, sir. Till we have done around 30-35 cases, sir, and it was very useful for us.
Well done, doctor. Well done.
Thank you, sir.
Thank you. The next is the talk is by Dr. Vignesh V. Comparative study between PFN and PFNA in the treatment of unstable intertrochanteric fractures.
Hello, sir. Hello.
Doctor, yes. Proceed, doctor.
Yes, sir. So, comparative study between PFN versus PFNA in the treatment of unstable intertrochanteric fracture. Intertrochanteric fracture are the most frequently operated fracture and has high mortality and morbidity rates. A wide range of treatment are available for this fracture. In olden days, these fractures were treated conservatively with several complications. To decrease the complication rate, internal fixation was done. PFN showed more number of post-operative complications like implant failure, screw pull-out in case of unstable intertrochanteric fracture. To improve PFNA, anti-rotation system introduced. PFNA claimed better rotation and angular stability with a single screw. Functional outcome is treating unstable intertrochanteric fracture were compared to present study. An effort was made to understand and analyze the advantage over the PFN in the management of unstable intertrochanteric fractures. Materials and method. This study was conducted in Arupadi Medical College Hospital 2019 and 20. A total of 10 cases, 6 males and 4 females were included in this group with the age group between 40 and 60 years. Patients were informed about their consent, respect and informed consent was taken from each patient. Patient with acute unilateral, non-pathological, unstable fracture with any comorbidity were included in this study. Fracture with identical geometry pattern were divided into 2 groups, each having 5 was treated with PFNA and other was treated with PFN, treated with regular PFN. All fractures were fixed by closed reduction and internal fixation in fracture table. A standard post-operative protocol was maintained, which included partial weight bearing for 2 months and assisted weight bearing for another 1 month with vitamin C and vitamin D supplementation. Calcium post-operative follow-up done for 4 to 6 weeks interval, period of up to 12 months. In all cases, antibiotic prophylaxis was administered in pre-operative period. A radiograph of affected were obtained in AP and lateral planes to assess the post-operative fracture reduction. In all the cases, assessment also done regarding operative time, blood loss, and time of union, post-operative complication, limb length discrepancy, pre- and post-surgical status. The quality of fracture reduction was graded as good and acceptable if 5 to 10 degree varus or valgus and anti-version, retroversion neck shaft angle, and poor more than 10 degree varus, valgus and anti-version, retroversion not maintained as a neck shaft angle, and other parameters like sign index, tip apex index, screw placement were also added. The position of PFN anti-rotation was graded as good if the blade was placed into the lower half of the neck AP view and central on the lateral view if the nail does not is the side of the graded trochanter. The clinical results were assessed using Harris hip score. Harris is excellent if 91 to 100 points and good 81 to 90 points and fair 71 to 80 points and poor less than 70. Results: out of 10 cases, 6 male and 4 female were operated. The mean operating time of PFNA was 60 minutes, whereas 90 minutes in PFN, and mean blood loss in case of PFNA is 120 ml, whereas in PFN is 160 ml. The time of union in PFNA group is 12 weeks and PFN is 14 weeks. And post-operative complication in PFN group 1, case of superficial infection was resolved with injectable antibiotic. In case of PFNA group, no case of superficial infection was noted. Limb length difference was noted in one case of PFNA, whereas 2 cases noted in PFN. In post-operative and ambulation, 4 cases, 80% gained pre-injury ambulatory state with 2 weeks, and remaining 1 case gained another in 8 weeks, whereas 3 gained pre-injury ambulatory status with 2 weeks, and another 2 cases were in another 8 weeks. Regarding functional outcome, Harris-Ipsco score was used. In PFN case, showed excellent result. 1 case showed 4 showed excellent result, and 1 case showed good result. Wherein PFN, 3 cases showed excellent result, and 1 case showed good result, and 1 case showed poor result. This is the same result, and it is a pre-op and post X-ray of PFN and PFNA. Harris-Ipsco score. And discussion, the aim of the study was to compare the functional outcome of unstable intertrochanteric fracture treated by 2 different methods of intramedullary fixation, PFNA and PFN. Intramedullary nail acts as an internal splint and helps in the healing device, cause minimal trauma to the vascular supply of the bone. To improve the rotational and angular stability, using a single element, the OA group came out with PFNA. Study showed less operative time, less blood loss, less complication rate, good post-operative ambulatory status, better Harris-Ipsco score with PFNA. The innovative helical blade design provides better compaction of cancellous bone. There will be increased contact area between the implant and the femoral head, better hold on the both compact bone and cancellous bone. PFNA improves the fixation stability by decreasing reaming of bone stock, which will be done in PFN. There is no need of another derotational screw, and it has been biomechanically proven to have better purchase of osteoporotic bones. Biomechanically, PFNA has a greater resistance to cut out better rotational stability achieved with single element large surface, and increased core diameter guarantee with maximum compression and optimum hold in the bone. It has showed improved resistance to vascular collapse, resistance to femoral head rotation, longer fatigue life. The 11 mm helical blade reduces the amount of bone removed in the neck. The tip of the PFNA is flexible with reduced stress on the bone at the tip, and therefore there will be a less implant failure. Conclusion, in PFNA, there is no need of another derotational screw. Innovative helical provides a hold on both compact and cancellous bone, increases the contact area and femoral head, improves stability and less incidence of screw cutoff in case of other intertrochanteric fracture. Our study showed PFNA is better implant than PFN in treating unstable intertrochanteric fractures. And these are the reference. Thank you, sir.
Thank you, Dinesh. I think first of all, one piece of advice. Your slides are showing lot of things written. This is not the way. At least
yes,
5 to 7 lines should be there in a slide. It's an
okay,
advice.
Sir.
Do it later on in practice, because this doesn't seem good to a person who is reviewing this presentation. Okay, coming to that, please mute the other people. You have done 10 cases, right?
Yes, sir.
Some disturbance is there. TV disturbance. Complete. Can you mute somebody? There is some TV disturbance.
Okay. Dinesh, you have done 10 cases, right?
Yes, sir, 10 cases, sir.
Okay. Is it significant to show that PFNA2 is from your study that much of significance? Because it's a very common fracture, trochanteric fracture.
Yes, sir. Yes, sir. I took only 10 cases because it is a one year period of study, sir, and 6 months follow up, sir. So I took only 10 cases, sir.
And what all types of fractures of classified trochanteric? Which type of trochanteric fractures were fixed in both? Have you classified the trochanteric fractures?
Yes, sir. I took only the unstable intertrochanteric fractures, sir.
Which type?
Yes, sir.
Unstable means?
Stable I didn't took, sir, because
you done which classification have you taken up?
Sir, not audible, sir.
Which classification you have used? The AO classification? Which one?
Sir. Yeah, AO classification for 80, sir.
All types were used, were treated. Which all types?
Sir, not audible, sir.
Which all types? You're not hearing?
Yeah, sir, not hearing, sir.
Which all types?
Hello.
And what is the, which type you have done PFN and which down you have done PFN A2? I heard that you all are unstable, but out of that, higher grades of instability in which, is there any this one? You can't hear me?
Doctor, can I just say something?
Yeah. Dr. Chipinga, please.
I think this paper may want to make a valid point, but the numbers are not high enough. It doesn't reach any statistical significance because a minimum number of 10 cases is not enough. I think we can't make any conclusions.
Okay. Thank you, doctor. We'll go to the next. Paper by Dr. Sadish Kumar Sellappan. It is Halifax nail, the trio wire concept with shorter nail length provides better outcome in intertrochanteric fractures.
Yes, sir. Good morning, one and all. I am Dr. Satish Kumar from Stanley Medical College. Today, my topic for presentation is Halifax nail with tri-wire and shorter nail length provides better outcome than PFN in the management of intertrochanteric femur fracture. So, aim of my study is to compare the functional and radiological outcome of intertrochanteric femur fractures managed with Halifax nail and PFN. It is a prospective study conducted in our institution for 24 months, consisting of 42 patients, 21 with PFN and 21 with Halifax nail. So inclusion criteria, all closed intertrochanteric femur fractures of either sex, more than 30 years of age group. We have excluded open fractures, pathological fractures, polytrauma, and neurovascular injury. We have followed AO classification for our study. And coming to PFN, it is a time-tested and proven device consisted of 240 mm nail length and one superior derotation screw and one inferior lag screw with two distal lockings. One is for static and one is for dynamic. So pitfalls are pitfalls in PFN group are anterior thigh pain and femoral shaft fractures due to stress resistor effect, Z effect, reverse Z effect. In some cases, difficulty in putting the derotation screw. Before going to Halifax nail, we will see the gamma nail. It is a predecessor of Halifax nail, and it is the first ever intermediate device for the intertrochanteric femur fractures. There are 3 generations of gamma nail. And coming to Halifax nail, it is the successor of gamma nail with newly developed tri-wire concept. So there are unique features are for the first time in the proximal femur fractures, tri-wire concept has been used, and a single jig provided with 3 variable angles for lag screw insertion, and only system which provides a screw for correcting the position of the guide wire, and a single hole for both static and dynamic distal locking, and lateral cortex breaker is used. So advantages are better rotational stability with single tri-wire system, and Z effect and Re effect are prevented by using set screw, and tri-wire pullout is prevented using a end cap. And the thigh pain is very negligible due to shorter nail length, and the head cap is used to prevent the bone over the proximal nail end, and the difficulty in using the second screw in the conventional PFN is overcome by a single tri-wire with the lag screw system. So coming to implant specification, length of the PFN is 240 mm, whereas in HAL is 190 mm. Proximal diameter is 15 mm in PFN, in 16 mm in HAL. The proximal nail angulation is 6 degree valgus in PFN, 4 degree valgus in Halifax nail. The lag screw diameter is 8 mm in PFN, whereas it is a single screw, so 10.5 mm in Halifax nail. Re-rotation screw is 6.5 mm in PFN. It is overcome by using a tri-wire system with 1.5 mm each tri-wire thickness. So we are all familiar about PFN. In Halifax, we will see this is a tri-wire, and this is the position of the tri-wire inside the lag screw. And it is lateral cortex breaker, and this is the screw provided to correct the position of guide wire, and a jig with 3 variable angles. Standard will operate with standard fracture table, and skin incision standard gamma nail incision with a shorter minimal skin incision, and entry is through the tip of the greater trochanter, and guide wire passed, proximal trimming done, nail assembled and inserted. So lateral cortex, I have told you earlier, lateral cortex piercer has been used, breaker has been used, and the position of the guide wire. If it is satisfactory, it will leave it as such. If it is not there, set screw is applied.
Yes.
Shorter than the lag screw is applied till it touches the subchondral bone. This is the position of the driver inside the lag screw, and set screw is 1/4 unturned. Then end cap is applied to prevent the driver pull out. Distal locking is applied, proximal head cap. Then this is the final position. Coming to post-operative protocol, first day itself we'll start the hip and knee mobilization exercises. In coming to weight bearing, in both stable and unstable fractures with good bone contact, the early weight bearing is indicated. With poor bone contact, partial weight bearing for 6 weeks. We have followed a modified Harris hip score for functional outcome. Coming to results, all these pictorial diagrams has been depicted in a single tabular column for better understanding. The mean duration of surgery is 56.9 minutes in Halifax, whereas 68.2 minutes in PFN group. Average blood loss is about 144 ml in Halifax, 188 ml in PFN group. Mean follow-up time is 10 months for both. Then the mean time for union is 11.7 weeks in Halifax group, whereas 14.6 weeks in PFN group. The average Harris hip score at 6 months of follow-up is 91.8 in Halifax group, whereas 84.47 in PFN group. Coming to follow-up, this is the first Halifax case, immediate post-op and 16 months follow-up. Functional outcome is excellent. This is the second case, pre-op, post-op case, 22 months follow-up, excellent functional outcome. The advantage of Halifax nail is we don't even want to use the distal locking when the nail is snugly fit. This is a pre-op case. This is post-op. We didn't even use the distal locking, you can see, because the nail is snugly fit into the bone. Then 1 year follow-up, there is no axial rotation deformity or coxa deformity. The fracture is united. Functional outcome is excellent. PFN groups, immediate post-op, 10 months X-ray, then functional outcome is excellent. Then second case, immediate post-op, 14 months, functional outcome. Third case, immediate post-op, 15 months, and functional outcome. So coming to complications, since Halifax scale is a newer implant, we encountered various unexpected complications. This is the first case. You can see in immediate post-op X-ray, the lag screw is not in the center position. The distal locking is also in the static position. The lag screw is almost in the superior quadrant. So when the patient is started to weight bear, the lag screw is migrated superiorly, and there was a lag screw pullout was there. Then the driver was breakage in found to be broke in 12 weeks of follow-up. So we have operated the patient and found that the driver was break inside the head. So we have done since the fracture is not united, we have done a procantric cemented hemi. In second case of Halifax, this is an immediate post-op X-ray. The patient sustained a fall after 15 weeks of follow-up. So we have encountered a peri-implant fracture. We have done an implant exit and planned for long PFN. In PFN case, I have told you earlier, due to short neck, we have not able to put the secondary rotation screw. So we have only put the lag screw. Same case, we have encountered a ZFL. Since the fracture is united, we have done an implant exit. Since there is no published paper for Halifax nail, we have done with we have gone through gamma nail publications. This is the paper by Halder itself. This is gamma nail in PFN and gamma nail in PFN. All these literature shows that gamma nail has better outcome than the PFN. And the efficacy of driver has been proved by these papers in distal tibia published by Halder and proximal humerus published by Halder. So coming to limitation of my study, it is a limited number of cases with short-term follow-up, and appropriate soft glass has not been used for measurement, and refractures after implant exit has not been encountered. So coming to the conclusion, Halifax nail is a less invasive procedure with shorter duration of surgery and minimal blood loss, which will reduce the chances of post-operative infection, and it also provides the early consolidation of fractures with higher union rate and excellent functional outcome. And tri-wire provides the better rotation stability. So with a limited experience, Halifax nail has better results than PFN in the management of intertrochanteric femur fractures. So take-home message is, what are the points to be considered for better outcome? Accurate fracture reduction first and foremost. Then position of lag screw should be at the center or slightly inferior in the neck, and it should be center in the head. And lateral end of the lag screw should be kept 5 mm outside the lateral cortex. And the set screw should be unturned 1/4, and the distal locking, if used, always should be in a dynamic position. And the tip apex distance should be about 5 mm in the older people. Thank you.
From your study, you have got complications for both. So shows that it is not only the
Hello,
which is important. your
Hello,
technique
sir.
and reduction and everything. Can you hear?
Hello, sir.
Okay.
Sir, yes,
You
sir.
have
Am I
complications
audible, sir?
both. Okay, you have complications in both the nails. So
Yes, sir. Yes.
it is not only the impact,
Yes, sir.
but also the technique and the reduction is more important.
Yes, sir. First and foremost, important thing is accurate fracture reduction, sir.
Okay, and you have done only removal for 2 or any fracture which you have completely united, you have removed the tri-wire?
So tri-wire exit has not been done we have encountered only one implant exit, sir. That is also for peri-implant fracture, sir. For united cases, we have done only one implant exit, sir.
That might
There
be
are
a
unique
problem
systems
for,
to remove.
yeah, that is true, but you might encounter problems in removing the tri-wire later on after union.
Since till now we didn't face any kind of difficulties doing tri-wire. I mean, for tri-wire removal, sir. Since there are unique devices.
How many removal you have done? How many removal you have done?
Sir, tri-wire revision. Sir, implant exit for united cases, we have done only one case, sir. But we revised the tri-wire in 2 cases. But for those cases, we didn't encounter any difficulties, sir.
Dr. Klingam, please.
Yeah. Now, well done, doctor, for sharing your experience with this nail. I personally have experience with this nail, doctor. I think the tip apex distance we talk about in dynamic improve and also with the A2.
Yes, sir.
Have you study on your group of patients? What was your tip apex distance, and did it actually correlate with your failure?
Sir, we didn't use any specialized instruments or softwares for connecting. I mean, measuring the tip apex distance, sir. But in our cases, the tip apex distance was not exactly correlating with the results, sir. Even though tip apex distance is slightly higher, the functional outcome is good, sir, because of better rotational stability from the tri-wire, sir.
Okay, doctor. Okay, doctor. See, the experience with PFN A2 is that the apex distance has to be slightly higher than what we use for DHS. But with reference to the screw design, screw design, the failure is shaft fractures. Okay, and you already shown one fracture, the screw hole. That because the Halifax nail is got 4 degrees only.
Yes, sir. Yeah, only 4 degrees valgus.
So how do you explain that fracture, doctor? The fracture through the screw hole.
Sir, that is because of the patient had accidental fall again during post-operative period. Sir. During 14 weeks of follow-up, the patient fell again, so he sustained the injury again, so he developed a fracture, sir. But in all other cases, we started even early weight bearing also, sir. But no patients had developed shaft fractures. Sir.
The last question, doctor, in your teaching hospital, and do you use nails only, or do you use dynamic hip screws still in your practice?
So we'll use dynamic hip screws also, sir.
So what is your recommendation for the orthopedic fraternity when you recommend using intramedullary nail versus dynamic hip screw? And out of which your nail, do you use any other nail other than Halifax nail?
So we use PFN also, sir, in our sir. According to our institution protocol, what we will follow is if the fracture is stable type of fracture, we'll use dynamic hip screw, sir. If the fracture is unstable or it is a greater trochanter is a separate fragment and all, it is AO type 2 and 3, we'll use intramedullary devices, sir. Now only we are following a Halifax nail cases, I mean surgery, sir. So we found better that Halifax nail is having better outcome than intertrochanteric fractures than PFN, sir.
And have you done statistical analysis of your results to show that Halifax nail is better than your conventional PFN?
So now we are doing, sir, but the statistical means we didn't follow any appropriate softwares for this study, sir. We just compared the functional outcomes, sir, and Harris hip score and time of union was earlier in Halifax nails for all these patients. And Harris hip scar are also found to be more, excellent in most of the patients in Halifax group than PFN.
So it's important that you follow your paper, doctor, with the prospective study with a large number of patients, and you take the significance as your endpoint. Thank you. Thank you. Well done.
Okay, sir. Okay, sir. Sure, sir. Thank you, sir. Thank you, sir.
Next paper is by Dr. Santosha JB. It is on cross-sectional study on fracture of both bones of forearm in obese and non-obese children between 2 to 5 years of age group attending in tertiary care hospital. Dr. Santosha.
Yes, hello, good afternoon, sir. Good morning, welcome. Myself, Dr. Santosh JB, Department of Orthopedics, the Assistant Institute of Medical Science, ASAN. Today, I am going to present a paper on a cross-section study on the fractures of the both bone forearms in the obese and non-obese children, the between 2 to 15 year of age group attending in a tertiary care hospital. So, as you know, throughout the history of mankind, the obesity and the weight gain are considered to be the personal health, the family wealth, and the indicator of the economical prosperity of the society. As the developing society are industrialized and urbanized, the standard of living continued to rise, so that obesity and weight gain began to pose a growing threat to the health of the citizen. So, as you know, the obesity that usually associated with the diabetic mellitus, hypertension, and coronary artery disease. But in the studies, we are showing a increased risk for the fracture both bone in the pediatric age group, about 2 to 15 year of age group. So we studied the relationship of obesity and forearm fractures. So my object is to study the risk of the pediatric obesity in the forearm fractures in the children, the age group of 2 to 15 years, and to compare the risk of fractures in obese and non-obese children. That too, the both bone forearm fractures. So materials and methods. So this study was done in the Department of Orthopedics and Pediatrics Outpatient Department and MRC Department at Dr. Vichara Medical College, Kolkata, from 2015 to 18 between the age group of 2 to 15 years. So we selected some of the inclusion criteria, that is the age group should be 2 to 15 years of age group with upper extremity long bone fractures attending OPD, and also that is important. Also those given a consent for participation, they're very important. And other thing is exclusion criteria. So we excluded the children with a congenital malformation and who suffered from the chronic comorbid conditions. So once you're selected, we have measured the anthropometric parameters. So in our study, we use the anthropometric parameters or body mass index. So BMI, very important. So here we measured in the emergency department at the time of injury and in the outpatient department at the first follow of the patient. So by using body mass index, children were classified into obese and non-obese children, and the fracture was classified by HAVO pediatric comprehensive classifications of the forearm fractures. So injury also graded like direct injury or slow motion injury or high motion injury. And statistical analysis was done by chi-square test, and significance was considered to be less than 0.05. So look at the observation results. So there's sex distributions. The gender distribution should be same in the obese children, and there will be some difference in the non-obese children. Okay, so in the tabulation you can see mean age group. See, in your study, we actually treated 583 patients. Out of 583 patients, the 433 patients were excluded because they had not met a inclusion criteria. The only 150 patients were included in our study. Out of 150, 69 patients, that is 46%. The mean age group was 7.81, and other was 84, that is 54%. That is that non-obese children, so the mean age group 8.27. Okay, and the kinetics of the trauma. So in the tabulation, if you're looking at the kinetics of the trauma, so slow motion will be more at the obese children. That means the less the severity of kinetics, more the severity of injury. Okay, so next will be the fractures. So if you look at a fracture, we have fracture radius, ulna, radius, and ulna. See, single bone fractures will be more in the non-obese children, but both bone fractures like either radius and ulna or humerus and radius will common in the more in the obese children. And look at the treatment. See, look at the treatment. So the most of the treatment up to 76.54, we immobilize with the above elbow POP plasters. Okay, and that means we are treated most of these fractures by conservative line of treatment and with some of the manipulation and the general anesthesia. So we avoided surgical and treatment, that too for the obese children. So we have done some surgical pins for the more for the non-obese children. So we avoided the surgical treatment in the obese children. So same thing we are look at the graph. See, so in the kinetics of trauma, slow motion injuries are more in the obese children. Obese. That means the less the severity of kinetics, more the severity of injury in the obese children. That is a risk compared to non-obese. Look at the fractures. The both bone fractures, radius and ulna were more common in the obese children, and single bone fracture are common in the non-obese children. And treatment also we are treated with with the conservative line of treatment, that is immobilization with the above elbow POP plasters. So that is blue line obese children, up to 73 to 76% were treated conservative treatment. Some of the cases, so we treated, if you are not reduced, if you are more displaced, we are reduced under general anesthesia, that is manipulation under general anesthesia, but surgical anesthesia usually we avoided in the obese children. So as we told in our study, we selected, that means we are treated 583 patients. So in the patient attending the outpatient department and emergency department. So out of which 433 were excluded. That means they are not met inclusion criteria. Among them, only 150 were met inclusion criteria. Okay, so as we discussed in the observation result, the gender distribution was same in the obese children. Okay, in our study, we found 46% of the prevalence of the obesity. That means it was a very higher, and risk of fracture more in the obese children than the non-obese children. But some studies in Canadian studies shows there is no statistical significance in the history of previous fractures. So now I am concluding that children's having upper limb both bone fracture was confirmed with the high prevalence of obesity, and in our study shows higher prevalence of the both bone fractures than general populations. Both the radius and ulnar fracture is in obese found to be significant, as already discussed in the observation result. There is the single bone fractures were common in the non-obese children, but one thing that there is a positive data. So this need to be studied to conclude the more association of both bone fracture and obesity. Okay, so next will be these are the references, the studies. Okay, this concludes our presentations, like cross-section studies in the both bone fracture in the obese and non-obese children in the 2 to 50 years of age group. Thank you.
Doctor, what is this? Why is this common in obese patients? Do you think what is the main reason? Doctor, are you here?
Your doctor said what? This makes perfect. I just need one more thing.
He's not able to hear that one.
Yeah.
He's not able to hear us.
Dr. Santosha, just unmute yourself. He's not there.
Nothing.
Let's go to the next.
They will go to the next paper.
Okay, next paper is by Dr. Savit Shetty, a comparative study of plate fixation versus intramedullary fixation of displaced midshaft clavicle fractures in adults.
I've been somewhere way better. Wow, that's quite a view.
Good day to all of you. Today I'll be presenting a paper on comparative study of plate fixation versus intramedullary fixation of displaced midshaft clavicle fractures in adults done in our center. As you all know, clavicle fracture is one of the frequently encountered fractures in our day-to-day practice. Of these clavicle fractures, 80% of cases are mid-shaft fractures. Classically, the teaching was a non-operative treatment for these fractures, but over a period of time, few of the literature started revealing that unsatisfactory outcome following these fractures, that is non-union and symptomatic malunion, were found to be quite significant number of cases. So the recent trend is towards operative management, that is open reduction and internal fixation using plate, or closed bar open reduction and usage of nails. In our study, these were the aims and objectives, that is to analyze the functional outcome of midshaft clavicle fractures treated with plate fixation versus intramedullary fixation, to analyze the complications of the surgery, to assess the time taken for bone union in both the groups. Ours was a quasi-experimental study. The study was done between November 2017 to October 2019 over a period of 2 years. 38 patients were enrolled with fully displaced midshaft fractures, and every alternate patient was treated with either intramedullary nailing or plate osteosynthesis. Patients included in our study were between the age group of 18 to 60 years with displaced midshaft clavicle fractures, that is type 2B1 or type 2B2 as per Robinson's classification, and duration of less than 14 days following injury. Open fractures, pathological fractures, and clavicle fractures with significant ipsilateral injury of the upper extremity and clavicle fractures associated with head injury were excluded from the study. In the plate osteosynthesis group, beach chair position was used. Incision was made over the clavicle. The supraclavicular nerves were identified and preserved as shown in the picture. 3.5 mm anatomical locking plate was used. Wherever possible, interfragmentary screw was used. Implant removal was not done in routinely, but in cases following union and in cases of infection and on patient's request, the implant removal was done. In nailing group, incision was done on the anterior aspect of the medial end of the clavicle as shown in the picture. Entry done using a bone awl. Close reduction of the fracture was done, and a titanium nail of appropriate size was passed from medial to lateral side across the fracture side. In few cases, we had to do a open reduction. Implant removal was done in all patients after union because medial end had produced a lot of irritation on the skin. The parameters we used to compare the surgical outcome were pain on the first post-operative day 1 using VAS score, the time taken for union in both groups, the functional outcome using DASH score at 6 weeks, 12 weeks, and 24 weeks follow-up, and complications encountered with each group were analyzed. The data was analyzed using SPSS version 22, a mean standard deviation independent sample t-test, Mann-Whitney U-test, chi-square test, or Fisher exact test were used wherever appropriate. A p-value of less than 0.05 was statistically significant. In our study, in the plating group, the mean age group was 42 years, whereas in nailing it was 31 years. This difference was statistically significant, that is, plating group had little elderly population, whereas male were the commonest with the displaced clavicle fracture in both the groups. The mean interval from the injury to the time of surgery was 3 days in both the groups. Commonest mode of injury was a fall and outstretched hand in both the groups. The type 2B1 Robinson classification type of clavicle fracture was the commonest type of fracture in both the groups. The DASH score as compared to preoperative at the end of 24 weeks improved significantly in both the groups, but on comparing both the groups, there was no statistical significant difference. Then we further went and did applied Bonferini test, wherein we checked the interdifference between each intervals. Therein we found a very highly significant statistical difference. Even with the mean visual analog score, as compared to the pre-op status on the first post-op day, there was a significant reduction in pain, which was statistically significant in both the groups. But on comparing the two groups, there was no much difference. Time taken for union, which was about 12 weeks in each groups, and there was no much difference. The mean duration of hospital stay was lesser in nailing, that was 7 days as compared to 9 days. So this was statistically significant. We encountered about 6 complications in each groups. There were 3 cases of implant loosening in plating group, for which we had to do a immobilization leading to restriction of shoulder movement. 1 case of delayed union, 1 of non-union, and 1 case had hypertrophic skin scar. 2 cases of implant failure were noted in nailing group, 1 with superficial infection, and 3 of them had implant irritation. This is the picture showing implant loosening and backing out of the screw following plating. The second picture showing the non-union of clavicle fracture following the removal of the plate. The third one wherein is an implant failure in case of nailing, wherein the patient had a refracture at the fracture and the nail also was broken. The last one was the nailing where it was done in a comminuted fracture. The nail got migrated through one of the comminuted fragment dorsally, leading to implant failure. But on analyzing all the complications and comparing them with both the groups, there was no much statistical significant difference. The optimal method of fixation, whether plate or nail, is still debatable. However, current studies do not show any significant difference in both the modalities. Interfragmentary screws used to stabilize the fracture in plating gives good bone-to-bone contact and reduces the chances of implant failure. 2 cases with implant failure in nailing group had comminuted fracture, so we probably feel that nailing is not a good option in comminuted fracture. To conclude, there is a role for surgical intervention for certain cases of displaced and comminuted fractures in order to avoid malunion or non-union and their potential long-term sequelae as compared to what was thought earlier. Both the procedures provide good anatomic reduction, stable fixation, and early return to their occupational activities with satisfying functional results. Intramedullary nail fixation is better suited for simple displaced non-comminuted fractures, while plate is one for comminuted clavicle fracture displaced one. This is what we inferred from our study. These were our references. Thank you.
Doctor, good paper. Doctor, can you hear me?
Are you there?
I think this voice get cut off.
Savit Shetty. All of these people are not there.
Not for discussion. I think we should move on.
Okay. Let's move on to the next paper. That is by Arun Mageshwaran. Dual fixation technique for non-union of long bones diaphysis.
Hello sir, I am Dr. S. Arun Mageshwaran, second year postgraduate from Government Mohan Kumar Mangalam Medical College Hospital, Salem. I am going to present a paper about dual fixation technique for non-union of diaphysis of long bones. These are my contents. First of all, introduction. Most commonly, failure of fracture union occurs due to the instability at the fracture site. So our first and foremost aim was to improve the mechanical stability of fixation at the fracture site. Accurate fracture reduction and absolute stability can be achieved in different fracture patterns, difficult fracture patterns, by using the unique fixation techniques. Dual fixation with plates or intramedullary nailing with augmentation plating can give good union rates when compared to fixation with the single implant. Materials and methods. This study is a prospective study conducted in our hospital from the year 2018 to 2019. A total of 12 patients were included in this study with a fracture non-union of long bones diaphysis. Inclusion criteria were age is more than 18 years, defect is less than 2 cm, and established cases of non-union. What are the exclusion criteria? Infected non-union, pathological non-union, patients with a neurological illness. Out of 12 patients we were operated, 3 patients were treated with dual plating and 9 patients were treated with intramedullary nailing with augmentation plating. And of that, 2 patients showed severe deformities. What are the operative techniques? There are 2 techniques, either dual plating or interlocking nailing with augmentation plating. All the patients already underwent one-stage definitive procedure. Preoperative radiograph and CT scans were done to assess the degree of deformity and bone defect. For patients in whom the dual plating was done, the fracture site was fully exposed and fracture ends were freshened. The deformity was corrected and fixation was done with two locking plates. Dynamic compression is actually not required in plate application since we plan to fill the fracture gaps by autogenous bone graft. In patients where the nail and plate fixation was planned, an intramedullary nailing of appropriate size was inserted after serial reaming of the medullary canal so that it snugly fits in. Once the fracture is reduced and stabilized, it is augmented by applying a locking compression plate. Autologous anterior superior iliac crest graft is applied between the fracture ends. Postoperative protocol. All patients were allowed to perform the non-weight bearing exercises immediately to avoid the joint stiffness. Partial weight bearing with the crutch was permitted after 6 weeks. Once the fracture healing was confirmed, full weight bearing was allowed. Follow-up at 1, 3 and 6 months were done. Results: all the patients were showed up regular intervals for a period of 2 years. The average time for union we have observed was 5 months. One patient had infection which was treated with antibiotic bone cement spacer, and the 2 patients developed the post-operative stiffness of the knee joint. Active range of movements improved after a month of physiotherapy. No other major complications were encountered in this study. Discussion: some words about the non-union. Non-union is defined as the fracture fails to unite by the end of 9 months after the fracture and didn't show any signs of healing radiologically for the 3 consecutive months. Types: it is of 2 types, hypertrophic and atrophic. Hypertrophic is nothing but it's characterized by the abundant callus and also radiolucent line at the fracture site, which is mostly due to the lack of mechanical stability. Another one type is atrophic non-union, which is characterized by the absence of callus and also resorption of the bone ends because of the impaired vascularity. We are using the Pallis classification to classify the non-unions. This is non-union. One is hypertrophic or hypervascular with biological reaction capacity. Another one is avascular or atrophic without biological reaction capacity. These are some types of hypertrophic non-union: elephant foot, horse hoof, oligotrophic. This is Pallis classification, type A and type B. Type A is less than 1 cm bone loss. A1 is lax or mobile. A2 stiff or non-mobile. Type B is non-union, involves more than 1 cm of bone loss. Actually, what is the mechanism of non-union of the long bones is multifactorial. Our aim is to achieve the 3 main goals. One is achieving the mechanical stability by dual fixation technique. Second one is augmenting the potential for bone healing by bone grafting, and also correct any alignment deformity by unique fixation for the first fixation technique. Dual fixation technique can achieve the both angular and axial mechanical stability. It can act as a 3-dimensional fixation construct that can provide some sufficient multiplanar stability, and hence it's suitable for patients with non-union of the long bones. Most commonly used plate for augmentation is the broad DCP, with the advantage of having the alternative screw holes in the staggered pattern, which allows us to insert the screws in front or behind the nail, inserted obliquely so that it sidestep the intramedullary nail in situ. The plate provides the additional stability when there is excessive motion at the non-union site. So according to Perron's theory, so it provides the good additional stability and also mechanical stability so that it won't move at the fracture site. So it provides the primary healing. Retained nail act as a load sharing device, neutralizing the shearing forces on the non-union site. Hence it also helpful in maintaining the alignment of the fracture. This is a case 1 scenario number 1. Patient middle third femur fracture in which intramedullary nail in situ showed some non-union after some months. So we are planning to do augmentation plating. It's a 8-hole BDCP was inserted. This is the immediate post-op X-ray. This one is a 3 months follow-up. There is some evidence of callus formation at the fracture site. This is 6 months. Good healing was observed after 6 months. This is a case scenario 2, proximal 1/3 femur fracture, which was previously fixed with the BDCP, non-locking BDCP 8-hole plate. Non-unionism was observed. So we are planning to remove the plate. We have done dual plating with 10-hole locking BDCP and PFLCP plating. This is immediate post-op X-ray. This is a 3 months follow-up X-ray, showed some evidence of callus. This is a 6 months follow-up X-ray, showed perfect union at the fracture site. This is a case scenario number 3. in which this is a patient in which comminuted fracture, distal femur closed comminuted fracture, in which we have done DFLCP plating using the lateral approach, and then back the patient was infected, and then we are planning to do that, and also no evidence of union. So we are planning to do the antibiotic bead application plus and also T buttress plating to support the medial side in the medial approach. This one is a 3 months follow-up X-ray. Shows some good evidence of callus formation. So what is the conclusion? Dual fixation technique can provide excellent mechanical stability to the non-union site and also achieve the good union. Out of 12 patients who were treated with dual fixation, we had been able to achieve the proper union in almost all the cases with average time of 5 months. It can be concluded that dual fixation is a unique and effective technique for the treatment of non-union of diaphysis of long bones. Thank you. These are my references.
Doctor, are you here? Are you here? Dr. Arun? Dr. Arun, are you here? I think he has shown a nail without locking and then done a plating also later on.
I think the message we wanted to see is what is dual fixation and when is it in, and the first case is not really an absolute indication they showed. But
And
unfortunately,
the last case is a metaphyseal fracture he has shown. Okay.
Yeah.
There it is indicated also. So you don't need to emphasize it on that.
If not paper, he can answer questions. I think we have to move on.
We'll go on to the next one. The last paper is by Avinash RN. It is a study of functional outcome of intramedullary interlocking nailing in surgical management of isolated or combined fractures of forearm.
10 minutes.
Good afternoon, sir. Am I audible, sir?
Yes, doctor, proceed.
Sir, my study is on the functional outcome of intramedullary interlocking nailing systems in surgical management of isolated or combined diaphyseal fractures of the forearm. So, introduction: fractures of the forearm are generally considered intra-articular due to its complex functional and anatomical characteristics, because the relationship of radiohumeral, proximal radioulnar, distal radioulnar, radiocarpal joints need to be maintained. Apart from this, the interosseous space needs to be aligned properly for a good axial alignment rather than and the rotational alignment. The development of a locked interlocking nailing system has expanded the role of forearm nails in the management of diaphyseal forearm fractures. So non-conservative management of forearm fractures are literally outdated. Even if a small displacement will always cause malunion and non-union due to complex movements occurring to the joints. So the indications of the thing are proximal radius fractures, where it will avoid injury to the posterior interosseous nerve, poor overlying skin and osteopenic bones, and severe mangling injuries. In case of compound injuries of grade 1, 2, 3 of Gustilo-Anderson, it can be nailed immediately without any wound debridement.
Doctor.
Contraindications is
Doctor?
nailing won't be. Sorry,
you're not
sir?
sharing the screen. Are you using any slides or you're just talking?
I'm using slides, sir. I'm actually sharing on it. It is showing stop sharing. Sir, am I visible, sir?
Slide is visible. I can see it.
Okay, sir. Shall I continue, sir?
Yeah, continue, doctor.
Yes, sir. Sir, this nailing system requires proximal and distal limit for the screw locking nails. Other than fractures of the shaft of radius and ulna, it won't be possible to fix fractures of the distal ends. And the diaphyseal, if the diameter is more than 3 millimeters, is also a contraindication. Problems with plate fixation, generally, though it is a standard of management nowadays, it also causes a lot of skin reactions like keloid scars and superficial infections. And sometimes when you go for posterior fixation, there is always hardware prominence and prominence of the patient in complaints. So the advantages with the nailing are little or no periosteal stripping is required. It is a smaller wound, and for close, in case even if you open the bone in order to reduce the fracture, you can always no need for bone grafting. Even if it is needed, you can do the same reaming material which they use for the fixation. And the aim was of our studies was to assess the functional outcome of diaphyseal fractures, isolated or combined radius and ulna treated by intramedullary interlocking nailing system. And with the same objective, we carried forward with the study from August 2017 to May 2019 with a sum of 30 patients. Majority of them were males, and average age group was around 28 to 72, with common mode of injury being the road traffic accidents. So the inclusion criteria were the diaphyseal fractures of both radius and ulna, and segmental fractures of both radius and ulna, or a single bone. We excluded comminuted fractures and compound open fractures. The operative technique was we used a forearm foresight nailing system, which can be bent before insertion. Was available in 4 and 5 millimeters of sizes, with the 2.7 mm self-tapping proximal screw and 1.9 mm self-tapping screw distally. The length of the screw was length of the rod was 22. Nail was 20 to 26 centimeters in 2 centimeter of increments. Choosing appropriate nails for both radius and ulna, we used to measure the gross ulnar length from the tip of olecranon to the ulnar styloid, which gives the gross ulnar length. And from this, we take off 1 centimeter, which gives the ulnar nail length. And from ulnar nail length, we minus 2 centimeter, which gives the radial nail length. And for the size of the nails, we usually template the X-rays, and also we confirm it while reaming it on the table. We usually prefer to over ream half to 1 millimeter above the size of the nail. So entry ports of the ulna were made to the center of the olecranon process through the center of a medullary canal in order to avoid the damage to ulnar nerve. Going medially was avoided. And 9.1 that was made, 1.9 mm trocar pin was confirmed, was placed and confirmed, and the reamer of 6 mm cannulated reamer was used for the entry reaming, and it was done till 2.5 centimeters. And the medullary canal was reamed with starting a 3 mm of a reamer, and it was increased in increments of 0.5 centimeters till 4.5 mm for a 4 mm nail and 6 mm for 5 mm nail. For the radius, the entry point was a Lister's tubercle below the extensor carpi radialis tendon, and 2.5 to 3 centimeter of a longitudinal incision was carefully done, preserving any damage to the superficial branch of radial nerve. The entry point was again confirmed with 1.9 mm trocar pin, and it was similarly reamed with the 6 mm cannulated reamer. Nail insertion. The same was inserted, same nail once the size was known, it was inserted to a jig, and the same was repeated for both proximal radius and ulna. Here you can see the instruments we used for the OT, and this is the entry point for the radius, and it was marked and it was confirmed in the CM. Entry point for ulna, it was confirmed in the CM, and these are the locking nails, and the nails were introduced through the jig, and the locking of the nails can be seen. So post-operatively, above elbow slab was given for the patient, and 2 weeks of after the 2 weeks, they were again called for suture removal, and was advised to carry the arm in an arm pouch, and patient was advised to perform active shoulder, elbow, wrist, and finger movements, and patient was advised not to lift any heavy weights, and was followed up at intervals of 6 weeks, 3 months, and 6 months, and 1 year. And the outcome was graded under Grace and Liverman's scoring system, which takes into consideration the supination and pronation, the rotation arc of the forearm, in which says that more than 90% of it is preserved. It gives excellent result, and good result are more than 80% of rotation arc preserved. Unacceptable results when more than 60% of loss of a rotation arc is present. The results were statistically analyzed, and it was found that more than 90% of the patients had excellent results, and it was two complications were expected with a delayed union and one superficial infection. This is the case one where we operated for a diaphyseal fracture of both bones forearm, and was fixed with 2 nails. And in the rotation arc, we can see the patient doing it. And this is isolated distal radial nerve fracture, radial bone fracture fixed with IMIL nailing. And this is the patient, the post-op patient with the rotation arc well maintained. This is another case with the shaft of both bones forearm fracture, and similarly the arc was maintained. And this is a distal shaft, diaphyseal shaft fracture with similar maintenance of the arc. So it concluding, it is a minimally invasive procedure with a less time-consuming, cosmetically acceptable, early return of functional activities, load sharing device. The risk of refracture is low and better option for selected diaphyseal fractures. And we also state to conclude that though plates are more preferred or more advantageous than nails, it is always better to go for nailing in case of a skin damage to the at the time of injury, or the skin over the fracture site is not viable for suturing. It is always better to go for a nailing in order to preserve the musculature and everything. So, thank you, sir.
Thank you. Are all these fractures closed nailed, or anywhere you have told the opening is also okay during the
Yes,
paper?
sir.
So have you opened in some cases to get the reduction?
Sir, we opened in I think 3 cases, sir, where the reduction was a little difficult. So we just opened it and aligned it with a bone clamp, and then we didn't use any bone graft, sir. It was not needed, sir.
Out of the 33, you have opened.
Yes, sir. Yes, sir.
How is the nail size usually used? 4 and 5. Do you find it difficult?
Yes, sir. 4 and 5 mm.
In our group of patients, the medullary cavity for the forearm is not that big. Do you find it difficult to introduce it?
No, sir, we didn't find any difficulty, sir. We preferred mostly with 4 mm nails, sir.
Doctor, what is the incidence of superficial radial nerve affection in your patients? Because your radial nailing goes through the exact zone of superficial radial nerve.
Sir, we didn't encounter, sir. We didn't encounter any incident, sir. We just isolated the superficial branch and we proceeded, sir.
Okay, doctor. Interesting paper. Thank you.
Okay, thank you. That comes to the close of this session. I think it was nice sharing you with you, Dr. Chokkalingam.
Thank you. Same here, doctor. Thank you.
Okay. Looking forward to seeing you in the next conference.
Definitely.
Okay,
Congratulations to all the speakers. Good work.
Yeah. And good work done. Okay, and over to the organizers.
Thank you, the organizing team.
Chokkalingam, hi Chokkalingam. How are you?
I'm fine.
Okay.
You should know there are 520 e-posters.
Wow. Who's judging them?
Aneen only. So he's going to take 1 month, I believe. He wants 1 month to judge them.
Definitely. There are other people, Dr. Vijayaraj and Dr. Aditya, what is that? His name is, just get it back to you.
Anyway, we discussed it, Aneen, we discussed it, and we decided to give it, we'll give you enough time. Enjoy.
I have told Karthik to send it offline.
No, it's good actually. See, rather than be in a rush and then doing a messy job, at least concentrate there. You can just analyze them, and then I think that's the best thing to do. We did not expect this. We did not expect 500 posters. No.
If you take 3 minutes for a paper for a poster to review, at least it will take 1,500. That is 30 hours.
So you take your time. There's no hurry because we want to do a good job. Just sit down and then you'll coordinate. and give us the results. That's it.
Okay.
Nice, nice.
And 2:30 is the GB, right? So
Starting. Hello, Sudhir.
No?
Yes, Sudhir.
Do you have
please.
time to drink tea at least?
Did you have a lunch or not?
Yeah, I had an early lunch.
Good.
I'm based in Cortical.
Cortical. Yeah, we would love to come there. Vasudevan is one of our close friends, and we keep inviting to meetings in Trichy, and maybe we will see you as well. We organize meetings in Trichy.
He might be here. He might be. Yeah, he's having some problem getting in. He's writing it there. He's the vice president of IASS now.
Wow. Good.
Yeah.
So how is the weather in Kozhikode? Raining? No rain?
No rains. Few days back there was a rain. That's all.
Here it is raining. In Trichy it's raining.
Yeah. You have some heavy rains there, right? Coming up last day.
Hello, good evening, Anin.
Good evening, sir.
Good evening.
I think we'll just give a minute for members to log in. They're just finishing their lectures. Okay, somebody help me here. I'm not seeing myself.
Raghav, can you hear me?
We are seeing there.
Raghav, can you hear me?
Sir.
No, I'm not able to hear also.
Yeah, I've been trying for last 1 hour. I'm not able to enter into the meeting.
I need the papers.
They are not hearing. Vasan, sir.
I was not able to enter the meeting.
Vasan, sir, come on.
Can you hear me?
Please come. Everybody is waiting.
Can you hear me?
Vasan, sir.
Yeah, can you hear me?
1 minute, just 1 minute. Hello, can you hear?
Yes, we can. Yeah.
Okay.
Yeah, we can hear.
Now, just is somebody sharing the screen so that we can all see the program?
Raghav, I'll be sharing the screen. You'll see the program there. I have the agenda. Raghav. You're muted.
If you put on the program,
yeah,
we will know when to speak and when not to speak, if you don't mind. Let's start. Is it okay to start, Nali?
Yes.
On behalf of the Orthopedic Association of South Indian States, I welcome you once again to our most important or one of the most important events of OASISCon 2020. This is the general body meeting. This is the time we will address and sort out and give direction to our members. Before we start, we will have a silent prayer for a minute, starting now. Thank you. Okay, we will start with the welcome address by the President. Can you all hear me, Nali?
Yes, sir, we can hear you, sir.
Now, this would be my first ever address to the general body as a president, and fortunately or unfortunately, will also be the last address as a president. It is extremely important for the members to know that our association has lost its steam. We started with a great idea, camaraderie, great vision. Somehow that has not materialized. As I said in the EC, and as we have shared the details of our questionnaire yesterday, more and more youngsters are not even aware of this association. Members are not participating. The numbers attending our live conferences, their numbers are dwindling. There is no money in the association. And above all, there is no enthusiasm for our oasis. Let us not discuss why this has happened. As I said yesterday, let there be no more tears like in Telugu movies. We have to move forward. We want ideas from you if you feel for oasis. Don't say it cannot be revived. Please write to us. One of the points that was discussed yesterday was lack of communication. And during this presidency, the most important thing that we will address is communication. We are going to create guidelines for conferences in the next 7 months. I will have a premature ejection in August, hardly 7-8 months I have next year. We need to have task forces created. We need to have clear guidelines about where to conduct the conferences. We cannot go to every corner of South India where there is neither a flight nor a train, and that is a disaster. If there are no members attending the conference, then it is very disheartening for the organizing community. Nobody visits our website. We are going to give you those statistics later on. We need a task force to improve our website. Each task force that I'm going to create will have members, youngsters mostly, and these task forces will run for 3 years. They are not EC members, but they will guide the EC in how to take oasis forward. We need a task force for academics. We're going to create a task force to write monographs and textbooks. We're going to create a task force to take the journal forward. We're going to create a task force to improve the finances of oasis. We need a task force to do drastic changes to our constitution. Should we have a direct election to the president? Is this system working? What are the changes that we need to improve our organization? Constitution is important, but that needs to be revised by the general body. And we need a task force to give directions to that. Should orations be forever? Should there not be a time limit of 5 to 6 years? So that the future generation of great orthopedic surgeons who are going to be coming up and becoming members of our association, they'll get a chance. Yesterday, one of the icons of orthopedics from South India, Professor Rangachari, died. How are they going to get orations or medals in their paper? What about how long are we going to say 2 talks to Kerala, 2 talks to Karnataka, 2 talks to Tamil Nadu? We are South Indians. No more divisions. We should be representing as one state, that is South Indian state. That's all. This is my view. And this is a very strong view. I am going to bulldoze anyone who is going to divide this association anymore. Oration should not be divided on state basis. Oration should be on merit basis. So must be the presidents. They should have the credentials to become president of the association. That's extremely important. Scientific committee should be there, overlooking the scientific agenda of OASIS. Till COVID goes, we should have webinars. There will be a committee starting OASIS webinars. We need to improve the finances. Today, I'm going to announce, we have announced 2.5 lakhs for a virtual conference. See the spirit of Dr. Karthik Pingal. He says, sir, you should announce 5 lakhs. So we're going to give you 5 lakhs to OASIS from this virtual conference when there are hardly any stalls. But that may not be the last that I'm going to speak. I may give you even more. Every OASIS con should contribute 5 lakhs. If you can't raise 5 lakhs for OASIS, then don't do it. Every CME which we're going to conduct and make sure that they are conducted should give us 1.5 lakhs. That means OASIS is going to get 9 lakhs every year and 5 lakhs from OASIS con. And the trauma con should give 2 lakhs. So directly I'm going to get 16 lakhs per year to OASIS. Then we will have a secretariat. Then we will have a journal that we are dreaming of for last 15 years. And every time saying somehow manage, this should go. An organization without 1 crore of rupees in its banks is no organization. And within 5 years, there should be an organization this organization should have 1 crore in the bank. And I'm going to start the foundation for that. EC is 42 people. Is this correct? Who did this? Why are we not questioning this? Why are we so scared of questioning this? EC should be a 10-member body. However, yesterday we have decided to have 21 members, and Dr. Anin this morning sent a mail and a message.
Raghav, can I remind you that it is welcome address? We'll go to the agendas later.
Agenda. So all this will be done in this program. Sorry, Nali, I got carried away, but we will address all these issues. Over to you. We can't hear you. Unmute yourself.
Unmute, Nalli.
Dr. Nalli, unmute. You are muted.
No, he is not muted. Nalli is muted.
He spoke just now.
Nalli, just press the space bar.
In the bottom left corner, sir. Dr. Nalli, bottom left corner.
Yeah.
Okay.
There. Unmute.
Please unmute, sir.
No, I'm having a problem now. 1 minute.
Okay.
Yeah.
Now you are okay.
Yeah.
Able to hear me now?
Yeah. Go ahead.
Okay, yeah. So we will start with the next agenda is obituary references. So these are the like Dr. T.L. Kurian, past president of KOE, Dr. Boslai from Ernakulam, who expired on 1/3/2020. Dr. Sachidanandan, the past Honorary Secretary of the Kerala Orthopedic Association, and the past President of Cochin Orthopedic Society, who expired on 8/7/2020. Dr. T.S. Ravindran of Thrissur, who expired on 3/9/2020. Dr. Anup Krishna, a young orthopedic surgeon from Kollam, who committed suicide on 1/10/2020. Dr. Ambukan from Thrissur again expired on 3/11/2020. Professor S. Rajagopal, the former head of the department, Department of Orthopedics, Madras Medical College, Chennai, expired on 1/8/2020. Dr. V. Sriram, the past president of Karur Orthopedics Club, Karur, who expired on 1/8/2020. Dr. Lakshmi Narayana Reddy from Nellore, he expired in the month of April. Professor P. Narsimulu, Professor of Orthopedics in various medical colleges of Andhra Pradesh, expired on 6th June 2020. Professor V. Shanmugam from Pandruti, Tamil Nadu, the former head of the department, Keelpok Medical College, Chennai, who expired on 17/9/2020. Dr. K. Sundaravadanam from Coimbatore, expired on 14/10/2020. Both Shanmugam and Sundaravadanam to COVID. Dr. Lazarus Mukherjee, I do not have the date of, 15/9/2020 expired. Dr. Narsimham from Andhra Pradesh again. And two references which were brought to my note yesterday were Professor Babu Kuti, the head of the Department of Orthopedics, Government Medical College, Ernakulam, expired again due to COVID only, again expired on 26 November 2020, 3 days back. And next is Dr. Rangachari, senior orthopedic surgeon from Andhra Pradesh. He expired on 27 November 2020. I believe he is the first PG student of combined Andhra Pradesh, and he had served as he started the Department of Orthopedics Warangal, and he has been professor of orthopedics various medical colleges of Andhra Pradesh. Lastly, in head of Department of Osmania Medical College. So these are the obituary references, and as a mark of respect, we will stay silent for a minute starting now. Thank you. We next go to the next agenda. It is the Secretary General's report. This is going to be a repetition of what I spoke in the inaugural function, so I would like to be a little brief. So the new cabinet took over on the 24th August 2019 after Dr. S. Pandian took over as the president from Dr. A. John during the YSCon 2019 at Puducherry. This is the set of office bearers, YSs, the EC members of the various states. And this is the YSS membership. We have a total of around 7,223 members, with the new members around 352. I have not got the details from Telangana yet. So that's nearly around 380, around that, probably 300 to 400 new members. Then the annual conference is, of course, the regular feature of all the state activities. And this was fortunately before the COVID crisis. So all the conferences were held on time during their appropriate times of various periods during January and February. TNOCon, Karnataka Orthopedics Conference, and the TOSACon, where the president and myself were part of the inaugural function there. It was held in a very grand manner. There were 3 executive committee members. I forgot to mention the one held yesterday. And we had a lot of deliberation because these were very important meetings, because we had to take a lot of decisions, especially in this period of COVID crisis. And these meetings are well attended and very useful also. The YSS TraumaCon was held on 18th October 2020, a very well organized program. The theme was non-union and malunion. We had nearly a 5-hour program, very well designed with very good faculty. And I should thank the organizing chairman, Professor R. Selvaraj, and the organizing team led by Professor K. Nagappan and Professor Annamalai Raghupati. This is the around 450 delegates attended the conference, and the efforts were made to get credit points from the Tamil Nadu Medical Council. The YSSCon, where we are now enjoying the academic feast here now. It was a very rich content and very well organized. And I really do not think it's something like virtual at all. It looks like I'm experience-wise, I feel like being in a conference. And these are the various programs, and the non-academic talks were also there. One today also we had it. And then the great effort was put to bring out this YISS bylaw, because the one we were following all these years, nearly 19 years, was the one which were written by our founder fathers. And there were a lot of ambiguity, and we had to go into the, every time we had a lot of controversies and difficulty in interpretation of the various rules. Hence, we needed a comprehensive bylaw, and efforts were put, and this EC went into this, and we had brought out the YISS bylaw now, which is very useful. This was released by our president during the inaugural function, past president. Okay. The Journal of Orthopedic Association of South Indian States, Dr. Raghav, in his introductory speech, was telling that we should get a journal. I would like to remind him that the journal is already there. So this is, in fact, this journal has been handed over to the Walter and Kluwer publishers. I'm sure they are going to do a wonderful job. Already I can see the glimpses of what is going to come in future from the first issue itself. And thanks to the efforts of Dr. Suresh Pillai, one another quite an efficient person. He's already got the Kerala Orthopedic Association journal indexed, and with that experience, I'm sure he is going to index this journal also. And Walter Kluwer has also promised that they will put in all their efforts to get this journal indexed. There's a lot of negotiation which went into the bringing out the journal by the Walter Kluwer. To say in detail, in fact, the initial cost they quoted was around 1.5 to 1.6 lakhs each issue. And after a lot of negotiations, they came down to 80,000 per issue. And we plan to bring 2 issues per year. And this, I'm sure, is the requirement for getting it indexed. And already Suresh Pillai started job. The next issue, I was told that it's going to come out another 2 more months. So I only welcome all the members to send in their articles to this journal so that we can get this index at the earliest. This was released, the journal was released by our present president, Dr. Raghav Dutt, in the inaugural function. The YISS newsletter, this is the one, this is going to act as a record for all the activities which are undergone throughout the year. And this is the second one, this is the second newsletter. The first one was released during the YSCon 2019 Puducherry, and both these newsletters are going to be put in the website. Already the first newsletter is on the website, and this is going to act as a record of all the activities which is undergone for the association. And this newsletter was released by our President-elect Professor R. Selvaraj during the inaugural function. Now the Journal of YISS, which was pending, there's a lot of hiccups in bringing out this journal, which was released during the previous conference, the YISCon 2019, and thanks to the good efforts of the then President Dr. S. Pandyan, this has been brought out, and a PDF copy has been sent to all the members by email, along with the our traveling fellowship details. So why is a traveling fellowship, which was instituted 4 years back, not 4 years, I think it was around 6 years back, has been set in motion now, and the various dates have been announced here. And the details about this fellowship can be you can go into the website and go into the various details about this why is a traveling fellowship. I once again request all the younger orthopedic surgeons to apply for this, and the application form is also there. You can download it from the YISS website. Now the activities of member states, I'll be very brief because we are going to have a section on the report by the various members from the salient ones. I'm going to mention it here now. Of course, starting with the journals of the various member states. The Kerala Orthopedic Association has a journal, the Kerala Journal of Orthopedics, which is indexed. The Journal of Karnataka Orthopedic Association, and the Journal of Orthopedic Joint Surgery brought out by the Tamil Nadu Orthopedic Association. So all these, I'm sure these journals are going to get indexed in the future, near future. And 2 monographs are brought up by they were released by the OSAP, the Andhra Pradesh chapter. One is on open fractures, another one was on orthobiologicals. Now, these are the various academic activities of the Tamil Nadu Orthopedic Association. I think you can see the numbers there. and quite a number we had. Then the because of the COVID problem, we wanted to continue with the academic activities, and there were a lot of webinars organized, and each association had their own series of webinars. This is the OSAP series of webinars. Then the Telangana Orthopedic Association also had their series of webinars. Then the Tamil Nadu Orthopedic Association came out with the PG teaching program. I think we are having the 32nd, today is Friday, yeah. I mean, yesterday we had the 32nd teaching program, and this has been regular feature on Tuesdays and Fridays. The KO webinar series again has been very successful and well organized. And small state as small as Posterior also had the series of webinars. And all the member states took keen interest in the activity of Bone and Joint Day in this year. In fact, we did not want to have the best chapter award this year because we did not think that we are going to have too many activities this year. But contrary to our belief, we had a lot of activities. In fact, we should have had the best chapter award also this year too. But however, probably, hopefully the COVID crisis will settle down and we'll have the award next year. And this is the Bone and Joint activities by Kerala Orthopedic Association, the Pondicherry Orthopedic Association, their activities, and walkathon by the Hospital Orthopedic Association, a part of the Karnataka Orthopedic Association. So this is in short about the activities of the member states. So with the permission of our president, can I go ahead with the next agenda,
Yeah,
which is
please.
confirmation of resolutions of the EC meetings?
Yeah.
Yes, sir. Yeah. So I will just finish off this one also as I think. So the we had I'm going to bring in the resolutions of the two meetings here. The first EC meeting, we had the OSS TraumaCon 2020 to be held in Chennai and OSSCon 2020 in Hyderabad. The EC decided to postpone both the programs due to COVID-19 crisis, and the EC was uniformly of the opinion that the program should not be cancelled. A nomination of orators for the Dr. Sudhakar Shetty oration and Dr. SSK Marthan orations. The orators shall be from member states in rotation, and the orators, 3 names should be suggested by the member state to the EC, and it is the EC that will finalize the orator in the second EC meeting. The orator for Dr. SSK Marthan oration will be from Andhra Pradesh, and the orator from Sudhakar Shetty oration will be from Kerala. The YSS Journal Editors Report as regards the 2019 YSS Journal, the EC decided to print 100 copies for distribution to the EC members and the state office bearers, and all the YSS members will receive in the form of e-journal. This has been done now. I'm sure all our members would have received, because over the last 1 week, we've been sending all the members the e-journal as well as the details about the fellowships along with the application also. The YSS Journal, comparing the proposals for Walter Kluwer and Orthopedic Research Group, it was decided to go with the Walters Kluwer and go for both print and online. The journal is to be released during the virtual conference in November. So we have released the journal now. The YSS newsletter, Dr. Roshan Kumar, the Secretary of the Karnataka Orthopedic Association, volunteered to bring out the YSS newsletter, which will be released during the virtual YSSCon 2020. This has been done. The YSS TraumaCon 2020, Chennai, Dr. R. Selvaraj, the Vice President of YSS, informed that the virtual YSS TraumaCon 2020 shall be held on the 3rd Sunday of October. That is on the 18th of October 2020. Again, this was held on the same day. The YSSCon 2020 Hyderabad, the virtual YSSCon 2020 shall be conducted on 27, 28, and 29th November 2020. The usual features like orations, 3 numbers, of course, the named orations and the presidential oration. The medal papers, both PG and consultant, free papers and guest lectures shall be part of the proposed virtual meeting. EC meeting shall be held separately on Friday 27th, and a general body meeting shall be held on the 28th Saturday. The changeover of the office bearer shall take place during the validatory function. This is only for the secretary and the treasurer, for the president's changeover has taken place. A nominal registration fee of ₹1,000 shall be charged for the delegates who are going to take part. The EC was informed by Dr. Aneen that the YSS Dr. Sudhakar Shetty oration shall be delivered by Professor T.S. Gopakumar from Kerala. Dr. Raghavat promised that he will contribute ₹250,000 to the YSS as the contributory amount. The YSS bylaws, after detailed deliberations and necessary corrections, the draft of the YSS bylaws was approved by the executive committee. As prior permission had been taken in the last AGM and the EC permitted the release of YSS bylaws during the inauguration of virtual YSSCon 2020. The YSS Traveling Fellowship, the EC decided to go ahead with the initiation of the YSS Fellowship. The EC was informed the following timelines regarding the fellowship. So these are the various dates, the details of which you can go into see the website. And the EC decided to set a deadline for submission of membership subscriptions by the virtual YSS TraumaCon 2020 as so as to enable the treasurer to settle the accounts before handing over in November during the virtual YSCon 2020. But this is still pending. Almost 3 states have four states will have to respond to this. The EC decided to do away with the Best Chapter Award of YSS and honoring of senior members at YSCon this year, as not many activities are taking place due to the COVID crisis. The EC decided to take the help of Dr. Tirunarayanan from Tamil Nadu for renewal of the registration of YSS pending for the past 6 years, which is a very difficult task. Of course, this work can be done only after completion of the filing of returns with the income tax department. President, can we go ahead with the treasurer's report?
Nalli, there was a small change you have done.
Yeah,
we have done. That is the fellowship amount as was made 30. You have shown that has to be approved. That's all.
We will have it not now, no? We'll have it.
You have shown it. You have shown it there.
Yeah. Okay, now.
No, that is just because the interest rates have come drastically down in the last 1 year due to COVID and all. It has come down to around 6% now from the 9 in FDs itself.
So we want the general body to approve 30,000 rather than 40,000.
Yes, approved.
Okay. Yes.
Yes.
Okay, we'll have the treasurer's report now. Dr. Nalli Gopinath.
Yeah, good evening, respected President, respected Secretary General, and all honorable members of the August Association. Our account, OASIS account, is held in State Bank of India, Chemias Road branch, Nandanam, Chennai. And these are the details. Next slide, please. At present, we hold around 11,50,301 rupees. And the expenses in the year of 2020 was 46,712. This was towards the certificates and medals for the OASIS Con held in 2018 and 19. Next slide, please. We also have fixed deposits towards the medals. We have 3 of them, one of 5 lakhs worth, another one is 10 lakhs, and then 2 lakhs. All these are for gold medals. These are fixed deposits. We've been taking steps towards auditing of our accounts, which has been pending for the last 5 years. And this is done by Mr. R. Bhaskaran of Chennai. We are proceeding. We have already initiated the process and should be over in around 3 weeks. He has promised that he can do it in 3 weeks' time. And we'll be submitting the accounts to the next treasurer by the end of December. The auditor has already visited the IT office 2 weeks ago.
This is the acknowledgement receipt. You can see it here. The e-filing was done on 6/8, as you noted here, 6/8/2020. And in fact, this I got it last evening. So as soon as he got this receipt, in fact, the acknowledgement, he passed it on to us. So he is really at the job, and we hope to finish the process at the earliest.
3 weeks.
Because, since we are not submitted to 5 years, now the procedure has become very, very difficult. And in fact, he has told us that he has the present person who's occupying the post was taken over as a good friend of one of his close friends. And he says that he will try to finish at the earliest. Probably he is asked time for just 3 weeks. Hope we finish the process in 3 weeks.
Yeah, definitely. Yes, we'll follow it up. Thank you. Next slide, please. Then contribution, there's one pending contribution from OASIS Con 2017 from Dr. Sharad Rao. And this was pending because of GST number. However, our auditor is of the opinion that associations, academic associations need not have a GST account. And hence we sent letters through our Secretary General to Sharad Rao. And we hope to follow that also.
Yeah, again, I try to clarify here, because we were waiting for the GST number, and we were told that GST number can be obtained after filing the IT returns. But then I had a detailed discussion with the auditor, and finally he came out with the opinion that the academic associations need not have GST accounts. And he says that if you are going to have a GST account, you will have to file statement every month, which is a very cumbersome process.
Tedious.
And that's the reason I said you don't have the GST account. And then this was in fact revealed to us only last March or something like that. And we have sent remind letters to Sharath.
Dr. Sharath is here. Why don't we ask him if it clarifies the position? That will solve the
That'd
problem.
be great.
Yes,
Sharath?
sir.
Dr. Sharath Rao is here. If he can speak and clarify.
Yeah.
Dr. Sharath?
Dr. Sharath, sir.
Is he there?
He was there, sir.
There, but his audio and video is muted. And
can you put up in the chat box otherwise?
Yes, sir. We'll put it up, and then once he comes online.
Yeah.
Yeah.
I think the problem there was that the amount was deposited into the Mahe University account, and they probably need a GST number, I think. I vaguely remember that, something to that effect. So there may have been issues from that. We'll clarify later, I think.
Yes, sir. We'll ask the auditor to probably clarify it again, sir, with the team, sir. We'll ask the auditor to talk to them, sir.
Let's go ahead.
Do that, sir. Yes, sir. Next slide, please.
Yeah, that's it.
Yeah, thank you. Thank you.
So we
one minute, Dr. Raghav.
Yeah.
I mean, President, sir.
Yes.
I have only one suggestion.
Yes.
Somehow we have to get rid of this GST number, because once you start the practice in one conference, because it's a collection for the government, so they are likely to insist for all the conferences everywhere the GST. So let us be little careful. And Ajit, you can also look at how best the university, whatever may be this thing, let us not bring the GST into the picture at all.
See, I agree, but the problem comes when the conference, the companies are asking for a GST number before they give us money for the conferences.
Yeah, I think, Dr. Nalli, you have to ask Bhaskaran about this, because I had a discussion with him before.
Yeah.
See, once you make it as a commercial thing, any conference, we have been collecting from a lot of companies on this. So that is why this.
Now it's there is a problem.
See, now the organizing committee is going to start their own account, right?
Yeah.
You can have a GST number for that account where you're going to file all the expenditure statement and everything.
Correct. And he is quite willing
the
to
association
accept.
is not in any way concerned with this at all. The auditor was very firm that please don't get a GST number. Once you get it, you're caught. So that is why I decided not to go for it. In fact, all the time we were trying to do that. I was in the process. In fact, I want to visit myself also. The good thing I took the advice of the auditor.
Raghav, I think you can find out what is legally right. And in the next EC meeting, I think you can go ahead and get it done correctly.
Yes.
Okay. And before going next agenda, I think we need to have someone to coordinate with the auditor. I think the mistake what happened the last 3 years where it was not filed, when the previous Secretary General was there was no one to coordinate with the auditor. So I think I vaguely remember that Dr. Vijayaragan was doing that job. And probably he's too busy a man to now look after all these things. I think we should have someone here. I think I will volunteer to see to it that this is timely, the returns are filed every year. And I will coordinate with the respective Secretary Generals whenever they are there. I think
I have, Nalli, I have a suggestion, President, sir.
Yes.
See, this is constantly happening through Chennai, because this auditor is known to me and he has been doing it almost for the last 20 years. I think some permanency is required here. If Nalli is offering this, why not we create a permanent treasurer's post?
No, sir. No, sir.
Not necessary.
Yeah. No, because that otherwise every time, it goes, now Nalli is in Chennai, he's now coordinating very well.
No, sir, I will coordinate with the treasurer. I'll see to it that process should start in March or something like that. I will see to it that it is done.
That is great. That is great. Then it's fine.
No post, sir. Please, no post. Yeah. I will assure that I will do that.
Okay.
So, Raghav, you got to unmute yourself.
Now, what we have to do is, now our office is in Chennai. So we need to establish a small secretariat there.
Sir,
And
next agenda, sir.
yeah.
Sir, next agenda, sir.
Yeah. No. Let's
Please, sir, because my report is not over, sir.
I know. Now, just 1 second. Please wait. All what we have to do is to have auditors in Chennai only.
No, yes. No, that is the, see, now we are having our accounts there. We need an address, permanent address they ask for.
Yes.
If you are going to change the address and you're going to change the bank, it is going to become very difficult starting another account.
Anything now.
So that's what we did. Last time we had a lot of difficulty.
Yes.
We transferred it from the same account was transferred to Chennai. And it is now, we will not hear of transfer because last time we were transferred to Warangal. So we had a lot of problems. That itself took 1.5 years. So year after, we will not do that mistake. Let that be in Chennai itself with that address. So this address is going to use for banking purposes as well as for the registration purpose.
Totally
agree. If we are going to change the headquarters every year, then every year we'll have to start a new process of registration, which is very, very cumbersome.
No, we'll stick to Chennai only. That's decided.
Yeah, better. That's the reason why we got an address there.
Right.
And I think TNO was good enough to give us the address.
Thank you.
They were willing to share it without any extra cost, because otherwise we'll have to pay for that also if you're going to have an address there.
Thank you, Nalli. You removed my residential. You removed my residential address. It was the address for almost 16 years.
No, sir. That will be done only after registration, sir.
Okay. Right.
Yeah. Yes.
Next one.
Thank you, sir.
The next agenda is the Voice Journal Editor's Report. Is Suresh there? Suresh Pillai. Okay, nothing new to say. I think the journals are rolled out. And the next issue is going to come in another two months' time. I only request all our members to send in as many articles as possible so that we have an index journal another 2 years' time. So the journal was released by our President, Dr. Raghav Datta. Now we go to the report by the secretaries and the activities of member states. So shall we start with the Andhra Pradesh? What's up report?
Yeah, shall I share the screen, sir? Shall I share the screen, sir?
Yeah, you can, yeah.
You are always in the OT.
I cheat.
Night and day.
Yeah.
DMH happened.
Able to see, sir?
Yes. Not the full screen, no?
Yeah, sorry. Sir, I will be quick in presentation. This is our...
Yeah, 2 minutes only, Naresh. Just 2 minutes.
1.5 minutes, I'll finish it up, sir.
Good.
So, it's our President, on behalf of President Subramania Rao, sir, and Vice President of YS is Professor Srinivas Reddy. I am presenting our report. Our membership strength as of now is 101,376, and we had 163 new members added up. So we just prepared the check for the new 398 members which have been pending for the first 3 years, sir. So I'll just pass it on to you. But as per resolution, that I think we need to pay 200 rupees for the last year, but that was not ratified in our general body. So I will be doing that if anything is there after approval from our state general body. So there are a few arbitraries from our state. We lost BP Narsimlu and Narsimham sir and PLN Reddy and Mukherjee last year. And so we are happy to say that we were one of the 5-star chapters of Indian Orthopedic Association last year and second best chapter of OASIS last year. This is our annual meeting conducted from January 30th to 1st February. New president and new team has took over. We had online elections for the EC members for the first time, and we had 4 new EC members joined up. So we had, this is the first EC meeting which was held in February, physical meeting, and then after that we had online EC meetings which have been going on continuously. So instructional course lecture was conducted in mid-year in Kakinada. So the highlights were we had 220 delegates and PG thesis award was conducted there. And our another project monograph is continuing. We had a second issue of our monograph on open fracture, and the third will be releasing soon in the next virtual meeting on case reports. This is a report for the best disease award which was instituted 2 years ago, and is continuing successfully. We had a Lifetime Achievement Award initiated last year, and Pon Chandrarao sir got it. And as per the COVID time, WhatsApp has conducted free online orthopedic consultations, which is Teleortho AP, an initiative done by our state, which was well appreciated and reported in the press. So we initiated WhatsApp research grant last year, and that 50,000 rupees will be given to a successful candidate to conduct a research work from WhatsApp will be given. And then we also initiated WhatsApp British India Orthopedic Surgeons International Fellowship. We had finalized the applicant, but due to COVID he couldn't travel. He will be traveling in the next year. So the few webinars which we have been done, I think this has been shown up nicely. And IOA matters, so we were runners up for the last year WhatsApp. Last year IOA Best Chapter Award for AK Gupta Trophy were one of the 5 chapters, 5-star chapters. And we received KT Dolakia medal. We won the KT Dolakia medal by Dr. Ashok Kumar, and we got the winners for the SM Tuli Best Published Paper Award from Arun Kumar and myself from AP, and we were the runners up for the PG competition, quiz competition.
నేను కొంచెం మీటింగ్ తర్వాత మాట్లాడాలా
తర్వాత మాట్లాడండి సార్
1 గంట.
So membership, the individual awards from were there, and we are happy to say we won the Silver Jubilee Oration Award also last year, 2019, presented by myself in IOM. That's the brief activities of WhatsApp in the last year, sir.
Well done, Naresh.
Thank you, sir.
I think we'll have the next presentation from Karnataka. Roshan, Dr. Roshan. Is Roshan around? Roshan Kumar. Okay, if he's not there, Kerala. Can you have the president of Kerala?
But he is there.
Kerala is not there. Karnataka, Kerala is not there.
Okay.
Then Tamil Nadu. Tamil Nadu. Very sad states. Puducherry.
So Tamil Nadu sent on our group, sir, some PDF there.
PDF is there, but there should be the secretary should be there presented.
Sir, sorry.
The annual general body meeting. Puducherry.
Nalli,
yeah.
Are they not able to log in? Is that the problem?
How can it be? This is there's nothing like separate thing, you know. Puducherry. Who else is there? Telangana. Vijay Bhaskar, sir. Yes.
I'm here. I'm trying to share this thing.
Yes.
I'm just trying to share it. I'm not able to get.
There's a green button, sir. It shares screen share screen.
But the file I'm not able to.
Read it out, sir. Otherwise.
Yeah.
Read it out, sir. Otherwise.
Read it out. Yeah.
Shall I read it out?
Yeah. Please do that.
Sir, good afternoon, all of you. The TOSA is the Telangana Orthopedic Surgeons Association. We have about 689 total members up to date, and IOA membership is about 6 members. We have about 11 districts, and a new district association is formed this time, and we have organized about 14 virtual conferences and a lot of CMEs and 2 workshops. Then last year we had a conference at Nizamabad. There were about 680 delegates, and then the IOA executive members attended this program. Following that, we had a ankle foot course 2020 at Hyderabad, and then we had following that we had a graduate academic conference Then, sorry, this I'm not able to. We had a EC meeting in the last Nizamabad conference, and following that we had a trauma con, and then we had a very good regular webinar conferences in our state with the support of corporate hospital orthopedic associations. And we had an ankle foot, and we had a Hyderabad Advanced Shoulder Arthroscopy Congress 2020 on 22/3/2020 at the Hyatt Place. Our president, Dr. P. Sudhir Kumar, taken over charge as a president of TOSA, in Nizamabad. And a new district chapter is started in Telangana, Siddipet District Association. That's all, sir. That is the up-to-date. Hello? Hello?
Yes, sir, we're able to hear you.
Yeah,
Vijay Bhaskar, able to hear you, yes.
Yeah, thank you, sir. Thank you.
Thank you, Vijay Bhaskar.
Yeah, thank you.
Yeah, I tried to contact secretary from Kerala, not responding. Secretary from Tamil Nadu, not responding. Vijay Raghavan, he says he is not aware of it, or is it really? He's trying to join now. And not able to contact Roshan Kumar also, the secretary of Karnataka. Very, very unfortunate.
Sir, 1 point from TOSA he missed.
Yes.
Nalli.
Yes.
Shall I tell? Dr. Vijay Chandra Reddy speaking.
Yeah, tell me.
Yeah, he missed that now as Dr. Raghav has taken over as president.
Yes.
Myself, I have become the vice president
Vice
now.
President, yes. I'm sorry. Yeah. Both are important points. And some of the professors are felicitated by certain important also. Those are missing. I'm not able to trace out them in my PPT.
Okay. Yeah.
There's some problem with technical problem in my PPT.
Okay. Right. Shall we go to the next?
Dr. Rangachari expired yesterday. He's one of the senior academic professor.
Yes.
Dr. Rangachari, sir.
I think we mentioned it. We mentioned it in the obituaries also.
Yeah.
Thank you, Dr. Vijay Bhaskar.
Thank you, sir.
Yeah. Okay. Next is the virtual VIS trauma con. Is Dr. Selvaraj around? Okay, as told, there are 450 delegates and around as told 46 faculty members, and there was a 6-hour program, very well organized, and topic was non-union malunions. Okay. Can we have a report from the present organizing team? VISCON 2020. Can someone give us the total registrations, number of faculty, number of papers received?
Karthik is there.
As of the start of the conference, we had 1,238 registrations. We've also added quite a few speakers who had not registered. And as of this afternoon, we have a total of 1,388 registrations, and that is going to increase today as well as tomorrow. So we are hoping that we will cross around 1,400 plus.
Okay.
Total abstracts received were 863. We have 266 faculty, 22 of them being international, the 6 consultant gold medal papers, postgraduate medal papers, and 163 free papers. We received 540 e-posters, which are all displayed in the e-poster hall.
Yes. Yeah. At this moment, I would like to inform that we have I think we shall be receiving the report from the judges. I've already received the report from the postgraduate medal session, but I've yet to receive the report from the consultant medal session. And regarding the e-posters, since the number is around 540, and Aneen was telling, no, like if they even devote 3 minutes for each poster. Aneen, can you tell me how many days it'll take?
Takes around 1560 minutes. That is around 30 hours.
Okay, 30 hours. So they requested me what to do. They wanted some more time. So since I think let them do a good job. There are 3 people at it. Aneen, Vijay from Tamil Nadu. One more person is?
Yes,
Who's the other one, Aneen?
Aditya Kapoor.
Aditya Kapoor. So there are 3 people who are at the job. And I think I seek the president's permission to ask them to submit it a bit later.
Yes, sir. And also
anyway,
what
we are going to distribute the medals only in the next conference.
Yes, sir. So what we are going to do is we are going to record all the posters onto a Google Drive and allow access for only the 3 judges to be able to go through it at leisure whenever they have time, so that the process can be completed even quicker.
Yeah, I think this is an unprecedented situation because we did not expect 500 posters. Normally we have around 120 or something, 130, 150. That is a small number, but why 40 is a big number. I think we will leave it to the judges to do a good job. Rather than rushing up and then doing a half-hearted work, we will permit the judges to go through it. And the announcement of the names of the winners will be made during the inaugural function next year. Maybe we can announce the results in the website with the permission of the president again. Yeah. Okay. Next agenda. YSCon 2021 is going to be held at Aircord, Salem. Mani, are you ready with your presentation? Mani? Mani, unmute yourself. Mani Maran.
Yes, sir. Yeah. I'm here.
Can you share your screen?
Yeah, sure, sir. So can you see, sir?
Not shared. Not yet.
Not yet?
Not yet.
Not shared. Screenshot
Yeah.
shared.
Yes, you're getting it.
Can you see, sir, the image?
No, we're not. Yeah, we can see the. We're not seeing the video. Yes.
Yeah, we are just seeing the icons.
Yeah.
Double click opening. Right click and open it. Open.
Probably you got to give open with there.
Open with, you can go VLC media.
No. Open with. No, second one.
Second one.
Yeah.
Second one. Open with. Oh, he's going.
Open with. Yeah.
VLC media.
Yes.
Yeah.
No.
Just bring it down. Then just bring this one down.
Sir, many times videos doesn't play actually.
Just close this. This one.
Pass it on to the
file.
Yes, sir.
Just close this file folder.
Okay, sir.
Might be underneath.
Yeah.
Might be underneath.
Control room can do that.
No, they can't do.
Control room can do that, I believe.
No, we can't do it at the control room because the file is on his. It's not recorded before.
Can share it, sir. You can share it
Yeah,
and put
I'll
next
do
video.
the presentation, sir.
Yeah,
Okay,
no problem.
yes.
Go ahead.
Poor thing, he had made a lot of efforts to prepare a video. Okay. First slide.
Yeah. Can you see this?
Yes, Mani.
Sir, respected President, Secretary General, and other senior doctors, I welcome you all to Salem YERCAD ZoasisCon 2021, which will be held from 10th to 12th September. On behalf of Midwest Ortho Society and TNOA, I welcome you all to Salem. So it's a warm greeting from our organizing desk, and it gives an immense pleasure in inviting you all to the upcoming OSisCon. Come and experience our Tamil culture, the traditional hospitality, and an excellent academic program, which will live up to your expectations. Don't miss the serene beauty of YERCAD. I know most of them will be knowing about YERCAD. It's a beautiful hill station, which is very calm, quiet, and very clean. And it's easily approachable from Salem also. It's just 32 kilometers from Salem. So this is our organizing team, and Professor Selvaraj is our organizing chairman and the president-elect. And my colleague is Dr. Frank Kirba, who's a senior colleague from Salem, and myself, Dr. Manimaran. So YERCAD, it's a small hill station near Salem. Why we selected YERCAD is like we want to come out of the hustle and bustle of the cities and from the COVID, the post-COVID era. I think this will be the first conference, probably the live conference going to happen in YERCAD. So we want to keep it in a good place, like not in the city. And it's a beautiful town. You have a lot of resorts and comfortable stays. It's guaranteed. We have almost more than 120 resorts in YERCAD, and we can accommodate up to 2,000 to 3,000 people at a time. And this is going to be our venue. It's called Alliance Convention Center. We have the incapacity of around 1,500 persons. And one more hall they are making in adjacent, which can accommodate another 1,500 persons. So totally we have capacity for 3,000 people. And
is it?
Yeah.
That's it,
yeah.
Mani?
No. We have two halls here, the bigger halls. One is the blue hall, which has got a capacity of around 750 people with good audio visual setup, and another red hall with 300 persons. And another yellow hall with another 300 persons. And we have a boardroom for our EC meeting also. So everything is built in. So it's the excellent audio visual facilities they have, and I think definitely it will be a good venue. It's going to be a good venue for our conference. And this is our website, which is on. We started in preparation, and it will be coming. It will be ready in probably in a couple of weeks. So I welcome you once again to Salem YERCAD for OSisCon 2021, and from 10th and 12th September. Please mark your date, and we are going to do it in a big way. Hope everybody will enjoy. Thank you, sir.
Mani, has the registration started?
Yeah, we are starting from January, sir.
Okay. Thank you, Mani. That's great. Yeah. Can you stop sharing the screen?
Yeah, sure, sir.
Yes. Okay. Yeah. So that is regarding OSisCon 2021 in YERCAD. Yeah. Then submission of OSIS membership subscription. I think today Naresh has told that he's handing over 39,800. That is, Naresh, this is for all the 3 years, is it?
It's a 3 years, sir.
3 years.
After you took over as a secretary and I took over as secretary.
Okay, so that's it. So Andhra Pradesh is paid now. So how about Karnataka, Puducherry, and Telangana?
We will send it to you, sir.
Any deadline?
Within a week.
Within a week.
Sir,
okay, who's that?
Nalli sir.
Yeah, yes.
Sir, I will take the responsibility of that, sir.
Okay, sir. Okay, sir. Right. Thank you.
Okay, sir.
Karnataka, anyone from Karnataka? Why is there from Karnataka?
Yes, Nityan sir is there.
Yeah. So anyone can.
Sir, I take this opportunity to say that after the conference of the state, within 1 month, this has to happen now onwards. You can't wait for years.
Okay.
The problem with it, Anin, the problem is the timings are different. Your calculation for year comes from August to August. Our
No, I'm telling you, your conference,
Yeah.
whenever you finish your conference, 1 month from that time. That's it. So no problem.
Okay. Right. Now, any other matter with permission of chair? I think before this, the next is just the word of thanks. I just want 2 minutes from the members. I just want to thank the cooperation extended to me by all the, because this is the last meeting I'm going to, the official meeting to be organized by the YSS. This is the last meeting for me. I took over in 2017 after conclusion of YSCon 2017 in Manipal. And it's been quite a tough time for me because as far as the YSCon is concerned, all the 3 YSCons had problems. The first one at Kerala had floods. The second one, there was problem as far with the venue. The third one, of course, the COVID crisis. So anyway, somehow with the cooperation of the the office bearers of the respective member states, we were able to overcome all these things. In fact, I'm quite happy with the way all 3 conferences were conducted. It's only the members who had not responded well to these conferences, because Kerala, we cannot say I really enjoyed, and the ambience also was very good, very well organized conference. It was the members who missed it. Similarly, in Puducherry also, though we had tough time in last minute shifting of venue, the venue was quite good, quite adequate also, and very comfortable also. Once again, the members did not respond. Of course, this virtual conference has been very well organized. This is a memorable conference also here. Next is the cooperation extended by all the office bearers of the member states. I cannot say I cannot expect more. It was roughly, they were very cooperative. The only thing is probably they were a little lazy, not attending the easy meetings and all. I think that has to, somehow we'll have to do away with that, because I was not happy with the way the members attended the EC meetings. There were at times when one entire state was not represented in the EC meeting. So this is very bad. I think somehow probably the next president will take over and do something for that. Otherwise, and one more thing is I had real tough time in handling the accounts. It literally took 2 years for me to start operating the account. Last 1 year only, we were able to operate the accounts. In fact, that is the reason why the treasurer presented 48,000, which I had to pay from my money, because we were not able to pay it from the YSS accounts. So 48,000, I just got it 2 days before the conference only from the treasurer. And then if that had been, if we had filed the IT returns, I would have definitely completed that task and also the registration task. These are 2 tasks I am not able to do that. However, I assure that I will help in getting the YS re-registered again, complete the registration process with the help of Dr. Thirunaran. In fact, I invited him for the EC meeting yesterday, but he was out of station. And I assure the association that I will be at the job and try to complete my task there, the process of completion of registration. So with this, I would like to thank each and every member and all the member state office bearers for extending the fullest cooperation to me. In fact, I enjoyed the tenure as the Secretary General of this great organization. Thank you.
Thank you, Nali. I think we should, the general body should place on record the invaluable contribution by Dr. Nali Yuvraj. He virtually controlled the association along with the presidents and put in place a lot of laws. That was the most important, and the organization is now on a good, even keel, and I really thank you. And just to remind you, you're not going anywhere. We have decided that you'll be there. Like
Yes,
it or
sir.
not, you have to be there.
Yeah,
Because the most important is Secretary General to, implement the things, because the new Secretary General, so many laws, you have to guide Anin, and then with both of you together, I'm sure we can, give a solid foundation to ISS. Thank you very much, Nali. Thank you.
Okay.
Really appreciate.
Great.
So now any other matter with the permission of chair, Dr. Raghav, it's all yours now.
Well, I think what we will do from next time on is to have the welcome address as a presidential address, that we will do it so that the president doesn't need to speak again. And now it's for members to say a few things, especially just if I may ask Ajit, he has already submitted the oasis in coma that we will contribute, that we will circulate. And I think it's very important for, unfortunately, uh, uh, we need to, Selva is not here, we need to establish a secretary, and a lot of things will fall in place, and a lot of headaches for sending mails, etc., will be taken off the shoulders of the secretary generals. That's what I think. We'll do that in the next week. Yeah, any member that want to advise, raise points?
So, Dr. Raghav, what is the, number of the participants of this general body today, virtual?
That only from Delhi we can get the number. Kiran? No, Kiran.
33
How
people.
many are attending the general body now?
33 people.
33, only 33.
No, that is people who are logged in.
No. This is the people logged in here into this site. And I've asked for the numbers from Karthik. I've given the job to him.
Roughly about 98 people are attending the general body, roughly.
Okay.
We get that number from the Delhi.
This was at 3:23 p.m.
At 3:23, there were 98 people.
Yeah, I've asked them to take it at 3 times. One is 15 minutes after start, then 1 hour after start, and at the end of the meeting also.
15 minutes after the start, it was 74. Then 3:23, it was 98. I will tell you right now, sir.
Yes.
Good.
But more than the members, Vijay, the key members are missing. That is the main issue.
Yeah, that is the problem.
That is not a good thing, as Nali says.
We are repeatedly asking the executive members to at least to share their ideas, to attend, but still we are the only 10-15 people are seen always. All the meetings are all the opinions. Okay.
Let's communicate more and do that in the coming years.
Yeah, in coming days, I think the communication aspect we should more strengthen. I think that is the most important thing. As Dr. Raghav repeatedly says that office secretary, his dream, I think it should come true.
No, as I said, Vijay.
Yeah.
As I said before, I'm just repeating. We may give 5 lakhs, or perhaps more also.
Yes.
So another thing, Nali, I need your suggestion on this.
Yeah.
Now, instead of asking every state how many members you got, pay $100, $200, why can't we ask each state to give 1 lakh rupees every year? State can easily do it. What do you think, Ajit?
Every year. You can
ask, but their general body should accept it. No.
That's the problem.
See,
you can ask them.
It's our general body, isn't it? We're all South Indian.
No. Raghav, we can ask so many things. But thing is that their respect is there, how their members respond.
See, their members will respond if the presidents and president-elects like you, vice presidents, if you put pressure. See, instead of taking 200, 500, why can't we give 1 lakh?
President Raghav,
yeah.
I just thought you have created such an excellent platform to have task forces, and you have had a lot of constitutional amendments to be done which were discussed. Why don't you put a small task force of 5-6 people to look at the constitutional amendments that needs to be done, and that can be sort of got approved in the next general body?
We're doing that. I've written down that.
Yeah.
We are planning one for constitution, one for orations, task force.
Okay.
Yeah, we're doing that.
Okay.
I'll circulate very shortly. We'll have a meeting.
Yeah.
In the next 1 week, I will sit down with Dr. Anin, and we will select the task forces.
Yes. Okay.
But these are not members of EC. They'll just guide the EC.
Correct. No, the idea is excellent. Only thing is these task forces should be given some target time for them to come back with the report so that you can consider it in the EC and take it.
Before
Dr.
the first
Vijayaraghavan,
EC.
what do you think? Should we not collect 1 lakh rupees per month instead of taking this, small amounts, which is difficult to calculate?
From each state, yeah. See, these are also amendments. See, at that time when we started, money was not the main issue at all. That's why we made the small contribution of 100 rupees. Now, this is a very good suggestion that even on a yearly basis, the state associations can be asked to provide 1 lakh as a fund towards YSS. And you can cut off this. They can just give the list of names of members to be accounted for. And easily they can even give 100 names or 200 names or even 300, whatever it is.
Doesn't matter.
Yeah, correct. No, this is an excellent suggestion. I think some of the ideas that you have floated are extremely welcome. It is high time we started introducing them. And I must place on record the extraordinary service rendered by Dr. Nalli Yuvraj. He has set the registration as well as the accounts process very, very well. So now the future, and I have no doubts that Anil will also take sufficient interest to see that this moves forward. So ultimately, as rightly told, I think by Dr. Vijay Chandra Reddy or somebody yesterday, that it depends on the president and the secretary to drive the whole thing process forward. That somehow will yield better results.
Dr. Vijayaraghavan, I mean, with this method, which I just suggested, right? I went very fast because of lack of time. See, we need, we'll get 5 lakhs from Oasis. Please support us in these ventures, right? Please do that.
Yeah.
See, the only thing Dr. Nalli Yuvraj was saying last 4 years is no money. That was the main concern. Now see, if you get 5 lakhs from Oasis, TraumaCon 2 lakhs, 1.5 lakhs per CME, that is 9 lakhs. And, each state giving 1 lakh, 6 lakhs. We will be touching more than 16 lakhs per year, just like that to Oasis. And it's not a big...
Absolutely. But that's what I'm saying. Now, these are the constitutional amendments you must do.
Yeah. That's right. With permission of general body.
Yeah.
Raghav. Yeah. See, it's very important that we take the opinion of the presidents and secretaries of the member states.
Sure.
Correct.
See, we have not taken an opinion at all and just deciding that. So we should allow the president secretaries first. They are the stakeholders. They are the ones who are going to execute what all we are going to decision we are going to take now. If we are not going to take that confidence, then it's going to be difficult.
No.
I think you allow all the press secretaries. Is it possible for them to give 1 lakh per year?
Can I just come in on that?
And then decide, because it is not just aristocratic way of deciding just and implementing it. This will not happen then. Nothing will work. That's a problem. So I would request you to take the opinion of the president secretaries of the member states before taking a decision.
Shall I start from Andhra Pradesh first?
If possible, also the members. There are few members because the members should also be allowed to talk. And I should remind here that members who want to talk, put your suggestions on the chat box. I will see to it that it is brought out in the general body meeting here now.
Yeah, before they talk, my suggestion is, please raise that from 100 rupees, which is nothing peanut, to 500 rupees for each head. That will be the best one, because after 19 years, 100 is nothing now. No, 500 rupees at least.
We have raised it in the last year EC only. We raised it to 200 rupees.
No, 500. I am telling that 200, 100, these are all nothing. 500 is the minimum. Actually, somebody suggested, Raghav, I think, said that it should be 1,000. But at least 500 rupees is the one which is acceptable to everyone, I think. That's my suggestion.
Anyway, Raghav sir has told this. We will find that whether the states are against or for it. We'll just see that here itself.
Yeah, please ask the state presidents or secretaries their opinion raising the membership fees.
Sir, shall I start from Andhra Pradesh? Yeah, sir. So, suggestions are all very good, sir, but we have issues of passing these things in state meetings, state general body, state EC. You can say 1 lakh to be given from each state to Oasis. So issue comes like IOA never asked for money. Oasis is going to ask for money. Why should we pay? And there was a discussion happened in one of our meetings also. Why can't Oasis can have its own membership fee? Whoever is interested can join. You are making everybody to be compulsory member of Oasis. And then in return, we are paying 100 rupees or 200 rupees, which doesn't make any sense. You should have something like, if you want to make a value addition to the oasis, people should opt for oasis, not by forcefully asking them to join, or you dictate terms from oasis to state. This conflict, I think, has been there from very long time. That it looks like from the presidents, because each president can only be there for a state for 1 year. But vice presidents will be there for 6 years. And every year, these vice presidents will be joining the meetings. And there is some conflict, which as a secretary, I know how to dilute the conflicts between the vice presidents of the oasis and presidents of the state. It's a big concern. This is one point which needs to be sorted out. And presidents of state, they still feel they are not part of oasis.
Naresh, that what you have told is right, but you can't be opting out and directly having a membership. Then this structure of state and then going to oasis will not happen. If that
I
is
understand,
there,
Anil. I totally understand, Anil. What if I have to answer for my members of state, why if he is not interested to be a part of oasis, we can't make it by a rule that you have to become a member of oasis. Is it or not? Yeah.
you don't need to increase that much, but
Can I just,
this is not the individual member's choice that is going to become member. It's a decision by the association. When he joins an association, he has to naturally abide by the rules and regulations of the association. They cannot act as an individual. You are an association. So you cannot say that I will not be a part of OS. This has been taken by the state associations at a point of time, which they have to abide.
No, that state
in fact, Naresh,
point exactly about the states, but the states which are at the time of formation were different, and the states which are running now are different.
No, Naresh, I'll clarify this for you.
Please,
I think many people have not understood the conceptualization of oasis. See, it is as Silvaraj told, it is an association's decision that it is like the OG association. I don't know whether you have known the OG part or not. You always become a South Zone member of obstetrics gynecology. You pay the amount also to the South Zone. They pay an amount to the central body. You understand? It's just like that. Unfortunately, IOA never sort of encouraged such things. So we wanted to bring in a similar principle. The members should be made to understand. See, this is an additional benefit. Which organization will give you so much of academic content for 100 rupees and 200 rupees? Choice is all right. I understand choice is all right. Everybody can choose what they want. But, you know, this is an additional feature that is being provided for every member. For being a state member, he has got a chance to also participate in the oasis member. And this brings in unity, supposedly unity. I know that it has not come in fully, but it is supposed to get a unity. Now, today we can boast of 7,300 members. No, even IOA did not get that much support till now because of the automatic membership. But they should understand what are the benefits that they get out of that. Because of this association, they have got every right to ask a participation in a conference as a faculty, as a participation as a member, even all the activities. Now they are going to increase the academic activity to almost 6 or 7 in the whole year. So there is a chance for all these people to understand what to gain out of that. I know 100 rupees or 200 rupees will be an issue. They may create some problem because they have not valued the program that is happening. As rightly said by Raghav and other people, every conference has actually attracted not more than 700 or 600 members. So that is why out of 7,300, if only 600 are going to get a benefit out of that, they feel that why this organization, that type, yeah.
Can I just add on to that, sir? It is like Dr. Naresh in passing mentioned, it is actually the feeling amongst the office bearers of that particular year in a particular state. What are they benefiting from oasis? It is some sort of an ego problem, not that he is losing any money out of this. The 200 rupees or whatever comes is going from a new member. It is not from the senior members. It is from the new members that is being contributed to the association. It is a disconnect between the current office bearers of the respective state associations versus the oasis. So that gap has to be bridged, and that is the responsibility of the vice presidents.
Yes, not the entire state association.
No,
It's only with
it is
the
a disconnect between the office bearers
not
of
everyone.
the respective states. So initially, that is the reason why, if I remember right, the president and secretary were involved in the conference in a respective state, and also all the presidents and secretaries were involved in the felicitation of the senior members.
Correct.
That was the reason, that was to make it all inclusive, to give them some involvement and importance to the respective office bearers of the states. So this is the responsibility of the respective vice president of the states to involve everybody and take them, together.
Point well made. I think, Naresh, what you should do is you should convey these feelings to members, number one. Now, just now in the chat box, Pondicherry, Dr. Vijay Raghavan says that Pondicherry cannot pay 1 lakh. I think even Nali Yuvraj did not get the message I was making. These are just observations. These are all my observations, my ideas.
Raghav,
Right?
Can I just butt in on that also, Dr. Raghav?
Please, 1 second, 1 second. So what we do is all these ideas of ours, from what Dr. Selva is saying, Dr. Anin is saying, Ajit is saying, all of us will, discuss again and again in webinars and all that, and then we will take a call. It's not compulsory. Nothing is passed by general body.
Raghav, can I say something?
As
One suggestion.
earlier,
Okay. Raghav, that's the reason why in yesterday's EC meeting also I said, see, now it's already 4:30 now. The next session has to start. Already all the postgrad students will enter the hall now. So that is the reason why I said we will have a detailed discussion in an EC meeting. So you can even convene it next month itself.
We'll do that.
Next month itself, you can convene the EC meeting, get hold of all the state representatives. You can discuss it threadbare, no? Like you can even 5 hours, 6 hours discussion.
Yes.
And then come out with a nice conclusion, and then you can execute this, because you need not actually wait till the next AGM to actually implement certain, except for the constitutional changes. Of course, the constitutional amendments, you got to wait for the approval from the general body. Whereas other things can be implemented once the EC members agree. And you can have a ratification later. So that's the
Good
reason
idea,
why we
Nandi.
call for a meeting next month.
That's
EC
how it's
meeting.
going to be done.
I think that's the best, because now we can't, you need more time now.
Even if there is time, these are just general ideas. Please remember, everybody. These are just
Raghav,
floating.
As Ajit sir has just pointed out, earlier we used to keep all the state president and secretaries on the stage in the inaugural function earlier. Now we are not doing that. That has to come back to give them. Sir, Ajit sir, you are right. Am I right?
I mean, sir, I think it's not the issue with the secretaries of the state, because secretaries will travel for 3 years with the OASIS. It's a problem with the president, because president will travel only for 1 year, and vice presidents will be there for 6 years. The one
Then it's a joint work of both the secretaries as well as the vice presidents of OASIS to convince the office bearers of that particular year.
There is a conflict.
I don't think it's a major issue.
There is a
I think
conflict.
it is just massaging egos, that's all.
Exactly. Exactly.
Just for 200 rupees, you are going to become a prestigious organization member, and then there'll be a lot of exchange of South Indian academic sessions, and there's a lot of relations spread over. There'll be a lot of unity among South Indians. Why not? It's not questionable, obviously.
Raghav sir, we'll have to put some proposal, solid proposal before the president and secretaries of the states, because their conferences are going to come from January. So they'll have to put it in the AGM and pass it. So we'll have to come up within December and put the proposals to them.
So all are going online, sir, this year? All are going online in February?
We don't know the situation.
Online, but your conferences are there, right?
Yeah. TNOA.
Situation.
Sorry.
What about the EC meetings from next onwards, sir? Virtual or EC meetings?
Anin?
What about the EC meetings next onwards?
Time comes. When the time comes, whether it is going to be virtual or physical, we have to decide when the time comes.
Selva.
No, we can have physical one. Physical one, we can have one easy.
Yeah, we'll plan. We'll plan.
That's better.
That's better.
Physical can be next year.
Yeah, easy physical is not a big deal, I think. Hardly 20 members will be there, no problem.
Yeah. Now,
somebody find difficult, they can come on virtual also. Physical meeting. If somebody find difficult to travel, then they can come on virtual also.
Okay, if nothing more, then can we close the session, Dr. Nali Yuvraj?
Yeah, okay. I think, is that over? Any other matters to brought in?
They are saying that to avoid the conflict for the candidates, why can't they announce in the general body or letter to EC that they're going to contest for this post, so that the EC and general body and OASIS can take them and support them, something like that.
Sir, we didn't understand. Sir,
So the future candidates who are going to contest, see, when we have a conference in Salem, right, they will come to general body and present that we are going to contest for next year.
Okay, good.
So that's a suggestion, so that we know who is going to contest, and then we can promote them, so that suddenly nobody is coming in and spoiling the chances of our candidates. One of the suggestions.
It's a good suggestion, sir.
Yeah. They
Only
can write
OASIS members. Only OASIS members, right, sir?
Yeah, only OASIS members.
Sir, I have only one comment here. It is not that this doesn't happen, but the attendance in the general body is as usual for OASIS not greater than 100 to 150. So how can 150 people influence 7,000 people is what you have to see. Because all this is excellent idea. Idea-wise, it has to be encouraged. Every time people will have to definitely request the general body wherever it happens and request for that. But then it is a very small body, and at the end of the day, they do not get transmitted to the entire population.
We'll make a start, sir. We have to make a start from that.
Also, irrespective of what the GB decides, what if the candidates just goes about and campaigns?
Nothing can
how
be
can
done.
you stop that? You can't stop that. So what steps can the body take? Nothing.
We can just propagate. That's it.
And all North Indian contestants are also members of South Indian states, sir.
That's what I want to raise, Naresh, because we must support a candidate from South Indian state who is residing and a member of OASIS. Not a
why don't you take off this your membership? Don't give it to outsiders.
We can give it to them, but give it as associate member status. Yeah. Why do you want to give life member status?
Yeah, that's what what's up the same thing.
Honorary member.
Honorary member. Taking it off. You have to be
converted into associate member so long as they are not working here.
Vijay,
yeah,
we have a rule in Telangana.
Yeah.
Whoever is practicing in the geographical area of Telangana, only he can become a member of TOSA.
Correct.
Actually, a lot of people who have come in from North India are not allowed by law.
I'm very happy. I am very happy, but you are a recently formed association. Many associations did not have constitutionally such rules, but they have to look at that. They have to look at amending such type of things.
Yes.
They have to amend it and then not allow. I know a lot of IOA so-called prospective candidates becoming across the country members by paying money and then taking that they are members of this and members of that.
Yes. No, we'll put a stop to this.
See, I again, Raghav, to your point, not a single contribution in academics. Take that. Not a single lecture given, not a single this thing given. However, member and, all this fellowship time utilized and then taken advantage.
Vijay, my heart goes out to you. Believe me. My heart goes out.
Dr. Raghav.
Yeah.
Dr. Raghav.
Yeah.
I think this subject is really vast one and needs a lot of brain hunting for this. I think in the first EC meeting, you should put this on top of the agenda so that everybody will come with different ideas and we can discuss threadbare.
Yes.
Having said this, number two, before you sign off, I would on behalf of OISIS and from Karnataka, especially from our president and president-elect and secretary, I would like to thank and place on record the fantastic job done by Dr. Nalli Uraj.
Oh,
He's
thank
done,
you.
he's done a
Yes.
fantastic job. I really envy him how he has found time, and he's communicated with everybody, and he was spot on. And I think just telling him thanks is not enough. And I think Dr. Raghav, you have to use him for the next year also in a selfish motive, because he has got a lot of inputs, and I think he'll do a lot of good work to the association. Dr. Nalli, it was our fortune to have you as our secretary for the past 3 years, Dr. Nalli. And I wish you best. All the best.
Rightly said, sir. Rightly said, sir.
Not going
Nalli,
anywhere.
sir,
The only person.
you deserve the applause.
Surely, I will. I can't leave YSS. I'll be with you all.
No, no,
Thank
no,
you.
no.
Thank you, Dr. Nalli.
Thank you. Thank you.
He's not going anywhere, and the only person who can control me in this world, other than my family members, is Nalli Uraj.
Can we have an EC meeting, first EC meeting, virtual next month sometime?
Yes, yes, yes.
Yes.
Please go ahead and do it.
I mean, we'll be talking to each other alternate day, like it or not.
Yeah, it's already 9 minutes more. The next session has to start, and the members will start coming in, postgraduates. Okay, thank you. I thank all the members who have attended the general body meeting. Thanks a lot. Thank you so much.
Thank you.
Thank you very much.
All the best to you, Kuti.
Thank you.
Thank you.